अभी वो देंगे आपको पेपर से। These are the headings.
Dr. Loveleen, please come on stage for your presentation.
Good morning, every.
Number 2. It is number 2. Dr. Loveleen.
Sorry.
You are? What is your
Dr.
good?
Loveleen.
Yeah. All right. Number 2.
Good morning. Good morning, everyone. Myself, Dr. Loveleen. Today, topic of my case presentation is endoscopic endonasal excision of Kaddish stage B esthesioneuroblastoma, a rare case report. Abstract. Olfactory neuroblastoma, esthesioneuroblastoma arises from the basal cells within the olfactory neuroepithelium. It has been reported that an extended endoscopic endonasal approach effective in treatment of malignant sinonasal tumor such as olfactory neuroblastoma, chondrosarcoma, chordoma, early stage squamous cell carcinoma, and adenocarcinoma. Case report. A 50 years old man presented to ENT OPD with chief complaint of right-sided nasal blockage, nasal stuffiness, and loss of smell. Nasal endoscopy was done after proper nasal decongestion. It was seen that right nasal cavity was filled with polyp-like mass. Endoscopic endonasal excision of mass was done. Histopathological report confirmed the diagnosis of olfactory neuroblastoma. Patient was followed up and investigated by any residual disease. No recurrence and residual disease was found on 6 months follow-up. Conclusion, in this case, we excised Kaddish stage B tumor with endoscopic approach. In this case, there was no intracranial invasion and distant metastasis. Hence, here, endoscopic excision of primary tumor combined with post-operative chemotherapy and radiotherapy help us to achieve cure for disease. Introduction. Olfactory neuroblastoma is a rare malignant tumor of olfactory epithelium. Because of its rarity, definite treatment guidelines have been limited in scope and depth, but there are still effective treatment for olfactory neuroblastoma. En-bloc resection combined with radiotherapy has been described as a standard of care. Recent study has been shown positive outcome for tumor treated with endoscopic surgery and adjuvant stereotactic radiosurgery as a minimal invasive treatment modality. Olfactory neuroblastoma arises from basal cells within the olfactory neuroepithelium. It represents less than 5% of sinonasal malignancies. Recently, much progress has been made in the field of otorhinolaryngology with regard to use of endoscopic endonasal surgery. In recent years, this type of surgery has been successfully performed on patients with skull-based tumor. It has been reported that an extended endoscopic endonasal approach is effective in treatment of malignant sinonasal tumor such as olfactory neuroblastoma, chondrosarcoma, chordoma, early stage squamous cell carcinoma, and adenocarcinoma. Case presentation. A 50-year-old man presented to ENT OPD with chief complaint of right side nasal blockage, nasal stuffiness, and loss of smell. He has no history of nasal bleeding, any false smelling nasal discharge, and associated medical condition. Anterior rhinoscopy done, it revealed a pale polyp-like mass occupying the right nasal cavity. There was no blood clot and bleed on probing. Left side DNS was present. General physical examination revealed both systolic and diastolic blood pressure on higher side. Investigation. Endoscopy, nasal endoscopy was done after proper nasal decongestion. Was seen right nasal cavity filled with polyp-like mass. Uh, this is the photo picture of the right nasal endoscopy, which showing tumor between septum and middle turbinate. Then non-enhanced coronal computed tomography of image of nose and PNS show mass in right nasal cavity rising from cribriform plate and extending into sphenoid sinus. There was bony distribution at cribriform plate, but there was no intracranial extension. It was seen that there was multiple polypus of right paranasal sinus with left DNS. MRI brain shows no intracranial extension. This is a figure of the NCCT taken of nose and PNS, which showing mass in the right nasal cavity arising from the cribriform plate. Ultrasonograph abdomen was done and that was found to be normal. Further nasal endoscopic biopsy was done and a histopathological report show features of malignant small round cell and tumor, possibly olfactory neuroblastoma. This is a histopathological slide which is showing the small round blue cells. Treatment. Endoscopic endonasal excision of mass was planned and under general anesthesia, nasal endoscopy was done and mass visualized, which was extending sphenoid cells with the help of lung forceps and microdebrider. Mass was excised from the attachment sphenoid sinus and cribriform plate and sent for histopathological examination. Hemostasis received histopathological report found to be the diagnosis of olfactory neuroblastoma. Immunohistochemistry was done and following markers were found positive: CD99, CD56, NSE, EMA, synaptophysin, and Ki67. 60-70% showed that tumor was olfactory neuroblastoma. Patient was given post-operative chemotherapy with cisplatin and etoposide for distant metastasis and any residual disease. Also, post-operative radiotherapy was given. Patient was followed and investigated for any residual disease. No recurrence and residual disease was found on 6-month follow-up. This is a photo taken after, this is an MRI done after 6 months, that post-operative MRI which shows no mass in right nasal cavity. And after nasal endoscopy of the right side after 6-month follow-up, there no recurrence of the disease. Discussion. Olfactory neuroblastoma thought to arise from the specialized sensory neuroepithelium olfactory cells that are normally found in upper part of nasal cavity, including the superior nasal concha, the upper part of septum, the roof of nose, and the cribriform plate of ethmoid. It has bimodal distribution with peak at 20 to 50 years of age. Unlike sinonasal malignancy, it is more common in women than men. Olfactory neuroblastoma is neuroendocrine tumor capable of causing paraneoplastic syndrome by secreting peptide. Patient with olfactory neuroblastoma causing Cushing syndrome, inappropriate antidiuretic hormone secretion, or hypertension produced by vasoactive peptides, which has been reported in literature. It is one of the group of small round blue cell tumors and need to be differentiated from the sinusal undifferentiated carcinoma, neuroendocrine tumor, small cell carcinoma, rhabdomyosarcoma, and lymphoma. Olfactory neuroblastoma typically express neuroendocrine marker, neuron-specific annulase, synaptophysin, and chromogranin, and it negative for keratin. As center may show positivity around the periphery of tumor only, help to differentiate olfactory neuroblastoma for sinusal melanoma, and its negativity for vimentin, actin, and desmin, which exclude rhabdomyosarcoma. Survival for more than 20 years is not unusual, while others are less fortunate, succumbing to high aggressive disease with widespread anterior cranial fossa. In 50% of patients, metastasis to cervical nodes are evident at the time of presentation, and distal metastasis already present in around 7% of patients. Conclusion. In this case, we excised cardiac stage B tumor with endoscopic approach. In this case, there was no intracranial invasion and distant metastasis, and endoscopic excision of primary tumor with post-operative chemotherapy and radiotherapy help us to achieve cure for the disease. These references. Thank you so much.
So, what is the post-operative follow-up of this patient?
Sir, we have followed this patient for around 6 months. He is doing apparently fine. He has undergone all the chemotherapy and radiotherapy treatment also.
What are the different stages of cardiac
So Kadi stage A, B, C divided into three. A is it in the nasal cavity. B is nose, perineal sinuses, and third is intracranial extension.
Have you got the sagittal view of the CT? Sagittal view is there or not?
So it's
Sagittal.
not with me right now. It's in the department. Okay. Sorry, didn't put in my hand.
All right. Thank you.
Thank you so much.
Is there any time limit for the
8
Yes, sir,
minutes.
10 minutes, sir.
10 minutes?
Yes.
10 minutes. Where is the watch? Can
Sir,
somebody?
it's with me.
Yeah, all right.
Dr. Divyagar, please come on stage. Good morning, everyone. My topic is clinical pathological study of neck masses in anterior triangle of neck. Abstract background. Tumors of the neck are interesting to surgeons, especially because of the complex neck anatomy and difficult differential diagnosis. Different types of neck masses are thyroid swellings, submandibular swellings, thyroglossal cysts, brachial cysts, lymphangioma, and also the miscellaneous and rare lumps in the neck. Fine needle aspiration cytology is a simple, quick, and cost-effective method to sample superficial masses found in the neck. Aim of the study is to study different types of neck masses in anterior triangle of neck, their nature, clinical features, and management according to age and sex. Method. This is a prospective study conducting at our institute from January 2021 to June 2022 for a duration of 18 months. All patients will be evaluated starting with clinical history and examination followed by fine needle aspiration cytology. The results for a total of 50 patients were studied during this period. Out of the 50 patients, 33 of them were midline swellings, comprising 66%, and 17 among them were lateral neck swellings. People over a wide range of age group between 10 to 50 years were affected. Midline neck swellings were common among them than lateral neck swellings. Conclusion. Among the midline neck swellings, thyroid swelling was found to be the commonest, followed by thyroglossal cysts. Thyroid swellings occur more commonly in the females than males. Ultrasound and FNAC is the most common, effective, and safe investigation that aids in the diagnosis. Treatment of choice for benign, non-inflammatory, and non-malignant neck swellings is mostly surgical excision rather than medical management. Introduction. Neck masses are a relatively common head and neck problems. There are usually no associated symptoms beside the recognition of lump noticed incidentally on palpation and cosmetic appearance with increase in size or swelling over a duration or noticed by another individual. Two most common methods of classifying neck masses are according to site of lesion and according to its etiology. Neck masses may be benign or malignant. The most common benign neck masses are thyroid swellings and those of the salivary gland. Less common pathologies presenting as neck swellings are from the thyroglossal cyst, brachial cleft cyst, and lymphatic malformation. Lumps may sometimes also be classified in relation to triangles of neck. Tumors of neck are interesting to surgeons, especially because of complex neck anatomy and difficult differential diagnosis. They arise from definite anatomical structures and are very common in the outpatient department. Every time a surgeon seeks a neck mass, he has several questions in his mind like whether it is congenital or acquired, inflammatory or non-inflammatory, tissue of origin, benign or malignant, primary or secondary lesion, if secondary then source of primary, or could it be occult primary, and what are the required diagnostic tools and treatment, etc. The differential diagnosis in a patient presenting with neck mass is often extensive and will vary with age. These neck masses are evaluated by a detailed history, clinical examination, and investigations like fine needle aspiration cytology, ultrasonography of neck, CT neck, and excision biopsy. Clinical examination of neck has false positive results between 20 to 30% and false negative results ranging from 30 to 40%. The aim of the study to study different types of neck masses in anterior triangle of neck, their nature, clinical features, and management according to age and sex. Methods. This is a prospective study conducted at our institute. The selection of patients for inclusion criteria contains all patients attending ENT OPD with neck swelling of both sexes and all age group. The exclusion criteria was patient who underwent FNAC but did not undergo subsequent histopathological diagnosis, suspected neck masses of vascular origin on clinical examination, and neck abscess or neck swellings on aspiration pus comes out. All patients attending the ENT OPD with neck swellings, including thyroid and salivary gland swellings, were included in this study. All patients were evaluated starting with clinical history examination. Provisional diagnosis was established, and further investigation in the form of ultrasonography, USG guided fine needle aspiration cytology, complete blood count, blood grouping, etc., were carried out on each patient. In some patients, special investigations like CT scan neck and MRI neck were also done. After coming to a final diagnosis, surgical excision was the modality of treatment preferred in most cases, with all masses sent for histopathological examination. The data was analyzed using the statistical package for social sciences. Result: a total of 50 patients were included in the study. Out of them, 66% were midline and 34% were lateral neck swellings. People in the range of 5 to 60 years were affected. Midline neck swelling lesions were most common than lateral neck swellings. Among the various neck masses, thyroid swelling is the most common midline benign neck swelling. It is more common in females than, as compared to males, and occurring more frequently during the third to fifth decade. Among the congenital anomalies, the most common neck swelling is thyroglossal cyst, and it is seen in the first decade of life. In the table 1, you can see the relative prevalence of midline and lateral neck swellings. The midline neck swellings, the number of cases were 13, causing 66%, and lateral were 17, causing 34%. In table 2, you can see a different midline neck swellings. It can be thyroid, thyroglossal cyst, ranula, epidermal cyst. The thyroid, there were cases of 30, thyroglossal cyst comprises 5, ranula 3, and epidermoid cyst with a total of 40 midline neck swellings. In the table 3, you can see lateral neck swellings comprising of salivary gland tumor, epidermal cyst, brachial cyst, salivary gland tumor comprising of 7 cases, epidermal 1, and brachial cyst coming out to be 10 in total. The different anatomical neck swellings comprising midline neck swellings like upper midline causing submental region is ranula, epidermal cyst. In mid-midline, there can be thyroid swelling or thyroglossal cyst. Lateral neck swelling comprising submandibular triangular submandibular ciliadenitis, lymphangioma, epidermal cyst, carotid triangle. It's a pie chart showing different neck swellings. The thyroid comprising the major 60%, then the salivary gland tumors comprising 20%, thyroglossal 17%, and other tumors consisting of 13%. This sex distribution in patients with clinical findings. The female ratio of thyroid swellings is more than males. Thyroglossal is almost equal, but comprising male to be more. Even salivary gland tumors are more in males, and other tumors are also in common in males. Treatment modalities: most of the benign neck swellings, after appropriate investigations like ultrasonography, USG guided FNAC, CT, MRI neck, and managed by surgical excision of these neck masses rather than management. For thyroid gland swellings, according to involvement of lobe, we do hemithyroidectomy or total thyroidectomy, or for salivary gland swelling, excision of the gland is a treatment of choice. For brachial cyst, surgical excision of brachial cyst, and for thyroglossal cyst trunk operation is the preferred surgical modality. This is the image showing patient having right lateral neck mass confirmed after histopathological report as brachial cyst, and on the right side you can see a patient having midline neck swelling, most probably a thyroid swelling. Discussion: neck masses are very frequently encountered in the outpatient department at a hospital and offer a diagnostic challenge for the surgeon. Thyroid mass, especially colloid goiter, is the most frequently encountered neck mass. Patient history and a physical examination are fundamental to making an early and correct diagnosis. Ultrasonography is very useful in detecting the site, extent, consistency, and relationship of neck swellings to adjacent structures. Ultrasonography is very helpful in differentiating between solid and cystic neck swellings. It is also differentiates between benign and malignant lesions of salivary glands and lymph nodes. USG guided fine needle aspiration cytology is simple, quick, and cost-effective method to diagnose superficial masses in the neck. The technique is preferred mostly in the outpatient department. The disadvantage being minimal trauma to the patient. It is always beneficial to differentiate a benign from malignant pathology, as it greatly influences the planned treatment. It can be both diagnostic and therapeutic in cystic swellings, but there are some limitations of FNAC in the neck region that can be encountered. They are as follows: difficulty in the diagnosis and subclassification of lymphoma, distinguish colloid goiter from follicular adenoma, differentiation of colloid goiter from macrofollicular papillary carcinoma, and distinguish between thyroid adenoma from early follicular carcinoma. The most common congenital lesions found in the pediatric population are thyroglossal cyst and brachial cyst, cleft cyst. Irani et al. Showed 24.2% of children had brachial cyst and 9% had thyroglossal duct cysts, as brachial cleft cysts are typically located in the submandibular region, and thyroglossal cysts are usually located in the midline in infrahyoid region. Risi et al. Study showed most common congenital mass was thyroglossal cyst 24.2%, then brachial cleft cyst 8.1%, then lymphangiomas 6.5%, and dermoid 1.6%, and inflammatory 33.9%. In our study, most common congenital neck masses are thyroglossal cysts 14%, and then dermoid cysts comprising of 7%, then lymphangiomas, and then brachial cleft cysts. Goel et al. Diagnosed the different types of cysts out of total head and neck swelling because these cysts are commonly present in head and neck region. In their study, 100 patients of different cystic neck swellings were studied over a period of 5 years from 2008 to 13 to compare the finding with clinical diagnosis, FNAC, and histopathological report for diagnostic reliability. The study found that simple clinical examination followed by FNAC and histopathologically is simple, quick, inexpensive, and minimal invasion technique to diagnose different types of head and neck swellings. In the study, out of different head and neck cystic swelling, thyroglossal cyst was most common, followed by dermoid cyst. In our study, out of the thyroid masses, colloid goiter 82.8% was most common, followed by follicular adenoma 14.2%, followed by thyroiditis 2.8%. This is consistent with the study of Marvin et al. Out of salivary gland masses, pleomorphic adenoma 60% of parotid was the most common, followed by submandibular gland ciliaridonitis comprising of 40%. This is consistent with the study by John et al. Most common benign lesions are found in thyroid. This is consistent with the study of Dean et al. Among the thyroid masses, colloid goiter, thyroiditis, and follicular adenoma were more common in females and young adults. In most of the other cases, which consist of cystic
Time's up
hygroma,
now.
ganglioneuroma, vascular malformation, sclerosing hemangioma, brachial cyst. CT gives a useful idea and anatomical relationship of the masses and helps to plan surgical treatment. Deborah L. Considered computer tomography as an excellent means of evaluating patients with neck masses. There are very few indications for CT scans for benign neck masses. They are if tumor is nearer to the carotid artery, large thyroid nodule causing compression of trachea. MRI is also done in some special benign neck swelling such as lymphangioma, epidermal cyst, and brachial cyst. Conclusion: from our present study, it can be concluded that thyroid predominantly midline benign neck swelling were found to be the commonest, followed by thyroglossal cyst. Thyroid swellings are most common in the females and young adult. USG-guided FNAC was the most common, effective, and safe investigation. Treatment of choice for benign, non-inflammatory, non-malignant neck masses is mostly surgical excision. References. Thank you.
Of course, FNAC nowadays is a very good tool.
Yes,
But what are the main contraindications of doing a FNAC?
Sorry, sir.
The conditions where the FNAC should not be done. There should be in your mind. Should be in your mind.
So when if it is a vascular origin, if we think on clinical examination, if it is a vascular origin swelling, so there we contradict FNAC as it can.
Can you give some examples? What are those vascular swellings?
Hemangiomas.
Anything other than this? Carotid body tumor. Okay.
Thank you, sir.
Dr. Manupreet, please come on stage.
Refuge.
Good morning, everyone. Myself, Dr. Manupreet. My topic of presentation today is sphenocoanal polyp mimicking as enterocoanal polyp, a case report. Introduction. Nasal polyps are polypoidal masses arising mainly from the mucous membrane of nose and paranasal sinuses. Coanal polyps are benign tumors which arise from inflamed and edematous mucosa of paranasal sinus and pass through the drainage ostium of the sinus and then projecting themselves to the coana. Polyps have three parts: intersinusoidal, ostial, and extrasinusoidal. These polyps arise mainly from the maxillary sinus, also known as the enteroquinal polyp. Ethmoidal sinus, they can also arise from the ethmoidal sinus, also known as ethmoidoquinal polyp, and sphenoid sinus, also known as the sphenoquinal polyp, which are rare. Enteroquinal polyps are the most frequent of them and account for 4 to 6% of all nasal polyps. Sphenoquinal polyps are very uncommon. However, they have similar clinical presentation as enteroquinal polyps. They can be differentiated by diagnostic nasal endoscopic examination and CT and MRI PNS. Here we report a case of sphenoquinal polyp in 15-year-old girl which was successfully removed through endoscopic approach under general anesthesia. Case presentation. A 15-year-old girl child presented in ENT OPD with chief complaint of the right nasal obstruction since 6 months and nasal discharge since 6 months. On anterior rhinoscopy, in right nasal cavity, inferior turbinate hypertrophy was present and polypoidal mass was seen in the anterior nasal cavity. On oral examination, polypoidal mass was seen hanging from the nasopharynx into oropharynx. CT-PNS was done, which showed the homogeneous opacification of the maxillary sinus and the whole of the nasal cavity. In the sagittal section also, the similar findings were there, and in the axial section, the mass can be seen hanging from the nasopharynx. Patient was then planned for functional endoscopic sinus surgery. During surgery, polypoidal mass was seen in the right nasal cavity, filling the entire cavity. It was not possible to remove the mass in total, so the polyp was cut near the pedicle and the bulky mass was taken out to the oral cavity. The pedicle was then traced for the region into sphenoid sinus through sphenoethmoidal recess, and stalk was seen originating from the posterior wall of the sphenoid sinus. Polyp was totally excised along its pedicle. Middle meatus was visualized, which was free of any polypoidal mass. Maxillary enterostomy was done and discharge was cleared from the maxillary sinus. Therefore, at the time of the surgery, polyp was diagnosed as sphenoquinal polyp. As it can be seen during the surgery, the sphenoid ostium has widened due to the polyp. Histopathological examination showed inflammatory polyp with no signs of any malignancy. Discussion. Sphenoquinal polyps originate from the sphenoid sinus, are usually solitary in nature and are uncommon. As clinical presentation of enteroquinal and sphenoquinal polyp is same, therefore nasal endoscopy and CT plays an important role in diagnosis. But in our case, nasal endoscopy could not confirm the origin because polyp completely obscured the nasal cavity, and CT-PNS showed opacification of the maxillary as well as ethmoidal and sphenoidal sinus. Therefore, a region couldn't be confirmed and was misdiagnosed as enteroquinal polyp, and during the surgery only we came to know that the origin of the polyp was from the sphenoid sinus. These are the references. Thank you.
So what is the second investigation you could offer in this case? Investigation after the CT.
After CT, sir?
Yeah.
Any role of MRI?
Yes, sir. We can, for naso and for confirming the nasal angiofibromas, but there would be history of the epistaxis there if there might be something else. Or...
It was a female patient.
Hanji, sir.
The MRI is also very diagnostic. All right.
Dr. Diksha Rani, please come on stage for the presentation.
Good morning, everyone. Today I am myself, Dr. Diksha. I am presenting a case on pleomorphic adenoma in parapharyngeal space. Introduction. The tumors in the parapharyngeal space are rare and constitute less than 0.5% of the head and neck neoplasm. Approximately 80% of these neoplasms are benign. Of these, pleomorphic adenoma is the commonest benign tumor.
Pleomorphic adenoma in the parapharyngeal space can either arise de novo or may arise in the deep lobe of the parotid gland and extend through a stylomandibular tunnel into the parapharyngeal space. Aponeurosis of Zuckerandle and testis divides the parapharyngeal space into the pre-styloid and the post-styloid plus spaces. Pre-styloid tumors are commonly from the salivary region, while the post-styloid space is most commonly affected by the neurogenic tumors. Case report. A 30-year-old male presented to the ENT OPD with complaints of difficulty in swelling of foot and, and swelling present on the right side of neck for the 1 year. There was no complaint of difficulty in breathing, fever, soreness of the throat, as it's shown in the picture. There's a swelling on the right side of the neck. On intraoral examination, there was a bulging of the right soft palate and the right lateral pharyngeal wall, crossing the midline and pushing the uvula to the left side, along with a smooth overlying mucosa. On digital palpation, swelling was firm, non-tender, and bimanually palpable. And there was no significant enlargement of the lymph nodes in the neck. Clinical examination didn't reveal involvement of any of the cranial nerves. Investigations. FNAC was showed benign-looking epithelial cells along with the fragments of Maya epithelial cells with background of chondromyxoid stroma, which are suggestive of benign salivary gland neoplasm. MRI showed a large well-defined T2 heterogeneous lesion measuring 5.6 into 3.4 into 4.4 centimeter in size in right pre-styloid parapharyngeal space, causing the compression and the displacement of the oropharyngeal lumen. It showed homogeneous enhancement on the post-contrast images and lesions, displacing the right carotid vessels and internal jugal vein posterolateral. Impression was mass in the parapharyngeal space involving the deep lobe of the parotid, suggestive of the pleomorphic adenoma. Then the surgery. Transcervical approach was used to gain access to the right parapharyngeal space without any mandibular osteotomy. The tumor was completely excised with blunt dissection. As in the first picture, right parapharyngeal mass excites the transcervical approach, and after excision, there's a empty space. On the gross examination, the tumor was 5.5 into 4.5 centimeter with whitish, lobulated, and glistening surface. Histopathological examination showed a neoplasm having the admixture of epithelial and the stromal components that was of the pleomorphic adenoma. And the follow-up was done for 1 year, and the period was uneventful. Discussion. In addition to a painless submucosal swelling, parapharyngeal space tumors may show additional symptoms like atalgia, neuralgia, palsies of the 9th, 10th, 11th, or 12th cranial nerves, or trismus. The diagnostic workup algorithm begins with hematological and the serological test, followed by FNAC, CT, and/or MRI studies should be the part of the preoperative diagnosis to determine the extent of disease, local spread, and even the type of tumor. Extension of tumors from the deep lobe of parotid gland is distinguishable from tumor arising de novo in the parapharyngeal space by a fine lucent line representing the compressed layer of fibroadipose tissue between the tumor and the deep lobe of parotid. The treatment of the pleomorphic adenoma is essentially surgical. The surgical resection techniques described in the literature are classified as transoral, transcervical, transparotid, transcervical, and transcervical transmandibular or infratemporal, and the correct choice between them depends upon the accurate information on the mass size and the location and its relationship with the surrounding vessels and the nerves. The approach of choice to the parapharyngeal space to allow adequate removal of the tumor should meet two criteria: wide intraoperative visibility for the safe radical dissection and the minimal functional or cosmetic after effects. However, the recurrence rate is higher in parapharyngeal space tumors as wide dissection is often not possible due to close proximity of the vital structures. Conclusion. Pleomorphic adenoma arising in the parapharyngeal space is of rare occurrence. High index of suspicion and the adequate clearance of the tumor with cuff of surrounding normal tissue is the key to the successful treatment. Thank you.
All right.
Okay, thank you.
Dr. Simran Taroja.
Good morning, everyone. I'm Dr. Simran Dhanawa, presenting my experience with laryngeal trauma. The incidence of laryngeal trauma occurring in the emergency is overall low, ranging between 1 in 5,000 to 1 in 1,37,000 emergency room admissions. Through this study, we wish to audit our approach to this relatively infrequent injury and share our experience. The laryngeal trauma may result from either blunt trauma, penetrating injuries, inhalational injuries, or iatrogenic injuries resulting from post-intubation. The blunt trauma and penetrating trauma can further be either a result of suicidal injuries, RSA injuries, and the patient usually presents with dyspnea, dysphonia, dysphagia, neck pain, hemoptysis, shock, and externally visible injuries if there is a penetrating injury with bleeding, or if there's a blunt injury, it could be an expanding hematoma. And on examination, the patients may have stridor, increased respiratory rate, that would be a sign of respiratory distress, tachycardia, use of accessory muscles, and the local findings can range from ecchymosis abrasions to lacerations to surgical emphysema in cases of blunt trauma patients. In our department, we studied these patients for 2 years, and all the patients who presented to the emergency department with such injuries were followed. In the total, 15 patients became a part of the sample size. And for these patients, the cause of the injury, symptoms, severity of the injury, site of the injury, the airway management, that is tracheostomy versus intubation, and the treatment and outcome were noted. The Schaefer classification was used to grade the severity of laryngeal injury. The Schaefer classification, as mentioned, ranges from either minor endolaryngeal hematomas or lacerations without detectable fractures, ranging to complete laryngeotracheal separation, with grades going from 1 till 5. With different grades of hematoma, different grades of exposure of the cartilages, and different grades of laryngeal fractures. In our study, we noted most patients that were involved were of the male sex, ranging from 21 to 40 years of age, owing to their higher incidence in involvement in the roadside accidents. And of all the cases that we saw, 5 resulted from the suicidal injuries, 3 resulted from roadside accidents, 3 from strangulation, be it accidental or intentional, 2 from assault cases, 1 due to ingestion of a toxic substance, and 1 from dog bite. And of all the cases, penetrating injuries in total were found to be there in 7 patients and 8 in the blunt patients, ranging from suicidal roadside, suicidal injuries being penetrating more so, and accidental strangulations being blunt more so. Of all the patients, 7 patients presented with stridor, 8 with hoarseness of voice, 10 with adynophagia, and 5 with hemoptysis, mostly seen with patients having penetrating injuries. And as mentioned, the grades of injury according to Schaefer classification, 5 patients had grade 1 injury, that is minor endolaryngeal hematomas. 5 patients had grade 2 injuries with minimal framework fractures. 3 patients had grade 3 injuries with mucosal separation and laryngeal fractures. And 2 patients had grade 5 injuries with laryngeotracheal separation. This patient had soft tissue injury to the anterior part of the neck. The airway was found to be intact. The patient was managed with primary suturing, and minimal endolaryngeal hematoma was found. Is a case of an RSA. This patient was a case of a suicidal injury to neck, self-inflicted wound. Airway was found to be intact on outer examination, but on endolaryngeal examination, minor hematoma was found to be in the area of anterior commissure. This patient presented after 3 days of an RSA with subcutaneous emphysema from covering a whole of the neck and the anterior part of the chest, and the hematoma, the emphysema was expanding over time. Therefore, the patient was taken for a tracheostomy after a CT scan was done, and the site of injury was determined, and patient was managed with primary suturing. One such X-ray of a patient presenting with subcutaneous emphysema has been shown. Of all the patients that presented to the emergency, medical management, that is conservative management, was undertaken in 4 patients, mostly in patients with blunt trauma, which included voice rest, anti-reflux, humidified oxygen, saline nebulization. In some patients, steroid was given, and antibiotic cover. For surgical management, primary suturing alone of the soft tissue and the skin wound was done in 3 patients. Tracheostomy alone for airway management was required in 4 patients. Tracheostomy and primary suturing was undertaken in 1 patient, and laryngeal repair was undertaken in 3 patients, with mostly primary suturing of the avulsed ends. The soft tissue injury alone primary suturing, again a soft tissue injury primary suturing. This patient was given a tracheostomy tube to secure the airway due to the endolaryngeal edema and hematoma giving rise to stridor, and primary suturing of the airway. This patient presented with transection of the thyroid membrane, and this patient was managed with primary suturing with the tracheostomy tube in situ to secure the airway to prevent aspiration of the blood. An intra-op photo of a tracheotracheal resection followed. In the follow-up, these patients were followed up for 6 months. Out of all the sample size of 15 patients, immediately 2 mortalities were seen owing to the blunt trauma injuries of the systemic parts, and 1 patient that was managed with laryngeal repair had failure of anastomosis and gaping of wound was seen on post-op day 5 and 7. At 3 months, 2 patients presented again in the emergency with stridor owing to, on examination, subglottic stenosis. 5 patients that were tracheostomized, successful decannulation was seen and good airway and voice outcome was seen. And 4 patients who were managed conservatively had good voice and air outcome at 3 months and also at 6 months. A patient with blunt trauma due to accidental strangulation with a dupatta that again presented to the emergency with stridor at 2 months, and on flexible endoscopic laryngoscopy, we found subglottic stenosis to be present. Of all the cases that we covered, young males were seen to be the most common cause and most commonly involved, ranging from 21 to 40 years. And as a study done by Schaefer, the same findings can be corroborated. Again, Bhojani reported a higher mortality in patients with blunt trauma, and in our study also, blunt trauma was mostly owing to the systemic injuries, whereas Shagnan and Mulder reported penetrating wound injuries more likely to result in death. Gussack et al. Recommended that endotracheal intubation, when performed under direct visualization, is a good airway securing technique for minor laryngoscopic disruption and supraglottic hematomas. Whereas Schaefer recommended that tracheostomy under local anesthesia for a patient with potential sign and symptom of potential airway obstruction is the preferred airway management choice. In our patients, where transection of the trachea was there, primary intubation was done to secure the airway and to manage the aspiration of blood, and further followed by tracheostomy. And in 7 of our patients, tracheostomy was done to those patients who presented with stridor. Bent et al. Reported a normal airway and phonatory function in patients with minimal laryngeal injury who were treated without surgery, and similar good outcome was reported in 4 of our patients managed conservatively. Fogelman and Stilwart concluded that penetrating neck traumas that violate the platysma should require surgical exploration. And we also explored all the patients who presented with penetrating blunt trauma to rule out any other bleeding sites and any other soft tissue injuries. Overall, a laryngotracheal injury is managed if there is a suspicion of airway obstruction by either firstly securing the airway by either a tracheostomy or by intubation, and then by doing a pan endoscopy by flexible route to ensure any injuries to larynx, other structures, and esophagus. Minor mucosal and cartilaginous injuries can be managed by conservative methods, and significant mucosal injuries or cartilaginous injuries further require suturing, stenting, reductions, laryngotracheal dissections. And if a patient has an airway stable, after following up with the radiological investigations and with fiber optic nasal endoscopy, if mild abnormalities to be found, the patient can be managed conservatively. And if there is a normal endolarynx, again, conservative management in the need of observation in ICU, humidification, voice rest, nasogastric feeding, anti-reflux has been shown to be helpful. So advancement in assessment of patients with the trauma in the laryngotracheal region have led to enhanced patient outcome and health-related quality in life owing to the advancement of fiber optic endoscopy and radiological investigations. Thank you.
So what is the characteristic of suicidal wound in the neck, cut wound?
A suicidal wound owing to the shape of the knife will have one deep end and one tapering end, sir. And deep end at one point and tapering it at the other point, sir.
And they are mostly in the upper part of the neck.
Yes, sir.
And what is important in the accidental injuries in the neck? If it is due to accident, but one thing is very important. Examination of the cervical spine.
So C-spine, yes, sir. Stabilization of C-spine was done in all the patients that presented to the emergency, sir.
Yeah.
Yes. Thank you.
All right.
Dr. Diksha Sharma.
Good morning, respected judges and all the faculty members and batchmates. Myself, Dr. Diksha Sharma, and I'll be presenting this paper on administration of drug posaconazole in COVID-associated mucormycosis patients in a tertiary care center, the challenges and difficulties. The aims and objectives were to assess the difficulty and challenges in administration of the drug posaconazole in a tertiary care center in patients of invasive fungal sinusitis during COVID-19 pandemic. The objectives were to compare the different forms of drug posaconazole, to assess the efficacy and side effects of drug posaconazole, to compare the various routes of administering drug posaconazole intravenously with their advantages and disadvantages. Introduction. Posaconazole is a novel lipophilic azole antifungal agent designated chemically with an empirical formula of C37H42F2N8004 with a molecular weight of 700.8 moles. It exhibits potent and broad spectrum antifungal activity. It is active against majority of yeast and filamentous fungi, especially in immunocompromised patients, and acts as a salvage therapy in patients with invasive fungal sinusitis. Two routes for administration are there, oral route of administration and IV route of administration. It is indicated in patients of 18 years and above. The dosage form is oral suspension is 40 mg per ml. Dose is 400 mg twice a day. Tablets are available in 100 mg preparations and 300 mg also in gastro-resistant forms. The dosage should be loading dose of 300 mg, which can be given as 300 mg tablets or 300 mg one tablet twice a day on the first day, and then 300 mg once a day thereafter. Injections are available in 300 mg preparations. Dosage should be loading dose of 300 mg IV twice a day on the first day as a loading dose, and with a maintenance dose of 300 mg once a day from the second day onwards. The IV administration of drug posaconazole it can be administered via central venous line by slow IV infusion over approximately 90 minutes. If a central venous catheter is not available, posaconazole injection may be administered through a peripheral venous route also by infusion over 30 minutes only as a single dose in advance of a central venous line placement, or to bridge the period during which a central venous line is placed, or in for other IV treatments. When multiple dosing is required, then infusion should be done via central venous line. It is preferred. Never administer posaconazole injection as an IV bolus injection. It can be very toxic. The methods used were, this prospective observational study was done on patients of COVID-associated mucormycosis in NSCB Medical College and Hospital between May 2021 to October 2021. The inclusion criteria were patients receiving the drug posaconazole, patients given consent for the study, and patients given consent for central venous line. The exclusion criteria were patients who refused for antifungal medication and patients with deranged renal and hepatic profiles. The data collection, detailed history regarding the COVID infection symptoms, hospitalization, and medical history, antifungal drug received or not, symptoms developed following medication, physical examination, and all necessary investigations were collected. During posaconazole, drug posaconazole given to the patient, dose was calculated as per weight of the patient and extent of the disease, as per the staging of the disease, like it's confined to sinuses or orbita or intracranial extension also. Pre and post-op state and renal and hepatic parameters were measured. Intolerance to amphotericin B was a very big criteria here, and in the non-availability of the amphotericin B. As we all know, during the pandemic, there was a huge crisis of amphotericin was not available for the patients, and the disease was extensive. It was within a matter of 2-3 days, it spreads intracranially, so it served as a very salvageable drug there. The data collected and entered in Microsoft Excel sheets and was analyzed. So the results were, out of 110 patients who received posaconazole injection via peripheral venous line, almost 72 patients developed adverse drug reaction, in which 25 people were in the age group of 51 to 60 years of age, then 13 in 60 to 70 years, and 12 patients were 31 to 40, 12 were 41 to 50 years, and 3 patients were of 71 to 80 years of age group. These are the charts and diagrams representing the data. The adverse drug reactions were thrombophlebitis. It was the major adverse reaction which we saw. The thrombophlebitis in 54 patients, fever in 29, Chills was presented in 25 patients with headaches in 4 and vomiting and sweating in 3 and 1 patient respectively. Thrombophlebitis was very severe, which among the chills was the main reason for discontinuation of the injectable form of drug by causing intolerance to the patient after only 1 dose of injection. When the peak of the mucormycosis epidemic slowed down, all the remaining 12 patients were counseled for the central IV central line insertion. 7 of them gave consent for it, and after that, we started them on IV posaconazole via the central line. Through central line, patients were able to tolerate injection posaconazole much better than the peripheral route, and therefore, we were able to give them the drug for about 10 days till the amphotericin B was available in our setting. Following are the drug reaction and side effects encountered on the first week. On the first day, all 7 patients had 1 or 2 episodes of low-grade fever within the 24 hours. The 4 patients had chills and rigor episodes within 2 hours and were managed easily by injection, Avil and antihistaminics. 4 patients developed vomiting, 3 developed diarrhea within 48 hours. Only 1 patient developed erythematous lesions of the skin, thigh, and arms in the next 7 days. These are the diagrams showing the time of onset of adverse drug reaction, first in the peripheral line, and the second one shows the onset of adverse reactions via the central line. As we can see, the central line time taken in via central line is more as compared to peripheral line. Discussion. Posaconazole is a systemic triazole antifungal drug derived from itraconazole and exerts the same antifungal mechanism of action as other azole derivatives. The posaconazole oral suspension and delayed release tablets are approved for patients aged 13 and older or adults aged 18 years of age in Europe, while the IV formulation is licensed only for patients of more than 18 years of age. Posaconazole inhibits the enzyme lanosterol 14 demethylase, which catalyzes an essential step in ergosterol biosynthesis. Posaconazole tablets are absorbed with a maximum Tmax of about 4 to 5 hours, exhibit dose proportional pharmacokinetics after single and multiple dosings up to 300 mg. For better absorption, these are taken with high fatty meal and with acidic carbonated drinks rather than fasting. Following administration of 300 mg of posaconazole concentrate for solution for infusion over 90 minutes, mean peak plasma concentration at the end of infusion was 3,280 nanograms per ml. Posaconazole had distribution volume of 261 liters, indicating extravascular distribution. Posaconazole is highly protein bound, more than 98% is found bound to albumin. Posaconazole, after administration of tablet, had a mean apparent volume of distribution of 394 liters, that is 42%, which is quite acceptable. These are the whisker plots showing the posaconazole serum levels given via tablets and IV and comparison. And it indicates that studies suggested that posaconazole attains higher serum level during treatment when administered through IV route as compared to oral route. Hence, the IV route is preferred post-operatively. After oral administration, bioavailability of the drug ranges from 8% to 47%, and if taken with fatty meals or carbonated drinks, it increases as compared to fasting. In present study, posaconazole injection has been administered to 110 patients in which adverse drug reactions in In present study, posaconazole injection has been administered to 110 patients in which adverse drug reaction was developed in 72 patients. Majority of the patients were in the age group of 50 to 60 years of age. The thrombophlebitis developed in 54 patients was the main reason for discontinuation of the therapy. All the patients who received IV posaconazole through central venous line doesn't show thrombophlebitis, and it was better tolerated by the patients. Fever was the most common short-term side effect. Other side effects were headache, vomiting, rigor chills, diarrhea, and it was managed easily. On one patient, but one patient developed erythematous skin lesions, and dermatology opinion was taken for that, and it was managed. Post-discharge, the patient was advised oral posaconazole tablets at least for a month. Although the ICMR guidelines which we are following now is at least 3 months to 6 months, the patient is advised to take oral posaconazole tablets. And but initially we advise the patients for at least continuation of the therapy for 1 month, and none of them showed any signs of deranged hepatic or renal profile or any other side effects. Liposomal amphotericin B remains the gold standard. Second choice of drug is posaconazole. Injection posaconazole should always be administered via central line. It is a preferred case in case of renal dysfunction, electrolyte imbalance, or unavailability of amphotericin B. The conclusion of the study was that posaconazole is the newest triazole antifungal agent, randomized and double-blind trials have been shown that posaconazole to be at least as efficacious as fluconazole for the prevention of invasive fungal infections in immunocompromised patients. It has also shown promising results in the treatment of various fungal infections refractory to other antifungal therapy. All posaconazole doses should be given with food or a nutrition supplement to enhance absorption. The most common adverse effects reported with posaconazole therapy was thrombophlebitis, fever, diarrhea, nausea, vomiting, and a headache. Instances of elevated liver enzymes, hyperbilirubinemia, and hepatocellular damage were also noted in clinical trials, and these lab values should be monitored during treatment with posaconazole, although we did not have any such patient who was showing these symptoms. IV posaconazole was preferably given via central line, and peripheral line specifically in a ratio of healthcare provider to patient is good. It is difficult during the time of epidemic-like situations. Intravenous posaconazole is better than oral posaconazole in immediate post-operative period to prevent recurrence or extension of the disease. And oral posaconazole can be given in discharge waiting patients as maintenance without much side effects and well tolerability, given hepatic and renal functions are monitored regularly. It should be taken with full meal or acidic carbonated drinks. The limitations of the study was hepatic and renal tolerance of the drug. Posaconazole via peripheral line was not evaluated in the study since it has been withheld in the patients with severe drug reactions after the first dose. And study on IV posaconazole via central line was possible only to a limited number of patients. Thank you so much.
Thank you very much. So now we are with Dr. Satish Jain. Hello.
Hello.
Yes.
Yes, sir.
OT. OT?
Yes, OT connected, sir.
Yeah, just. Hello. Yes, Dr. Satish.
Good morning, boss.
Good morning. Good morning. We are waiting for you now.
Okay.
Sorry for delay. 5-minute delay.
Yeah.
Good presentation by all our PGs.
Super. So, today's session will start with yesterday was more of basics and today is little advanced as usual as we planned. So today we have the cases we have lined up. To begin with, the JNA is already induced. We are all set to start. Then we have a cochlear implantation with some subtotal petrojectomy. The case of CSON with bilateral profound deafness, and our plan is to do a subtotal petrojectomy and cochlear implantation at the same time. Then some parotid and some more cases. So, hello.
Yes, yes.
Yeah, are you getting any picture?
Yeah, we're getting the CT.
Okay. Are you getting the CT scan? Then this is the picture of this patient who is a 12-year-old child, 12-year-old male patient who presented with a nasal mass, nasopharyngeal mass, history of bleeding, complete nasal obstruction. On endoscopy, a reddish mass-like lesion, and then suspecting a JNA, biopsy is never advocated. And the CT scan has all characteristic features of JNA. Characteristic means JNA has propensity to spread to certain sites preferentially. That's how it is diagnosed on the basis of radiology. JNA is known for its extreme vascularity, which frightens the surgeons when it comes to surgical excision. So, with the advancement in the surgical technique, advancement in better understanding of radiology and equipments, now there is a sea change you must have observed in last, say, 1.5 decades to address more and more JNA endoscopically. The reason is so obvious as I mentioned.
Yes, yes.
And that has, certain advantages. It is not that endoscope is advantageous as it avoids a scar mark. If it gives a scar mark and gives better result, I'll go in for a scar mark rather than endoscopy. As simple as that. So the advantages here is in endoscopy, you're able to see under magnification, under close illumination, each and every part of the tumor wherever it is going. JNA, as I said, has a propensity to grow all around. It has a propensity to invade the bone, the cancellous bone. It has propensity to pass through the narrow canal and crevices to the surrounding regions. And if you leave even the smallest part of the JNA, it is going to come back. That's how it is notorious to recur, people call it. It is never a recurrence, it is a benign tumor. If you completely remove, it cannot come back. Even if you leave a small residue, it can grow to the biggest one and become more notorious. So, complete excision is the cure. And in order to do that, we need to remove from wherever it is extending to the smallest of the canal and crevices into the bone and everywhere. Problem with the open approaches is, like for example, this tumor has a propensity to invade the pterygoid cancellous bone. It has propensity to invade through various canals and fissures from the pterygopalatine fossa. I will show in this case. In open approach, owing to the extreme bleeding, the moment you remove the tumor, the gush of blood comes and you ultimately pack and come out, and you don't have opportunity to look into those areas where the tumor can be left behind and it can grow back. With endoscopy techniques, in spite of challenge of being a vascular tumor, understanding the vascularity is very, very important. I will show that how the vessels are supplying this tumor, how it is so vascular. Understanding that fact, you can extirpate majority of these tumors, whatsoever the size of the tumor is, you can extirpate endoscopically, understanding the vascularity of the tumor, taking the vascularity in control first, majority of the vascularity you can take in control first. You have many of the techniques now for hemostasis now, a lot of new gadgets for hemostasis, and you can extirpate all those endoscopically with the biggest advantage of removing the tumor from any smallest canal, crevices, fissure, anywhere it is extending to, under vision, to the bones, the cancellous bone, wherever it is extending to the pterygoid or part of the sphenoid or clival bone, wherever you can remove under vision, you can separate it from the critical structures like dura, brain or carotid artery or cavernous sinus from anywhere. So everything is done under vision, which is not possible in open approach. So that is the biggest advantage. Now let us see, coming on to the topic for today's case. Now what radiology to be ordered? For everybody, simple, the first investigation to order is a contrast enhanced CT scan when you suspect a JNA, or if possible, to get a CT angiogram done. That serves the purpose of contrast enhanced CT as well as it gives you full information of the vascularity. We have in this patient a contrast CT scan. And see, I told you JNA is diagnosed for its characteristic preferential spread to certain regions. Now see, as I said yesterday, the CT is always shot in axial sections. This is 0.6 mm contrast enhanced CT scan, and see this contrast enhancing mass lesion occupying the complete nasopharynx, posterior part of the nasal cavity and coming quite anteriorly. Then see this region we saw in dissection day before. That's the pterygoid process, the lateral and the medial pterygoid plate, pterygoid fossa, pterygoid wedge, and see the posterior wall of the maxilla. This is the region of the pterygopalatine fossa which is expanded because of the mass lesion. So mass is arising from here, extending into the preferentially in the posterior part of the nasal cavity and nasopharynx, eroding the pterygoid, expanding the pterygopalatine fossa, and beyond this lateral plate, it is extended into the infratemporal fossa. Since it expands from behind, it expands the, erodes the posterior wall of the maxilla and push it anteriorly. That is what the Hallman-Miller sign is. See the posterior wall of the maxilla here. See the normal pterygopalatine fossa, and now see how it is expanded by the tumor. The tumor is not invading the maxillary sinus. The periosteum is always intact. It is pushing from behind, and it is because of the pressure, the bone is necrosed. You see how the tumor is expanded in the maxillary sinus like anything. See, more the tumor coming anteriorly into the nose, more tumor coming anteriorly into the maxillary sinus poses more challenge to the surgeon, as you get less space to maneuver your instruments. So that is the add-on challenge in this patient also, as it is coming quite anteriorly and pushing into the maxillary sinus from behind, pushing the posterior wall of the maxillary sinus from behind to bulge in the maxillary sinus. Now this is one extension. Let me reconstruct this. See this. I am on the CT scan only. We have MRI and the angiogram as well. I will come to that. Now see, I'll come from anterior to posterior. See, this is the lesion. This is enhancing mass lesion. This is not enhancing maxillary sinus content most anteriorly. So this is non-enhancing is the mucus secretion. The trap secretion, which is not in the sinus drainage. Now as we go behind, see now as we go behind, this mass is rising up. See this rising up towards the cribriform plate, towards the anterior thyroidal roof here. See, it is rising up. See, the center of universe for this mass is the pterygoid region, and it is expanding circumferentially from there all around. So this mass is rising up towards the cribriform, number one. See here. Now as it goes behind, as we go behind, again it is rising towards the posterior thyroidal roof. See carefully. Entire ethmoids have been destroyed by the tumor pressure, and tumor has gone towards the roof. Now similarly this tumor has gone laterally. We have seen in the axial sections. This tumor, now see the posterior part of the maxillary sinus. This is the posterior part of the maxillary sinus. This is the tumor bulge from behind, which has reduced the maxillary sinus volume, and the tumor is bulging from behind. That's a bulge from behind in the maxillary sinus. That's the normal maxillary sinus on the opposite side. And then it has extended into the infratemporal fossa. See this tumor mass prolapsing in the infratemporal fossa. Is that clear?
Yes, yes.
Now, as we go further behind, see this. It has a preferential spread, I tell you. See where it is rising up? Inferior orbital fissure. Can you see?
Yes, yes.
See the opposite inferior orbital fissure? The normal opposite inferior orbital fissure?
Yes, yes.
And see how this tumor has gone all the way as we go behind from the inferior orbital fissure, and to have come into the orbital apex. Can you see?
Yeah.
This is the tumor mass in the orbital apex. See this?
Yeah,
that's the tumor mass in the orbital apex. I will corroborate in all planes where exactly this tumor mass is and what is the relation with the carotid artery and other structures. Now, here, see this tumor in the nasopharynx. It is, we have always seen it is attached to the roof of the nasopharynx over here. And see how it has eroded the pterygoid process. Can you see this?
Yes,
This pterygoid is hollowed out because of the tumor involvement. See the opposite pterygoid intact.
Yes, yes.
See the opposite pterygoid completely intact, and see this pterygoid is hollowed out. We have seen the tumor rising towards the roof of the anterior ethmoid and posterior ethmoid, but see the sphenoid is spared. Sphenoid is spared. This to me doesn't look like tumor. There's a mucus secretion. This is not enhancing. See, this is the tumor which has completely hollowed out the pterygoid process. Can you see?
Yeah.
Now this part of the pterygoid has lots of foraminas. In the lower part is the Vedian canal, mostly destroyed with such a massive tumor, because the tumor arises in the vicinity of the Vedian canal. And above is the V2, V1 is behind in the supraorbital fissure, and V3 is laterally, and it mostly goes in between these two.
Yes.
Between V1 and V2 is the anteromedial triangle. Between V2 and V3 the posteromedial triangle, anterolateral triangle. And see this tumor passes by means of eroding this bone. I had shown you that day on cadaver, drilling that bone to show you the temporal lobe of the brain.
Yeah.
And this is how, through the roof of the pterygoid, this ascends toward the temporal lobe of the brain. Though this bone is intact in this particular case.
Yes.
This was the bone I drilled. Had this tumor had progressed further, this would have eroded this bone and gone inside the temporal fossa.
Yes.
That's how many of these tumors we see extending high up in the temporal fossa. But fortunately, they remain extradural as they come from below. They push the dura up. They rarely invade the dura. Yes, the recurrent tumors have a propensity. They become more invasive. They acquire more, haphazard and different vascularity from the internal carotid system. Then their story is different. Otherwise, primarily, they don't erode the dura, and the similar way they have grown. If you find a tumor grown in a temporal lobe like this, don't frighten yourself. You widen this axis, drill away some more bone and pull it down. Simply in the same manner it has ascended up. No issues at all.
Yes.
Now, this has gone in the orbital apex here and the cavernous sinus behind. See this?
Yes, yes.
This region. Let me put my cursor over here and see how it has gone. Let me show you on sagittal for your better understanding. See this tumor here. This tumor, it has ascended the, see this is the orbit?
Yes, yes. Shiva?
It has ascended over the, through the inferior orbital fissure here. See this?
Yes.
This is the inferior orbital fissure through which it had ascended and gone towards the orbital apex. That was the region of the tumor which we picked up. Now, this grows behind, it can invade the carotid artery, involve the carotid artery. Now, how far it is from the carotid? Let me show you carotid where it is. See, can you see the carotid artery here?
Yes, yes.
Can you see the carotid artery here?
Very clear.
Now, let me follow the carotid, follow the carotid, follow the carotid, follow the carotid. See this carotid? See this carotid here? And this tumor is here. See this?
Yeah, yeah.
This tumor is here. That's the tumor. And that's the carotid artery. So my carotid is away from the tumor.
Yeah,
There
yeah.
is ample of space between the carotid and tumor, though it is ascending towards the cavernous sinus, but it is extending through the orbital fissure, and I will show you. I will widen this orbital fissure and pull it out immediately the way it has gone inside. Simple. See, if somebody says that I have removed from the orbital apex, I have removed from the middle cranial fossa, there is nothing great. Once you remove the regular angiofibroma, you can remove all these extensions by the same way by pulling from those areas as it doesn't invade. So don't frighten yourself. The tumor has ascended into the orbital apex and the anterior part of the cavernous sinus here. My carotid is, little away from here, and I can remove this or pull this tumor easily from here. The same way it has ascended through the orbital fissure, the same way will you pull it from the orbital fissure from here. So that is one extension. Now, this tumor has all classical extensions. Coronal section, you can see this on coronal section. That's the tumor that has gone to the inferior temporal fossa. This is the orbital fissure component. That is into the anterior part of the cavernous sinus, orbital apex. That is erosion of the pterygoid bone, pterygoid base. I would say it is completely eroded. The sphenoid floor is eroded, but fortunately tumor has not gone inside the sphenoid. This is the area through which it ascends into the sphenoid. It never enters the sphenoid through the natural ostium. Either by eroding the floor or by eroding the pterygoid base, it ascends into the sphenoid sinus and never takes attachment into the sphenoid, even if it has gone inside the sphenoid sinus. So that is the whole, about the extension of the tumor. Now we have MRI also. There are certain important things you can see on MRI. See, on a contrast MRI, contrast will depict the tumor as a strongly enhancing component. See this?
Yes, yes.
You can get to know whether, see, this is the orbital apex on this side.
Yeah.
See the orbital apex on this side. How tumor has gone.
Yes.
And that's the carotid artery behind.
Yes, yes.
And we are immediately anterior to it. We can see on sagittal plane also.
Yeah, yeah. Carotid.
How this tumor has gone towards the cavernous sinus but not invaded the carotid artery. Now, the most important thing which I want to show is the vascularity. Vascularity to this tumor. We have angiogram. Though CT angiogram is more useful, but still this is the 3D contrast. To correlate in 3D like we correlated in CT scan, this is 3D contrast. This is 3D contrast. And this tumor, which has ascended into the orbital apex, you can see better. See this? Like we saw on CT scan. This is the tumor which has ascended here. That's the tumor which has ascended. And that is our carotid artery. That is our carotid artery here. And this is the tumor. So we are away from the carotid by and large. Number one. Number two, the vascularity supplying to the tumor. For that, I will take you to the, the MR angiogram.
Yes.
We don't have CT angiogram, we have MR angiogram. Now let me tell you what do we see on MR angiogram first of all. See, this is the upper, this is not a complete angiogram of the neck
Yes,
till
yes,
head,
little
it
bit
is
head.
only head. So what I can show you, see this is the internal maxillary artery.
Yeah, we can see very clearly.
From here, the external carotid divides into internal maxillary and superficial temporal. Superficial temporal goes out, internal maxillary goes in,
Yeah,
and here internal maxillary, see, it gives off a branch to the tumor directly going from behind.
yeah.
you see here?
Yes.
Number one. Number two, the main maxillary artery, see, follow my cursor.
Yeah, going down.
See the main maxillary artery,
And
follow my cursor, is entering
feeding,
into the
yes, feeding
tumor
here, feeding here.
just behind. This is maxillary sinus.
Yes.
Just behind the maxillary sinus, it is entering into the tumor through multiple branches. See this?
Yes, we can see very
That's the
clearly.
main maxillary artery which we need to catch. Besides this, this is internal carotid. See this internal carotid here?
Yeah, very clearly.
See this? Very interestingly, we know, we have seen the day before in cadaver,
Yes.
internal carotid doesn't give any branch in the neck. And see what is happening here. Internal carotid is giving a branch to the tumor. Can you see this?
Okay.
Internal carotid is giving a branch to the
Yeah.
tumor, which is going into the tumor from behind in the nasopharyngeal component. Can you see this?
That has to be taken care of.
So we have to be ready to face this bleeding.
Yes.
We can't go and catch and control this because this is far behind. We can't see this unless we remove the entire tumor. So anything which is coming anteriorly like this maxillary, our first goal will be to catch this vessel and devascularize.
Yes.
But we can't catch these two vessels, the branch of the external and the branch of the internal coming from behind.
Yes.
So we have to be ready to face the bleeding in this case as well. Now, even if you embolize, you can embolize this branch of the external carotid, but not the internal one.
Yeah, of course.
So you can't help it. You have to face this. You have to be prepared to deal with this bleeding. Okay?
Okay, got it. Ultimate.
I hope it is very clear.
Yeah, very clear, very. So
So
we have
that is
three,
the
we have three feeders
Yes, three main group of feeders you can say.
and
And this is really a massive tumor. See this? It has a massive component in nasopharynx, lateral part, and everywhere. And see what I'm going to do. My plan. This is the medial component. Can you see?
Sir, can you again tell that the posterior branch of external carotid, what is that?
Yes. Yeah.
The internal maxillary, we could get it.
Yeah.
Which branch is
Yeah.
that?
See, this is the internal maxillary.
Yes.
It gives off a branch here. See this?
Okay, this is the branch of internal maxillary only.
Yes. This is going. See, internal maxillary main trunk is here.
Yes.
This another branch is entering into the tumor from behind.
Right. Okay.
That you can't catch.
ठीक.
You have a far big tumor anteriorly.
Okay.
You can catch only this vessel, so
Yes.
we'll have to face some bleeding, and we will use our cobblator and other maneuvers to handle that bleeding. There is no way, but this prepares you to expect this kind of bleeding and to be ready to handle that.
okay.
Okay?
What are protocols to before starting the case, like blood arrangement? How much you ask?
So what we have done here, this is a new setup for me. We have already loaded the patient with 1,000 ml or so, some fluid, some starch or something to dilute the blood, which is going to be lost, number one, because I'm expecting a good amount of blood loss as well as it has certain feeders which are beyond our control. Number one, we'll be using cobblator all the way on surface, as a majority of the bleeding is on the surface.
Yes.
As the tumor grows more and more, the central part become more and more necrotic. So on surface, we'll be using cobblator. Number three, will not enter the tumor any point of time unless we expose it from all around.
Yes.
Unless we take the internal maxillary as a principal supply in control. So our goal will be to take the maxillary in control before we extirpate the tumor. Fourth, we'll be using in case required some Surgiflo seal in case required for some venous bleeding or some arterial bleeding, which is required to be to control to keep our field good. And number five, see this. This is the medial component of the tumor,
Yes.
the big one.
Yes.
See this, like a cricket ball in the nasopharynx.
Yes.
Huge one. Huge cricket ball in the nasopharynx, that kind of a component we have. So what my plan is, and similarly we have a huge lateral component. Now this huge lateral component along with medial component cannot be accommodated together in the nasal cavity. It doesn't have that much space. So my plan would be to catch the internal maxillary first and divide this component at the medial wall of the maxilla. See this level. We will divide this into two.
Yes.
We will remove the medial component first and deliver in the oropharynx, and we'll have ample of space to bring the lateral component inside and accommodate. Got my point?
Yes, yes, yes.
So this will be our clear plan in this particular case, wherein we are going to divide into two in a planned way. Once you do a planned division, your internal maxillary must be in control first. If your maxillary is not in control, this maxillary is particularly, enlarged to give more blood flow to the tumors. And if your internal maxillary laterally is not controlled, you can't divide it, will not allow you to divide it, will make completely mess with a lot of blood into the field. So first goal, see, we have this much of tumor. First goal is to give a good exposure. See, what I will do dankers, modified dankers that we saw day before. I will remove this medial wall of the maxilla.
Yeah.
I will remove this part of the anterolateral wall of the maxilla. And we'll have a head-on access to this entire area, number one. Head-on access to this entire area, number one. And then I will go behind to the posterior wall laterally and look for the internal maxillary to take it in control.
Okay.
That will be my first goal. So first goal is to take the internal maxillary in control. That will be our prime goal. You can see where the maxillary artery is going to be. See this? From cursor, you can take the maxillary here and see on coronal, this is my maxillary artery. This is my maxillary artery.
Yes, yes.
See how you can find easily on DICOM. This is my maxillary artery. See this is my maxillary artery.
Yes, coming in.
See, this is coming here. See this maxillary artery?
Yes, yes.
This maxillary artery?
Yes.
This is pushed high up. Can you see?
Yes, going up, yes.
See, this is my maxillary artery coming into the tumor. This is tumor.
Yes,
This is
yes.
orbit on the right side. This is your pterygopalatine fossa. And because of the tumor mass, your artery is pushed superiorly. That is such an important finding. Otherwise, you keep on looking for the artery inferiorly and don't find anything. Got my point?
Yes, got it.
See this artery here, this is our goal to catch. This artery is our goal to catch, and you can see this vessel in all planes. क्या हुआ? चल जाएगा? कैसे जाएगा?
चल रहा है
नहीं, कंसोल नहीं चल, ये नहीं चल रहा ना. यहाँ पर चला दो. इधर लगा. Yes. See the internal maxillary? And this internal maxillary you can see in all planes. See in the axial plane? See in the axial plane, this is your internal maxillary. Can you see?
Yes.
How it is traveling inside the tumor. So you can see in all planes your internal maxillary, and you should have all plans to catch this vessel below the orbit to devascularize it. And once you devascularize, then you'll be able to handle this tumor. Even after devascularizing, we'll expose the tumor from all around. Expose it superiorly by doing a sinus dissection above, posteriorly by seeing the sphenoid behind the tumor. Then medially we'll do a posterior septotomy to see the tumor and the part of the nasopharynx which is spared from the tumor, to see the nasopharyngeal attachment, and then we will divide into two components and remove the medial component first. That's the whole plan for this case. And once we remove the medial component, the lateral component removal becomes a child's play.
Yes.
Because that has gone laterally
Yeah.
You have to pull it from wherever it is going. So in this case, we have to pull from the pterygopalatine fossa, infratemporal fossa. We have to pull from the inferior orbital fissure and then further from the orbital apex. And lastly, whatever pterygoid is destroyed by the tumor, we have to drill away completely till its base on the middle canal fossa floor.
Yes.
So under vision, we will see the entire Haversian canals of the pterygoid which is involved to be free of tumor until it starts bleeding on its own.
Check. Okay.
That's the plan. Do we go ahead or any questions?
Yes, yes.
Sir, good morning, sir. Is it mandatory to get a CT and MRI both in all cases of JNA?
Not really. So I told you first to get a contrast CT or CT angiogram first. If
Yeah.
the tumor is not invading the skull base or intracranial space, you don't need MRI because
Right.
that is not going to change your treatment anyway.
Yes.
If it invades the skull base or intracranial space, you must, like this tumor was going to the orbital apex, was like prolapsing into the entry part of the cavernous through the orbital fissure. So it is better to have MRI for better, relationship. Otherwise not. For a small tumor, you don't need MRI at all.
Right, sir. Thank you.
CT angiogram in itself is a complete investigation that includes a contrast and a CT scan along with a CT angiogram both to give a full idea of the vascularity. See now, how important was this in this case to know the vascularity for us?
Yeah, this internal X-ray.
See how the vessels are entering into the tumor and how we have planned ourselves, the tumor division, taking the vessel in control, and then after dividing, pulling from all the three areas which it has expanded beyond into, like pterygopalatine fossa, infratemporal fossa, inferior orbital fissure, orbital apex, everywhere we will pull simply. And that part after division to remove from everywhere will be simplest, I tell you. Don't think that tumor extending into the infratemporal fossa is more challenging. Tumor extending into orbital apex is more challenging. It is the basic Denker's approach which is most important and the tumor division. Rest wherever it is extending, you have to pull it out. And second most important part is drilling of the pterygoid. That is the most important thing which was not done, in the open approaches, as you can't see the tumor, small tumor, prolapsing here and there. And that is why the endoscopy approach prevails as a preferred approach, because you can remove under vision, under brilliant illumination, magnification. I will show you from each and every area you can see and remove the tumor. Even of a slightest down anywhere in the eroding the bone, you can drill away the bone completely. As our goal is very clear, complete removal of the tumor is the goal. Even if you leave a slightest of the residue, it is going to come back in a more, terrific manner than what it is. The primary angiofibroma is it behaves like a good boy. It is a well-behaved child. It has a preferential spread, preferential vascularity, everything what it is predictable. But the revisions are never predictable because they acquire unpredictable vascularity, difficult vascularity from behind, vascularity from internal system. You can't even embolize, and all those challenges you can think of. They become more invasive. They even invade the dura, invade the brain tissue proper. We have seen a couple of cases where the tumor was invading truly the brain tissue. So the story in the revision is altogether different. So in primary, it is more predictable. Plan your approach with the scans properly. The scan is the key in planning everything, as what I have told you, shared you with you just now.
Sir, there are many reports which suggest that the most common area of recurrence is around the median canal.
Yes, it's pterygoid. Yes. See the bone. This tumor has a preferential ability to invade the Haversian space of the cancellous bone. Now, if you leave the tumor behind, it is going to come back. So the word you are using, recurrence, to me is never appropriate. It is the residual tumor which regrows. And that is the added advantage of endoscopy over the open approaches. Because in open approaches, when you remove this big of the tumor, you pull from everywhere, remove, there is a gush of bleeding and you ultimately pack and come out. You don't have any, option but to pack. And then you don't see where the tumor, small tumor is extending into. The endoscopy is the biggest advantage in terms of visualizing all those small areas, canal, crevices, where you can see. I will show you all those extensions I have shown you on CT scan and MRI. I will show you each and every area under vision, under magnification, under high illumination that the tumor have come out.
Do you drill the Hessian system in every case, sir, or only in the case?
If I find the tumor is eroded. Now, that's a very important question from madam. How to ascertain? See, what you see on the surface is different. You may find on the surface the pterygoid looks good.
Right.
But whether the pterygoid is microscopically invaded, how do you get to know? That's a very, very important question I forgot to mention. See this. In this particular patient, I don't think the MRI was done in Calcutta for this patient, who came to us, and I transferred to Karnal. See this. This is T2 weighted imaging. That's why the onus is again on the surgeon to order what imaging you need in the JNA. We always mention fat suppressed T2 weighted imaging. Why? This is a very, very important question for madam. See. That's the pterygoid bone. Can you see on this side? Yes. And that's the pterygoid bone. Can you see on this side?
Yes, yes.
See, what is this bright? On T2 weighted, the fat is always bright.
Okay.
Got my point?
Okay, yes.
Infection, inflammation is always bright.
Okay.
Now, this is not fat suppressed. See here, everywhere there is superficial fat everywhere.
Yes.
Fat is bright. See this fat in the orbit is bright everywhere.
Right.
So, the pterygoid has a marrow space and marrow contains fat and it is bright. See this bright?
Right. Huh.
Now, if you have a fat suppressed imaging, suppose
yes,
this fat will be suppressed and what you see this entire thing? Black. Black. Now, on the opposite side, the tumor is invading the pterygoid.
Okay.
What will happen on fat suppressed imaging? If tumor is invading, it will never be black.
Okay, okay.
You will see the tumor enhancing this region because this is a vascular tumor. So, fat suppressed imaging is must. On fat suppressed imaging, if you find on fat suppressed imaging the fat is not suppressed, that means the tumor is infiltrated.
Okay.
Tumor is infiltrated. So, even if your pterygoid process looks by and large good from your endoscopic appearance, if your MRI shows on T2 weighted fat suppressed, the signals of the fat suppressed are not good. Even after suppressing the bone marrow fat, there are signals that signifies the tumor within, and then you have to drill the pterygoid. That's the indication for pterygoid drilling rather than on surface endoscopy you take the decision.
Thank you, sir. Very nicely explained this point.
So the onus on the surgeon is to advocate what kind of MRI. Let me put you what kind of imaging, like our previous surgeon asked the question, what, whether CT is MRI, both are required. So first is the CT angiogram, that itself is a contrast and then CT scan along with angiogram to show you vascularity. That is the first investigation. If it is invading the skull base, then you order the MRI. And MRI, you order the 3D contrast imaging along with T1 weighted and T2 fat suppressed.
Can I ask you one question more? You are telling this is
angiogram. Yes.
You are telling it is involved the inferior orbital fissure. So can we see whether it is extending up to the superior orbital fissure or not?
Yes.
That point is, can you just describe it?
See, superior orbital fissure is anterior continuation of cavernous sinus.
Cavernous sinus.
It is prolapsing into the anterior part of the cavernous sinus. Obviously, it is going through the superior orbital fissure.
Okay, so superior orbital fissure is a narrow zone.
Yeah, so it is extending through the inferior part of the superior orbital fissure. It is extending from anterior to posterior. Similar way, I will remove the medial wall of this fissure, show you the tumor going inside, and then we will pull out gently the way it is extended into.
So what approach will be that you remove the medial wall?
Same. After the dankers, everything will be in front of you.
Okay.
After the dankers, I'll show you where the V2 is going, where is the maxillary strat, where is the superior orbital fissure. That's what I'd shown you in dissection. That was the That's why we showed on dissection.
Right.
And then I'll show you the superior orbital fissure, medial wall. We'll remove the part of the medial wall and see the tumor going into it, and then we'll pull it out.
Thank you. Thank you. That's good.
So, secondly, we must order T2 weighted first, fat suppress. Again.
Sir, any neurological manifestation patient will have, or they will not have?
Not really.
Not really.
Not really. See, this is expanding by compression. Yes, if it compresses the cavernous cranial nerves, it can give, but it has not given. Another investigation which is very useful. See this? This is diffusion weighted. I tell you very often. Last month we have referred a case from outside somewhere as a JNA, classic 12-year-old child. CT scan was done. Mass in the nasopharynx, has occasional history of bleeding, complete nasal blockage, and it was labeled as JNA. We got the MRI done. On diffusion, there was restriction in the tumor, overall restriction. A restriction in the tumor signifies a malignant tumor rather than a benign tumor. So this is another investigation you must add on in your MRI protocol. T2 weighted fat suppress along with diffusion weighted MRI. See, what does the diffusion weighted MRI show? Let me put the axial regular MRI. See, this is enhancing tumor, contrast enhancing tumor, and see, on diffusion, it is also enhancing, showing bright. What does it mean? Diffusion MRI is a bioimaging. We always get a diffusion imaging done before taking patient for surgery. Even if sometimes the patient has got an MRI done elsewhere, we repeat it. We have no option but to do it to rule out any malignant tumor inside. So, diffusion is what? Is a bioimaging. MRI is a magnetic field. A magnetic field in the, this area where the magnetic field shows the diffusion of water molecules. Diffusion of water molecules in the magnetic field is what the diffusion MRI shows. Now, what happens? In a malignant tumor, it is more vascular, more nucleus, then less cytoplasm, more nuclear cytoplasmic ratio, less water content, and there is very less diffusion. In benign tumors, there is more water content. More water content, more diffusion of water molecules, and see, this is the bright picture. Had this been a malignant tumor, this would have been absolutely dark. Had this been absolutely dark, I would never label it JNA and I would take a biopsy. So the diffusion MRI, you must include in your protocol.
So how about the
misdiagnosis?
vascular tumor, hemangiomas, AV malformation? They will also give this type.
Bright, always bright on diffusion. Any malignant tumor, any tumor with a high cellularity, more nuclear cytoplasmic ratio will show diffusion restriction. That's how, we have been using this diffusion by many means now. As one of the, top priority investigation in many malignant tumors also.
Okay.
So like, in malignant tumors, you can differentiate how virulent the malignancy is. Like lymphomas, they're most cellular tumors shows highest level of diffusion restriction. You show in squamous cell carcinoma, you get the report from the pathologist showing differentiation. Well differentiated, moderately differentiated, poorly differentiated. Poorly differentiated tumor fare poor. Well differentiated tumor fare better because of the characteristic nuclear features. Now same in diffusion, when you get an MRI of a squamous cell carcinoma on diffusion, you can get to know to fairly good extent how restriction in diffusion in that particular tumor. More the restriction is, poorer is going to be the outcome, overall outcome. There is more nuclear cytoplasmic ratio, more virulent a tumor. Similarly, you can see the tumor progression on therapy as well. Like for example, in many laryngopharyngeal tumor, we advocate CTRT. Now, many are sensitive, many are not. If the patient tumor is not CTRT sensitive, there is no fun in continuing the CTRT for 2 months or 3 months or whatever. Got my point?
Yes.
So what we do, we get the initial diffusion MRI. We get after 3 weeks the diffusion MRI done again, and if we find the change, find a good change, we will continue, otherwise discontinue and take the patient for surgery better than unnecessarily, subjecting to the CT MRI, side effects. Whether it is not working, not sensitive, there is no point in doing that. So diffusion is a great investigation in monitoring the treatment response as well in malignant tumors.
That is beautiful, sir. Or any other indication in head and neck, is sir?
Diffusion?
Yes.
Yeah, diffusion can rule out, like in cholesteatoma, in differentiation of the middle ear masses, in abscesses where you suspect somewhere, any mass lesion suspect abscess, get a diffusion showing restriction. So diffusion and number of applications.
Any role of CT angiography or something like that to know the vessel supply, or this MRI is good enough then?
For?
Should we supplement the investigation better with angiographic study of external internal carotid or not?
For which pathology?
Angiofibromas, sir.
Angiofibromas, CT angiogram is the first investigation. Always get CT angiogram. That will give you complete better information about the vessel supplying the tumor, even better than the MR angiogram.
Okay, sir. Thank you.
So MRI is indicated only if it is invading the skull base or intracranial space. Do we start?
Yes, we are waiting.
So we can continue discussion during surgery. Please feel free to interrupt me anytime.
So that is the surgical armamentarium for the JNA, for any phase. Clip is there. See you. Okay, applicator is
Hello, Dr. Rajiv.
Yes.
So we are having so many cases today.
Yes.
So what is the demand right now after angiofibroma?
JNA, then spectrosectomy, then parotid.
And then?
Parotid.
Then
your choice.
Okay. So we are having parotid also, we are having thyroglossal cyst also, we are having submandibular also.
First, I think JNA followed by implant, then parotid.
Okay. Are you getting the picture?
Yeah, we are getting it.
Okay. Clear? It's clear?
Yeah, it's very clear, very clear.
Okay.
Yes, collaborator.
Hello.
Yes.
Am I audible, boss?
Yeah, very much.
How's the picture?
Wonderful.
This is thanks to the Dr. Khanna and this Carl Store's spice system.
Yes.
See this?
Picture is amazing.
So this is the tumor. See this? And I expect this to be very, very vascular today.
Yes.
And you will witness that. You have seen many of the angiofibromas earlier.
Yeah.
But since I expect this to be very vascular because of the. See, my man of the match today.
Collaborator.
gallbladder.
भेजूंगा मैं, होते
Surface decongestion for many reasons. Number one, to reduce the vascularity as maximum is on the surface. Number two, to shrink the tumor as well, to acquire more space. So whenever you start visualizing the tumor, start surface coagulation. See this attachment on the turbinate? Can you see attachment on the turbinate?
Very much.
This tumor has a preferential attachment on the middle turbinate here. It is almost always there on the middle turbinate and septum. You'll rarely find on the nasal floor.
So you're
whatever
using
tumor,
cutting board, you're using cutting
whatever
board?
tumor coming in your view, see this,
Yes.
always keep doing surface coagulation. So inadvertently, even if your instrument happens to poke into it on the surface, it is not going to bleed. This is very important, otherwise bleeds like anything.
So you are using coagulation as well as cutting board, both the modes.
Yes, right now, coagulation.
Yeah, right now coagulation, but
अब तो लग रहा था गोली।
See, whatever tumor we see, it has shrunken.
yes, yes.
So have you asked the anesthetist for hypotensive in this patient?
Yes. And I am so grateful to our anesthesia team here. Amazing. Yesterday also you saw the seamless anesthesia in all cases, and today they were so committed. They came early, put a central line. They're all set with their plans. They loaded with the fluid. See, I'm dissecting, separating this turbinate a little bit here. See this? That was the turbinate attachment. And they are giving us hypotensive anesthesia. See this attachment to the wall?
Yes, yes.
See what a tool this coagulation is. This is like a magic wand for this.
Sir, let's say if we happen
It has the
to
ability to cut, ability to coagulate. At the same time, it has a suction channel as well as the irrigation channel. So it maintains the visualization all the time. So whatever tumor visible to you, keep coagulating.
excuse me, sir.
This surface coagulation is very, very important to maintain our visualization.
Sir, can you hear us? Hello.
See, we saw on MRI, CT scan, this tumor was rising towards the anterethmoidal roof. Can you see? Hello?
Hello. Can you hear us, sir?
Hello?
Hello, OT.
See, this tumor was rising towards the anterethmoidal roof and see attachment with the septum. Can you see?
Yes, sir.
Hello, auditorium?
Yes, sir. Do you listen us? Dr. Satish.
Hello?
Hello, Dr. Satish. Hello.
Hello, are you audible, sir?
Yes, yes. Am I
Dr.
audible
Satish.
there?
Yes, yes, we are hearing you.
See, this tumor is rising towards the ethmoidal roof.
Yes.
And see the attachment with the septum.
Yes.
See, wherever it comes in contact with, it takes attachment. and additional blood supply.
Yes.
And what you need to do is coagulate and cut off the blood supply wherever it is additionally attached to. See this?
Yeah. Before coagulation, how you used to do it? I mean, with coagulation, it seems so beautiful, bloodless field.
Yes, coagulation is magic. Now give me a peck. See now, whatever visible portion of the tumor is, we have been coagulating. See how it has shrunken behind. Earlier was less space with us.
Now the space has increased.
Now see, this space is opened up. Dubey sir?
Yes, yes, sir.
Excuse me,
This is not wastage of time. This is investment.
Yes.
See,
I
never takes attachment on the floor. See, in times to come, this tumor you will see like a well-behaving guy.
Tamed down in front of you with your coagulation.
Yeah. See, attached to the uncinate, attached to the turbinate, and everything under vision. Angiofibroma is something with this kind of angiofibroma. This big, see the visualization.
Excellent.
Panoramic view in the nasal cavity and see the tumor. After it is shrunken, you can see the ethmoidal roof. See the middle turbinate is pushed laterally.
Yes.
And whatever tumor I have exposed, I will cover with the. I will cover with this adrenaline,
So
watch
God,
pieces. Right. So as to prevent my instrumentation unnecessarily, poking into it.
And now you have enough space for your
Enough
tanker.
space to maneuver. Yes, that's why I told you. It
Yes.
was coming here actually.
Now the tanker's space is there.
We'll be able to do dankers and see everything under vision. So far, no blood loss.
Not at all.
Everything under vision. Now, for the dankers, you have seen number of times. Day before, for everybody present here, we did in a cadaver. I showed each and every step of it. Now see, this is your axilla. Roughly, my orbital roof is, you can say, a centimeter below the axilla. Roughly. So what I will do, I will first coagulate this mucoperiosteum. See this?
Yes.
Until the pyriform aperture. This mucoperiosteum is very vascular. It is supplied by many vessels, including the facial artery, anterethmoidal artery, and a branch of the sphenopalatine as well. So coagulate thoroughly. See this?
Yes.
This one tool is working all the way. Magic wand. And this is a separate bone, that is
Inferior turbinate.
inferior turbinate. And see my limit anteriorly. My limit anteriorly is this pyriform aperture. See this?
Yes.
Don't come anterior to it. See this, a centimeter anterior to this. This is the lower ala.
Yeah.
If I happen to injure this lower ala, patient will require rhinoplasty. We will have to reinforce the cartilage to elevate the ala then.
So always enter through the inferior part of the pyriform aperture?
Yes. Till the nasal floor. See this? We have to flush with the floor. This is pyriform aperture. Now, once I have coagulated, now I will use my ablation for the first time. This mucoperiosteum, otherwise you
bleeds.
Have the taste sometime without coagulation, how it is. See this?
Yes. Oh, layer by layer. It is melting like a butter.
Yeah, that's the beauty of coagulation.
Like painting.
See, that's a pyriform aperture.
Yes.
Can you see? Can you see?
Yes, sir. Very clearly, we can see the pyriform aperture.
This bone.
Bone.
Sir.
Now see, this is a separate bone, inferior turbinate.
Yes.
I had shown you that day also in the cadaver. So the advantage of cadaveric dissection is we have already done the rehearsal. See, this is inferior meatus.
Yes.
Sir,
I will coagulate this mucosa until I flush with the floor. Yes, sir.
sir, if we are using coagulation on the tumor, and if we by chance enter the tumor inside, so if there is a torrential bleed, then
You have to pack, you have to coagulate, you have to bipolarize, or you have to pack for some time. That's why you have to be careful. And with this coagulation itself, you are not going to enter. This is not a sharp tool.
and somehow, sir, if there is no coagulation with us, then
Then without coagulation, you cannot have this luxury of what I am doing. See, the one tool single-handedly.
Sir, since you are using this tool, can you tell what was the difference you took on the tumor and on the lateral wall, sir? How you are operating it on the tumor and on the lateral wall for cutting?
Yeah, so I didn't get your question, madam. Can you
सर
repeat?
कॉबुलेशन के डिफरेंट मोड्स होते हैं, तो एक मोड से आपने सरफेस पे किया, एक मोड से आप कट कर रहे हैं,
Yes.
तो ये प्लीज एक्सप्लेन दिस.
So whenever you feel or you find a need of cutting, then only come to the ablation. Ablation is a dangerous mode. It can cut whatever comes in the way. So if you are close to the vessel or nerve, it can cut. No time. So ablation mode, you have to be used very, very selectively whenever you feel like cutting something. See this?
Yes.
My medial wall completely exposed,
Yes.
and so far no bleeding.
Okay.
See, this inferior turbinate, inferior turbinate has a major vascularity coming from behind. We all know from the branch of sphenopalatine. See this inferior turbinate?
Yes.
Yes. So now we have more space. See this?
Yes.
Any slightest of the doubt, any point of time, feel free to interrupt me. I believe you are all experienced surgeons. You are all doing endoscopic work. I came to know. We discussed yesterday FES. It is little bit extension of it. And you should all be able to do it if you are not doing. So any fear in mind, please discuss. Say this now.
Yes.
Exposure photo.
Boss, you did a surface cauterization with the surface coagulation with the coagulator. Is there any limiting factor to the depth of coagulation that you can do? The shrinking of the tumor because there is no bone inside.
You have to apply it gently without any pressure.
Okay.
Don't poke into the tumor. Okay. Now see, I am going to the anterolateral wall. Subperiosteally. See this?
Yes. Very nice. Sometimes this also bleeds.
Yes. But don't worry, since you have coagulation, you can manage. This way you are bound to severe certain, nerves, neurovascular bundles, the fine anterior superior alveolar nerve. See these
Very good.
nerve filaments. At the limit here, if you want to go, you can go up to the infraorbital bundle. Depending upon the need. Infraorbital, I will show you. Infraorbital bundle is till what I have elevated infraorbital bundle is within a centimeter from this. I had shown you in cadaver if you remember.
So will this case be an indication for coming from opposite side transseptally, also creating a window?
Yeah, that is another poor way of doing it. I would say, alternative. Now with you have endoscope and dankers as an approach. You don't need to do that. Earlier, people would take the advantage of coming transseptal to reach this area. Why to? Why to take a route of, going to Delhi?
Indirect route.
Via Punjab from here. You have a direct route. See this? Now this bone is our target.
Yes.
The moment we remove will be head on into the
Tumor.
maxillary sinus. वो section periosteum ले लो. Now I will punch out whatever thin bone it is.
What instrument you are using, sir?
This is the lux forceps, simple. See the thin anterior bone I am punching out.
Yes.
Rest I need to drill. That day, we did discuss in detail the steps of the dankers. I can show today. Somebody asked about to ascertain the level of the, orbital floor. We will see and ascertain.
Because
Don't do
live,
anything blind. See and believe.
because live danker is more elegant and clean than cadaveric.
Yeah, cadaveric is difficult because you don't have, coagulator then. Suction. Suction. क्या कर रहा है वो? Suction periosteum रख लें तो दूसरा suction दे दे. वो suction periosteum रख दे. I hope you are oriented.
Yes,
what I have
sir.
done until now.
Yes, yes, sir.
Now see, this is a thick bone. Now above is the orbital floor. Now how to ascertain? I am going into this anterolateral wall.
Making a hole. So it's your stylus or coarse diamond
Yes,
burr?
stylus, always stylus. This is something I am addicted to.
Stylus has got suction inbuilt.
Suction, irrigation, everything.
And
see, I am just making a window into it.
yes. To
To
see the
see
superior
inside.
border.
You know the posterior wall has been pushed anteriorly.
Yes.
Dubey sir, had you seen the MRI CT?
Yes, yes. I was all the time watching your MRI and CT angio discussion.
Now, let's see.
We know that maxillary artery is pushed upward in this case.
Yes.
Some
See the
secretions are there.
secretions?
Yes.
See the mucosal secretions?
Yeah.
We have seen, remember on CT angiogram, non-enhancing component. See this mucosa?
Yes.
This is simple disease mucosa because it is not draining. See this?
Yes, yes.
So our orbital floor is little higher. See this
Higher.
is still higher.
So we can go a little more.
What I will do, give me a debrider. Let me tackle this mucosa, pack this, decongest this and show you better. Just for the sake of demo.
Sir, can you put the endoscope further to see the orbital floor?
Yeah, I will show you. That's what I am doing. I am removing this mucosa. See the orbital floor up.
Yes.
Yes, sir. Yes.
Yes. Very clearly visible.
That's the prominence of nasolacrimal system. Now, let's go widen this window up.
Because now we are seeing the limit.
Bada pani.
Good picture.
See this?
Yes.
Yes.
This is 15-degree
Angle.
burr point.
Yes.
So my shaft never comes in the way.
That is why we are getting
That
very
is
good picture.
something mesmerizes.
Yes.
And it is so sleek, like you're holding a pen.
So it's a M5 with the stylus, or what are you using?
Pardon?
M5 system with the stylus?
Yes. Yes, sir. See, that is the orbital floor.
Floor, yes.
Above. The rider.
You are almost flush to the orbital floor.
Not yet. Yes, but close to it.
Yes.
Just to show you. See that?
Yes, yes.
We'll do a little bit more. Tracker. Drill. The problem with this burr point is the cost. Every single burr point costs around 35,000.
And how long it longs?
One case.
So एक केस के बाद इसको कहाँ रखते हो आप?
Pardon, sir?
एक केस के बाद इस बर को रखते कहाँ हो आप?
इस बर को मैं कैडेवर में यूज कर लेता हूँ कभी कभार. Like day before it was broken, huh?
Right.
फेंकता नहीं हूँ, चिंता मत करो. See this widening of the anterior wall?
Yes.
Some more widening because this has a quite significant lateral extent. Fine. Investing time in exposure, you know.
Yes.
My 90% of time will be invested in exposure, exposure, exposure. See this orbital floor?
Yes, sir.
See that orbital floor?
Yes.
Now this bone already thinned out. Let me thin it more to break it. See the nasolacrimal duct prominence behind.
Yes, yes.
Yes, looks. So I can now punch out this bone. See this?
Yes. It is thinned out now. Yes.
See what is behind.
Nasolacrimal duct.
So day before somebody was asking about the nasolacrimal duct anatomy. You can see the duct standing prominent. See this?
Yes.
Yes.
It has three walls. Formed by bones, three different bones. The most prominent one is the frontal process of maxilla. Then, see this?
Yes.
Yes.
Then below, on one side here by the lacrimal bone, and below by the lacrimal process of inferior turbinate. These three bones constitute the nasolacrimal duct. And there are more than 12 different named walls in this system. Named walls. We only know commonly the valve of Hassner below. But there are 12 named walls right from the canalicular opening to the valve of Hassner. You know? Needs further exposure. Spend time into it. You know, Now see the thick bone here. The thick bone, you have to flush with the floor. See this?
Yes.
Why? Because when we remove the tumor from behind and laterally, this prominence will hamper our instrumentation.
Right. This is a very thick bone.
Yeah, so you have to remove it. Don't jump onto the tumor. If you try to jump on like this, you will cut a sorry figure. Without proper exposure, this tumor is in a little cruder way.
Yeah.
You can remove this with a Gaussian hammer like I did yesterday before.
Yes, yes. Or there are now available some sheathed burrs are there, which
Pardon?
is some burr with sheath to do work into the nose. They are now available. They are cheaper than this stylus. They have got sheath there so that it should not traumatize your philtrum or nasal vault.
Okay.
It is available with Sambros.
Available with?
Sambros, the lady.
Yes, yes.
Jyoti Vadera.
Yeah.
But the essence of the thing is that you have to be patient enough for exposure.
See, my entire time is invested in exposure.
Exposure only, yes, sir.
I am in no hurry to compromise with the exposure.
So you are a very fast, real-time surgeon. What you speaks, you immediately demonstrate.
The brighter. The brighter. See, the thick bone forming the nasolacrimal duct is what? This is frontal process of
Maxilla.
See this?
Yes.
Yes.
Now the duct is clearly visible.
Now, see the thin bone forming the wall below?
Yes.
Let me show you again. See this thin bone?
Yes, sir.
This is lacrimal process of inferior turbinate. And see this thin bone above forming this wall. See this?
Yes, lacrimal bone. You always advocate that it should be cut very sharply.
Yes. Right.
Flush with the bone.
So that it doesn't fibrose. Overhanging nasolacrimal duct may get fibrose and then epiphora is a problem. In case happens to occur, then go above and do a formal DCR.
Right.
Later. I will give further more lateral exposure in this patient. I need a little,
yes, lateral
adequate lateral
here.
exposure. The tumor is going far laterally. Full suction for you. The suction is clogged or what?
Suction is weak.
Yeah, it's partially clogged. Hey. Now retract this, retract this. See this part of the anterolateral wall?
Yes.
Why, which I want more and more. See, if the bone is thin and you can punch out with the flux, it is faster way of doing that. See this pony projection?
Yes, yes.
Brighter. See now my exposure to the posterior wall of the maxilla is improving.
Yes, sir.
I will improve it more and more. See the wall of the maxilla?
Yes, yes. Wall is intact.
Ah, later. Later. See all this soft tissue bleeding. The
Yes.
answer is ovulator.
Ovulator, yes.
Ovulator. So I have a reasonably good exposure of the posterior wall now.
Yes, sir. Yes, sir. Very nice.
Now little bit of this bone. Give me a Gaussian. See this little bone?
Yes, it is. It has to be flush with the floor. We are using chisel and hammer because it's a very thick and hard bone.
Yes. To expedite your procedure.
Yes.
See this? Big chunk.
Almost flush with the floor.
Washed up. See now the field?
Yes.
This mucosa I need to remove as I have to go behind. See this?
Full stripping.
Rider. I need to remove as I have to drill the bone and go behind.
Yes, sir.
See, this is a tumor bulge.
Yes, yes.
You see this?
Yes.
This is the tumor bulge from behind. This is that is uncinate process. See that?
Yes.
Do everything under vision. So as make sure that your tumor is not disturbed. Drill. Funny. Final touch on this exposure.
Yes.
See now, behind my instrument should glide easily.
Right. There should not be any hindrance.
There should be no hindrance to the instrument pass. See, flush the nasal floor.
Yes.
Gallbladder.
Even with coagulation, all the small bleeder will.
Coagulation is man of the match. The brighter. The brighter. See what we have achieved is anterior exposure of the tumor,
Yes.
anterolateral exposure of the tumor. लगा नहीं. And now we'll get rid of this nasolacrimal duct. So we'll be head on onto the tumor. See, the
Right.
structure which is obstructing our approach to the tumor is the nasolacrimal duct. That is the uncinate process. Taking from behind. See this?
Yes. Very nice.
From behind. There's still left.
Small part is there.
Oh. Now see the duct and see the level of the orbital floor.
Yes.
See this? Drill. Very soon we are going to cut off this. See now how it is flushed.
Yes. Flush with the orbital floor.
See, can you see it? Completely, almost completely flushed.
Yes, sir.
All money. Sir, agreed it is flushed?
Yes, absolutely flush. Very nice. Now we'll cut the,
We have to cut it sharp. So now it doesn't come in our way anymore. See that?
yes,
See the duct.
yes, 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 yes,
Okay?
yes.
So it is now out of
Scene.
scene. See the exposure. I hope everybody is oriented so far.
Yes, sir,
Yes, sir.
absolutely fine.
Kapila, are you sleeping?
Kapila is sitting behind, asking for infraorbital nerve.
Infraorbital now. See here,
Yes.
this prominence.
Have you seen?
Yes,
That
good
prominence
morning,
is-
boss.
Good
I'm
morning,
watching grossly and gauged, so
Everybody is spellbound,
beautifully
so
done, boss.
there is no words. Eyes are open, mouth is shut.
Now see, this is the component completer. This is the periosteum which is pushed from behind. See this
Yes.
part. This is the nasal component. This is the pterygopalatine fossa component.
Yes,
And
sir.
we had seen on, CT and MRI that here the bone is eroded because the pterygopalatine fossa, the maxillary posterior wall is a relatively thinner bone. And because of the tumor, prolapse, the thin bone is eroded, pressure erosion and bulges out. The periosteum always remain intact. We may find some thin bone also. See this?
Yes.
Yes,
And see the margins.
yes.
Yes.
But this is only medial bone forming the part of the pterygopalatine fossa. Mind it.
Yes.
The bone forming laterally, the pterygopalatine fossa is a narrow space.
The laterally the bone appears thick, boss. no?
Yes, always.
Mm,
That is infratemporal fossa wall.
Yes.
That is always thicker.
Fossa is already widened.
Yes.
Yes, thin bone is there.
The mucosa, thin bone. See the thin bone?
Yes, very thin. Very gentle and firm stroke.
Later. See the periosteal little bit of the oozing,
Yes.
and we have for that cobblator.
So it is the part that is going superiorly through the infraorbital fissure, boss.
Here
The
it
same-
is,
yes.
it is going up.
Yes.
Here.
Yes.
See here infraorbital now prominence.
Yes, boss.
Yes.
Mm.
Here at this edge, I don't want to leave any bone in between.
Right.
See this tumor, whatever extension it is one component.
In this case.
See this more tumor coming in exposure,
Yes, sir.
more surface coagulation. That's part of the antirythmoid. Give me the debrider. See, we have seen the tumor is rising towards the antirythmoidal roof in the middle. Huh?
Yes.
What I will define here, my lateral limit as lamina. Can you see? I am
Yes.
dissecting the antirythmoids.
Yes, sir. So we are gaining the superior control of the tumor.
Yes.
Right.
So I am the debrider clock. I'm gaining the superior control. I will go behind. We have seen tumor is not entering the sphenoid sinus.
Yes.
Yes.
See, the ethmoids are pretty free.
Yes.
That's a part of the middle turbinate which was attached to the tumor inferiorly, and we have
Remove it.
yes cut off already. So this will help us bring the tumor down later. See, never be in hurry to deal with the tumor.
Exposure from all the side.
Satish, when you don't get so much of space like we get, that sometimes the tumor is so big and it is coming out anteriorly through the nose.
Yeah.
So how do you deal in those cases?
Yeah, we get many of such cases. So what you do Denkers first of all laterally.
Okay.
Have a catch hold on the vessel, and then debulk this tumor a little bit.
Okay.
To acquire more space to manipulate your instrument. See my ethmoidal cavity?
Yes, sir.
Boss, have you ever combined midline degloving technique along with this?
Mid-facial degloving?
Mid-facial degloving
Yeah, earlier
technique.
many a time.
Okay.
I'm fan of that technique for many reasons, but not nowadays for JNA. For many other regions, fibrosis lesions.
We can see the skull base now.
Yes, that is model skull base.
Yes.
This is pure ethmoidal skull base. See the artery
That's
behind.
anterior ethmoidal artery.
Yes.
Yes.
That's the post-ethmoidal roof. Blocked. बंद है यार. Don't do this. Follow the tree.
You are trying to go to the sphenoid now,
Right,
boss?
yes.
Yeah, I know this tumor is not going there.
Okay.
But I have to define all around. Because later on we'll push it down.
Okay, boss.
Very soon we will catch the vessel and divide the tumor.
So that we have ample of space.
So gallbladder. See this attachment on the septum which we previously divided.
Yes.
See this periosteal attachment?
Yes.
Yes,
See
sir.
the sphenoid.
Yes.
I told you there was secretion, not the tumor.
Yes.
Yes.
Now whatever secretion, see this? Now whatever tumor I have exposed, I have to. This venous bleeding from this area is expected.
Boss, this part of the this step, I mean this part of the surgery you do before ligating the maxillary artery?
Yeah, you can do
Yes.
because it is not going to bleed anyway. much, yes, but you can postpone it until you see this region.
Yes.
Yes.
See the ethmoids and little bulge in the floor of the sphenoid. See that?
Yes.
Yes, yes.
I told you the wall of the sphenoid, the lower wall is eroded.
Yes. So that is the characteristic sign of angiofibromas.
Because it doesn't enter through the natural
Natural
ostium.
ostia.
See the tumor bulge.
Yes.
Look up later. See further septal attachment. See this?
Yes.
Such a broad attachment on the septum. More and more midline attachment, more are the chances of acquiring blood supply from opposite side.
Adjacent.
You will do the posterior septectomy, boss, here?
Yes. See now, our exposure is good.
Yeah,
Yes.
very nice, boss. Very good. Very clean field. No
Now
bleeding.
leave a small gauge piece. Okay, I will leave this area. Why I did this earlier, I tell you. When I come back, this will be absolutely clear. I'll have some time now. See this absolutely free from behind, and only posterior septectomy is required to be done to get rid of tumor from here. Yes. Now coming to the control of the vessel.
Yes. Maxillary artery.
We know this tumor is extending into infratemporal fossa,
Yes.
and this infratemporal wall from where the vessel is coming, crossing the lateral pterygoid. You have seen that day how the vessel crosses
Yes.
the lateral pterygoid on the surface of the lateral pterygoid to enter the pterygopalatine fossa oblator. So far we have not entered into the tumor. Yes, dumbbell tumor. See very clear cut tumor surface. Oblator.
So, boss, here you are using coagulating mode on the tumor and the ablating mode on the mucosal surface, right?
Yeah, whenever you have to cut.
Yes.
Even when I divide this tumor, I will use the ablation mode.
Okay, boss. So that is the crista, just the bone below the crista of the sphenopalatine foramen.
Yes. So this area is absolutely clear?
Absolutely clear.
Yes.
That is what my goal was, not to leave any chance of, problem. Now, drill. See, I will remove this part of why I expose this maxilla so much. Laterally, because we have a lateral extension.
Yes.
Yes.
This tumor is already bulging out, difficult to go into the tumor unnecessarily. And I will remove this part of the thick bone now and catch the vessel. Okay?
Right.
Yes.
Which thick bone? This one.
Yes.
forceps, gallbladder. Gallbladder. See, that is the periosteum.
Periosteum, yes, boss.
Carry sir. Section. Yeah. See this thick bone?
Yes, boss. Yes. So, what will be your lateral limit of exposure here, boss?
Yeah. Here I am little towards more and more exposure. See the fat.
Fat, yes.
Yes.
That itself answers number one.
Yes.
Fat tells you the tumor limit. So this,
Yes.
we have used couple of times. This is such a good fat as a flap, vascularized flap.
As a vascularized flap.
Yes, amazing. In OSMF cases, gallbladder there.
Some vessel is there behind.
Some vein.
So many times, boss, we can feel the pulsations of the maxillary artery through this fat.
Yeah, right. Yes, yes. Artery just behind the fat.
Yes.
I think it might be pushed above, so we are not seeing pulsation right now.
Just I'm acquiring some space to work. I'll remove more and more fat.
So how you, I mean, what is the safe limit of removing fat without injuring the artery?
There's nothing. No, the artery is behind the plane of the fat.
Okay.
You can see under vision.
So, boss, at this stage, while finding out maxillary artery, if somebody inadvertently injures it, so how to manage that? Does it also retract posteriorly or
Not
posterior
really.
inferiorly?
Not really.
Okay.
You can catch and coagulate or put a clip. Still, if it retracts. If you want me, I will leave it once and show you.
Okay, boss.
So, I mean, clipping is better than coagulation?
Yes, always. The more secure way, you are more secure that artery is not going to reopen once you have clipped. See the fat?
Yes.
This will give us more space.
Lot of fat is there. हमेशा इतनी फैट होता है कि इसमें कुछ ज्यादा ही है
होता है सर It's a good flap, I tell you.
So, boss is using debrider at a very slow speed here.
Yes. The goal is to tease out this slowly.
Yes.
Very soon you will see the vessel.
Yeah.
Yes, sir. We are waiting for it.
बंद हो गया बे? बोल। कहाँ जा रहा है?
Yeah, I think just posterior now.
See surface of the muscle?
Yes. So that's lateral pterygoid muscle.
See, looks like vessel there. No? I could see the glimpse of vessel.
So which muscle is?
So,
Carison, I could see the glimpse of vessel. Why I'm working little up? Because on radiology we found the vessel was arching up.
yes. And the vessel generally lies very loosely in this soft fat, boss, in a very tortuous way. Yes.
Very tortuous. Oh. See the muscle behind. Now we can see lateral is the temporalis muscle.
So yes, boss. So we will go between this tumor and the temporalis muscle. No? Yes.
Let me remove this bone. Munch. How later? How later? See superiorly. Now we'll retract this tumor little medial and open up this space. Okay. This
I
should
think
be your vessel.
That's the vessel. Yes, boss. Right.
Can you see the vessel?
Yes, very clear. Right. Yes.
See the big vessel?
Yes, very clear, boss. So, but it was relatively quite posterior as we usually find in routine cases.
It depends. That's why you should be able to locate it wherever it is.
And it is, we can see it is going superiorly, boss. Superior part of the tumor above.
Go there, ball pro. See?
Yes.
There's the vessel.
Yeah, very thick, thick vessel, boss.
Very big. I want to loop around. Look at this. Can you see the vessel?
Yes. Beautiful, boss. Beautiful.
See, such a huge one. Look at it. See this, everybody?
Yes, yes.
The sir?
Yes, sir. We are holding our breath.
Many of us here have skipped a heartbeat, sir, when you was doing this.
Topics are there.
All the.
One clip is already applied.
Now, harmonic will not control such a big vessel. Yeah, vessel, sealer can help it. Vessel sealer can help.
Okay.
और दे.
So
बड़ा वाला देख ले.
they have it with our laparoscopic colleagues have it now many times.
No, we have vessel sealer. You can have vessel sealer.
So how many clip you applied?
Three.
See, such a huge vessel. So we have already applied 3 clips.
Yes.
So you will coagulate now?
Yeah, still.
Okay.
Fine. On है क्या? Fine done. Funny section. See, in spite of the clipping, this being so huge. This will have a huge impact on the reducing the overall tumor vascularity. Isn't that?
Right.
The tumor is acquiring blood supply from many places, but this will have a huge impact.
So sometimes you get a tumor very much in cheek, yeah, like you can feel it also in the cheek.
You can push from
So
there.
how much exposure you'll add more in this?
You can push from there then.
अच्छा वहीं से वो सरडाना इंसिशन देखकर या ऐसे blind?
One finger
One.
and push from there.
You give an incision or blindly you push?
No, why incision? Feel the tumor and push it and pull from inside.
Okay, you have to give an incision, palpate it and then push it.
Can you see the nerve above?
Yes.
See the vessel
Yes.
and the nerve above. Can you see? Very clear?
Yes, yes.
That is V2.
Okay.
And see, this vessel is so high up. That we knew. That is our clip. See that? Hello?
Yes, sir.
Having done this, this will help us dividing the tumor in a much better way. Okay? Now, before dividing, I will take the posteromedial control.
Okay.
where you kept your watch piece.
Yes.
Now you'll have a clear field there.
See this now? Leave it. We
Go
have
to that
reduced
side.
tumor which cross the midline in nasopharyngeal attachment and too much of septal, attachments acquire blood supply from the opposite side also. So now I will do a posterior septotomy. Posterior means from the level of the anterior border of the tumor.
Okay.
So my good posterior control. See this?
Yes.
This has a huge nasopharyngeal component, we know.
Yes. Satish was in cases of DNS and nasal spur, I mean the sharp edges, does that sometimes be a problem at this stage?
Pardon?
Sometimes there is a posterior spur, nasal spur or sharp edges of the bone. So is that any problem at this stage when we are lifting the periosteum over it?
Not really. See this little bit of the spur?
With the pressure of tumor. Yes, lateral spur.
See this. You have to remove this bone in toto. Beta.
This bone is sometimes very thick.
Yes. See, I have separated on both sides.
Yes.
So in spite of the clipping of the maxillary artery, the tumor is still, it's bleeding.
That is not the
Yeah.
something completely 100% blocked. This tumor is a blood supply from many places.
Yes.
But this is not significant bleeding,
Yes, boss. Not significant in your hands, boss.
Now see, all the time our irrigation. This really helps in maintaining the visualization.
Yes.
See this?
Yes.
Now, let me open the opposite mucosa. See this? To enter into the opposite nasal cavity and nasopharynx from here. See the secretions?
Yes, sir. So that is the inferior turbinate on the opposite side.
Yeah. The brother. Why it is not working, Subrider? क्या करता है यार? Oblator. Subrider is not working. See, removing everything to reach the nasopharynx. See the nasopharyngeal component now.
Yes, boss.
Yes.
See, it is such a big one.
Yes,
Adherent.
boss. Yes, adherent. And it has very strong attachments here sometimes, no? It's very
Yes.
Mm.
See on to the
thick attachments.
nasal septum periosteum.
Yes.
See this?
Yes, sir.
What a thick attachment here. Now freed. Still there. Dikha. Okay, wait. Look now. Back is up and down. Yes. See this attachment is still there?
Yes, boss. So that is the floor of the nose.
See how important it is
Inferiorly, yes.
to separate. Separated.
Yes.
See that?
Yes, boss.
Yes.
And see, it is completely occupying the nasopharynx like a ball.
Hardly giving any space to manipulate.
Yes.
Sometimes it also gets supply from the nasopharynx also, get adherent to it.
So huge one. Let me get some more access because it is quite big there. So I will acquire some additional access. Starting.
सर जो नेसोफेरेंजियल पार्ट जो बेस अपन निकालते हैं posterior wall से sir we need to see that dissection coagulation how you're using there.
Yeah, I will show you. Yes, madam. So extra 2 minutes, I'll acquire some more exposure. I have to segregate in the nasopharyngeal roof the blood attachment and the blood supply coming, possible blood supply coming from opposite side. Rakesh. Is this tumor?
Yes.
Which is the level you're exactly using debrider on sir?
Pardon?
Septum पे ऊपर debrider कहाँ है आपका?
My debrider was coming from opposite side.
Okay.
Yes, the cobbletter. This field is the telescope is spoiled.
So like what is the depth or area where that bleeding is occurring?
Bleeding is not much. It is the scope which is spoiling.
Achha.
Yeah, it is not the bleeding which is.
This area where the cobbletter is touching, what is that exactly that area?
Yeah, that is the terminate, opposite terminate. See, I am cauterizing.
Okay. Now I'm oriented, right. So it was taking
See the opposite
attachment
side
there also.
terminate. Opposite side terminate. See.
Okay,
Yes.
right.
See this?
Yes.
See the opposite nasopharyngeal attachment.
Okay.
Here.
Yes.
Which I want to
Secure.
segregate here.
Okay.
Because this also bleeds sometimes very
Yes.
heavily. Broad base is there, taking blood supply from.
See the opposite side I have segregated.
Yes.
See this?
Very nice. Yes.
Well, Karnal. See this opposite side. And this is the
vault.
See the vessel?
Yes.
Okay.
Which I have. See the opposite side roof?
Very
Yes,
nice.
yes.
Muscle.
Okay?
Yes, yes.
Having done this,
Right.
now we are ready to divide the tumor and pull it down. I will pack for a while.
Okay.
See, this is packed towards the opposite side where I have segregated. Okay? Can you
Right.
see very clear now?
Yes, yes, yes.
So when you work so posteriorly with that, 10 surfaces anteriorly, the visualization sometimes is a challenge. So you have to overcome that. See this? See now, to orient you. That is the posterior side.
Yes,
This is the septum, septotomy. This is the rostrum.
yes.
And this is the same side sphenoid sinus. Are you oriented?
Yes, sir, yes, sir.
And this is tumor. See this?
Yes. So you will mobilize the tumor from the nasopharynx now or later on, sir?
Yes, now first I will divide.
First you will divide and then, okay.
See, the field is good.
The part of the opposite side he is already mobilized.
So we have done a major work to have segregated from opposite side, have a window to
Sir.
control the tumor from both sides.
Sir, can't we remove the rostrum here?
Yeah, I will. Before mobilizing, I will. I have already marked that. लंबा देता काट देखता कहाँ है? See that section? So things are in control now. What
Yes.
we have achieved, we have taken the vessel in control. We have, exposed the tumor anteriorly, anterolaterally, superiorly, posterior-superiorly, posterior-medially. Okay?
Yes.
Now we'll divide and take this luminal component out. And then bipolar. देखता बड़ा चाहिए क्लियर बाय क्या हुआ Can somebody do something to the bipolar please? क्या है वो टीम कोई बस बाइपोलर कौन देखेगा पूछो ना अरे इस जगह छोड़ी उसको टूट गया देख लग गया देना लेट मी चेक पानी डालना सक्शन का सक्शन करना वर्किंग और नॉट देख ले चल रही है पानी डाल सक्शन Hello.
Yes.
Yes,
So
sir.
now we come to one of the most important step. That is
Division.
division. The lateral component we have to pull then, nothing else. It is the medial component removal, which is a challenge. Tumor removal, division and medial component removal is the big challenge. See this? No. See, this is my level of the maxilla.
Yes.
I will divide at this level. So here to show you, first I am using bipolar. Can you see this?
Yes, sir.
Section and irrigation. Section. Yes. Chalo. Irrigation.
चल नहीं रही सही.
ध्यान दे कितना Can you see this?
Yes, yes.
Satish, sometimes the tumor hair is so thick in diameter that while cutting, we lose the orientation that in which direction actually we are going.
Take the orientation from the lateral wall. See this.
Okay.
See this lateral wall. Always divide at the level of the lateral wall.
Sir, have you transected the vessel maxillary artery after clipping?
Not
No, it is
really.
need to
No.
transit.
Not really.
We are far away from there.
Oh.
So after coagulating with bipolar,
Just additional, safeguard. We know this tumor is getting blood supply from many other vessels also. Additional safeguard.
yes.
Boss, such a good exposure that we can see your endoscope in your bipolar, bayonet bipolar in your suction in. So it's the exposure
That is the
really
beauty
matter
of
at this
Denker.
stage, yes.
That is the beauty of Denker. Impossible. Without Denker, it is impossible.
Sir, can we use a harmonic scalpel here?
I don't.
Recommend.
Yeah,
Okay, okay.
that may not be so effective in this arterial bleeding. ला, पकड़ इसको, coagulator. See now, I will use my coagulator. Coagulator cannot control the big vessels,
Right. So you will use coagulator here in an ablation mode and coagulation in between.
Yes. See, this is coagulation right now.
Okay.
Major surface coagulation is done by bipolar. Then
बंद करके देखना. See now, ready to be divided?
yes.
See my level of the lateral nasal wall?
Yes, sir.
Yes.
जल्दी करे यार. अरे 2 मिनट चाहिए. Ready?
बहुत अच्छा.
So ये किस मोड से कट हो रहा है?
Cutting.
Cutting.
Now coagulating.
Coagulation.
Now cutting.
अच्छा.
After coagulating with bipolar, you are doing with ablation.
Yes.
In between, you are coagulating if there is some bleeding.
Yes. पकड़ आगे. आगे से पकड़.
So
See the tumor surface?
Yes.
I hope you are oriented.
Yes, yes.
See this?
Yes, boss, we can see beautifully done, and there is no significant bleeding even you are going through the tumor. So we can
Yes.
imagine had the maxillary artery not clipped, what would have happened here? But the exposure you are getting and the assistance is marvelous, boss.
The exposure is the key.
Yeah.
So far, we have been wasting time on exposure. See my reference of the lateral wall. Never leave that.
Yes.
Don't poke here and there.
Yes.
Straight in the straight line. See this? See this lateral wall?
Yes. Yes.
Yes.
boss. We are almost at the posterior limit of the tumor now. You are?
See just coagulation. This is ablation.
So,
Now, let's pull it down.
that's beautiful, boss. I think it's done, boss. Great.
See, let's see. What section? This is the superior component, you know?
Yes.
That was bulging.
Yes. Now you
I'm
taking
pulling it down.
Yes.
See this?
Yes.
Yes.
Yeah. Suction. Suction block. Come on. Sit. Back up to that.
All frustration coming.
Yeah, just a minute. Just a minute. Don't worry. See this component. I'm pushing down. See this under vision.
Yes, yes.
Just a minute. Let me show. Upper section. Kar. This component is being pushed down. See this?
Yes.
Pack. Give me a pack, a small pack above.
It's active bleeding here.
No, not. In the endoscope, it looks.
Okay, big.
So now the only attachment that is left is to the nasopharynx
Nasopharyngeal
periosteum on the right side.
Left already.
Left
Yes,
has
yes.
already been done, yes.
Either section. Either. See, that's a maxillary sinus. That's just accumulated blood, nothing else. Now, this tumor, which is pushed in behind, has to be removed, you know, because this is too big. The challenge is the size, you know.
Yes.
This is irrigation. That's nasopharyngeal roof.
Yes.
See the nasopharyngeal roof?
Yes, we can.
And now is the time to remove this rostrum and show you. See my patch from the opposite side coming up. That tells me the level.
Yes.
And Allah. Give me lux. See? Things are under control. Now I am removing this.
Rostrum.
Yeah, part of the rostrum.
Satish, why you removed this rostrum at this stage?
Pardon?
Why you remove this rostrum now?
Because that gives me an idea of the interior of the sphenoid now. See this?
Okay. All right.
Yes,
See now?
that is clear.
All right.
a clear-cut idea that I have gone down. With us?
Yes.
See, the tumor is now
Yes.
below the level.
Observe.
See above. Suction, yeah. Come on. See, the suction is the main important key here. That the inferior wall of the
Sphenoid.
yes. See interior of the sphenoid?
Yes.
A tumor is limited here below.
Yes.
Can you see? Venous bleeding is also expected once you.
Sir, is this the posterior septal branch of sphenopalatine?
Not really. We can't say.
As
It
it
is not
is-
the arterial bleeding for that matter. Now, hold this. Now see, I am separating from the nasopharyngeal roof now.
Yes.
See why I remove the rostrum at this point to orient. You know?
Yes,
Point
sir.
all over, point all over. Now, this is the nasopharyngeal roof.
Yes, yes, we are very well oriented.
Yes. Yes. Can you see now?
Yes, yes.
This tumor being separated now from the nasopharyngeal roof. This is periosteum. पानी नहीं आ रहा है यार कॉबलेटर में क्या करते हो तुम एंड टाइम पे यार नो इरिगेशन द कॉबलेटर कम ऑन
रुक गया उनका।
You know, this
Raise.
part also sometimes trouble.
See, I stopped because the cobbleter had, no saline coming. It was dry.
There is a sputter in there.
See this?
Yes, sir.
The moment
Yes,
it
sir.
is dry, I will push it down.
Yes.
Suction cobbleter का suction नहीं चल रहा suction नहीं चल रहा वो बंद हो गया ना dry से see the picture
Yes, yes,
Yes,
very
sir.
clear.
so keep yourself oriented Rakesh
Yes. So we can see the salar floor and the paraclival carotid and the clivus there in the sphenoid.
oh, yeah.
Even above the optic.
give me cobbleter come on at end time पे सब बंद हो रहा है तुम्हारा
Suction band.
see here I am dividing
Yes.
see my lateral wall bone
Yes.
Yes, yes.
because that we will remove in the
That's the palatovaginal foramen.
yeah and here the venous bleeding is always expected from the sphenoid foramina.
Yes.
See the traction below
Yes. And separating.
and we are cutting through the periosteum. This tumor is never attached to the adenoid surface. Always to the periosteum. See this? See the opposite Eustachian tube?
Yes, sir.
Very clear or not?
Yes, sir.
Yes, sir. Yes.
See the adenoid surface below?
Yes.
It is just the traction which is allowing me to cut. The thick periosteum. See that thick periosteum.
Yes.
Now I will cut this periosteum of this side. Elevate this tumor from this side. See this periosteum. See where my see this little bit of the periosteal contact.
Tag is there.
See, little bit of the periosteum. Yeah, see this.
Yes.
And then I'll be through. See if it is free or not. No, अभी भी थोड़ा बहुत है शायद. Let's see. Let's see whether tumor is free or not from all around. See, such a huge component. So no. It's free. Yeah, yeah. See the vessel there?
Yes, sir. Yes, sir.
See the bleeder, doesn't matter. दूसरी लाया. Her cobbler is not working, my dear. Hey, come on.
आप
क्या हो जाता है तुमको एंड टाइम पे? See the cobbler is not working. It is free.
Sir, that site is not appropriate for applying lighter clip or you prefer cobbler?
Pardon for applying?
Sir, bleeder के ऊपर lighter clip applying के लिए you prefer cobbler or that site?
That is not such a big bleeder.
Okay, okay, that is the reason. Might be the posterior branch which you showed.
Yeah, yeah. In a second's time it will
come out.
Well, cobbler will work.
Okay.
See the cobbler, it will stop working that time. See now?
Okay, okay.
Pani dal. See now it's free?
Yes.
Sir.
See this is nasopharyngeal adenoid surface.
Okay.
Yes.
Avoid the sphenoid sinus.
Yes, sir.
So upside down you approached.
That is the sphenoid sinus. रुक जा पानी मत डाल यार. See this?
अब बढ़िया दिख रहा है.
Yes, sir.
Now it is tamed.
So it is division of the tumor which is the key.
Yes.
See now the midline component all the way.
Yes, sir.
Absolutely dry.
Yes.
Very nice.
Give me a pack here. At the nasopharyngeal surface, little bit of the oozing would be there where I cut the periosteum. And that will be controlled. See everything under control again.
Very angry.
So the difficulty was handling such a big component, you know, in a narrow space. See the picture now.
Yes.
We'll open, remove from the oral cavity. Suction. Sir, आप ट्राई कटा है. No. Suction. Yeah. Can you see this tumor?
Yes. Huge.
Huge one.
Applause. Big applause for you.
Great.
See how big it is.
Yes.
See this?
Yes, yes, yes.
So now what we have achieved, see this. See the anatomy again. Now whatever is left will come out easily. We have ample of space now. See this?
Yes, sir.
In spite of this tumor being so vascular, see no bleeding now?
Yes, not at all.
See here. Here I segregated from the opposite side. See this? At this place. The cobbler there.
Here always brisk bleeding when you separate.
Yeah, that is always periosteal ooze. This will go in no time. And this bony, see, sphenoid bone is such a bone with a lot of venous channels passing through it. See this venal bleeding here?
Yes, yes, yes.
Don't bother about that. I will pack something over there. See this adenoid surface below. It never gives attachment. See this?
Yes, yes.
It is only the periosteum which gives attachment. Fine?
Yes, sir.
See this bone here? Now this is the pterygoid bone and this is the tumor into it. See this?
Yes, yes. This part
See the
is right.
sphenoid is pretty
Yes,
clear?
yes.
Yes, sir.
सक्शन करनी चाहिए इतनी देर में तो रख देनी रख दे C for lower down for the surface, that is the pack. Okay, and for this venous, give me small. I just push a small surgery cell.
Surgery cell.
Gauge piece. इसी को रहता है. See that?
Yes.
That will take care. Now no bleeding.
Yes, sir.
Now coming to the lateral part. Now we have three things left. One is this component in the pterygobaltine fossa and this in the infratemporal fossa. See this, it has gone down like this.
Right.
These two, then we have a component which has gone up in the orbital fissure. See that?
Yes, sir.
पकड़ना सक्शन कर ले पूरे को yes yes see this component
Yes, it is coming.
बोला ना one piece that is going into the orbital fissure. See now I am removing this wall. Madam was asking that time.
Yes, sir, nicely seen.
I am removing this bony wall of the fissure. See this component?
Yes, sir.
Forceps. See now, wherever you go to the skull base, venous bleeding is likely. See this component. See how much it is going. Completely being pulled off. See that?
Yes.
This is your maxillary strut.
Okay.
And where we are removed from? This is your superior orbital fissure.
Okay.
Action दे यार. So तू पकड़, छोड़ मत उस. Don't do that. छोड़. बस पकड़ उस. See that? That is the periosteum of the. पकड़ उस. See that is the periosteum of superior orbital fissure. हल्का हल्का.
Sir. Sir.
Yes, please.
Where is the V2 here?
V2 is just below this. We'll come to it. See this. Now, this is the entire pterygoid process below.
Yes.
See this?
Yes.
This is full of tumor. Above we have removed from the
Okay.
superior orbital fissure. See the periosteum. Lux there. See the wall of the superior orbital fissure?
Yes.
It is said that you should not put a surgical or abgel there, otherwise blindness might occur.
Yeah, if you tightly push.
Okay, okay.
You have to
Lightly
push
we
to
have to
stop
do.
the
Bleeding.
Don't push tightly. It's a narrow space. See this. See the superior orbital fissure above. That's the periosteum which I pulled off. Hold on. And this is not tumor, this is the periosteum which was broken. Good. See this? That's the normal periosteum. Can you see?
Yes.
This is the medial
Yes,
wall of the
yes.
superior orbital fissure.
Yes.
Yes, sir.
And the tumor is
Absolutely
out from
clear.
there.
Yes, sir. So that
Yes.
is a Vidian canal just
It's below.
inferior. Yes.
It's far below.
Yes.
Section. Everywhere.
Beautifully done, boss.
Now reorient. That's sphenoid sinus. See that? That's the part of the superior orbital fissure. Yeah, keep it like this. Now we'll remove the tumor from the.
Infratemporal fossa.
Yeah, you were asking about the V2. V2 is there. Hello.
Yes.
Yes, sir.
नहीं इधर से पुल करना इधर हाँ see the V2 there.
Yes.
Yes.
Sometimes it may take this path also, sir. V2 के through भी जा सकते.
पकड़ लो. Yeah. See now the lateral component. इसको पकड़ो. इसको पकड़ो. See, that's the tumor.
Yes.
Can you see?
Coming out, yes.
Yes, yes.
Oh, the vessel opened. No issues.
You wanted to do that, but
Rajiv wanted. See this? That's the
Yes,
tumor.
that's the infratemporal part of the
That's the infratemporal
Yes,
component. See?
yes.
Being dissected. And separated the V2 from the tumor.
Yes. So the V2 is going forward. You can see separately.
Yes.
Yeah.
so sometimes the tumor goes through this V2 canal also up lesson.
Really.
Rarely.
Clip लगा दो. See this inferior part of the tumor. See such a huge tumor. Give me cobbletter. Don't worry. और इधर से पकड़. See that's a simple pull. यहाँ से पकड़. See this?
Yes.
Yes.
And now with the cobbletter I will separate it. See the simple dissection and see the vessel below.
Yeah, that's greater palatine.
अरे यार. See, this is our main vessel again.
Yes, sir.
Here.
We can see, sir, right.
See, the tumor has been completely pulled out of the infratemporal fossa.
Yes.
In plane, can you see?
Yes, sir. We can see the pterygoid wedge also now clearly.
Very clear.
Very clear.
See, this is traction and counter traction. That's it. Yes, traction. See now,
Yes.
tumor being elevated completely. Just a matter of traction and
So you're using it just as a dissector, the cobbletter wand.
yeah, in between. See my nerve. Oh, छोड़ दिया छूट गया yes and now see
Yes. It's very clear.
and this is the main vessel again. See the main vessel. Oh.
Wow.
Leave it, leave it. Give me a pack. We'll come there later. Yeah. See the things, the anatomy.
Yeah, we can see that.
Hello.
Yes, sir.
When everything is in front of you.
Yes, we can correlate it with the cadaveric dissection day before yesterday, boss.
See my nerve there.
Yes.
Yeah, V2. V2 is going into
Cobbletter. Yeah, that's the V2. See the V2 going to the foramen rotundum.
Yes.
See that?
Yes.
and just medial to that is Vidian canal, no, boss?
Yeah. See the V2 is left.
Yes.
See the V2 is left there.
Separate, yes, yes. boss.
Yes.
And now rest of the tumor is in the pterygoid.
Yes, that's the pterygoid wedge, right?
All this tumor is in the pterygoids only. See this?
Yes, yes.
We have broken and taken out. See this? See this huge component again.
Yes. And you will drill
Now
out
the
the
pterygoid
pterygoid.
component. Now the pterygoid component will be dealt with the drill.
The drill, yes.
And see, always there is pterygoid venous plexus using.
Yes.
See that?
Yes, sir.
So last part of the tumor left is pterygoid. Right?
So, boss, do you recommend that even if it is not involved, drilling in this part later on?
On slightest doubt on MRI basis, you have to take a call.
Right.
Leave behind,
So-
it is going to come back.
Yes. So ideally, it should be a dictum that we should drill it till we
If
get
it is
a normal
involving,
bone,
if
yes.
it is involving.
Sir, according to the latest theories, they say you always drill it.
Yeah, because this is the most common cause of
Recurrence or residual.
Yes.
Yeah, it is the site of origin also.
Yeah, according to the latest theories.
Leave it, leave it, leave it, leave it. No irrigation. See now, that last region left is the pterygoid. बोल ना यार.
But it's beautiful to see nowadays such huge angiofibromas being done endoscopically. I remember when in SMS days we used to do maxillary swing approach for angiofibromas like this.
Yes.
Such a morbid approach and such a big incision on the
Now
face
see.
for benign
Now
tumor.
see, that's the V2.
Yes.
Yes.
And what is there infromedial to it? Is the median canal.
Median canal, yes.
And see the region of the median canal. It's totally occupied by the tumor. It is destroyed. See this?
Yes.
That is all tumor. See this? Let me remove this tumor first. will not stop bleeding otherwise. Now see how to deal with the pterygoid process. Last part. See, this is pterygoid bleeding. See this?
Yes.
Our V2 is left above. Now this is the body of the pull this gently. पकड़ने वाले थे यार. साफ कर. This is the last one. देना क्यों? जरूरत नहीं. हाँ. Can you see this tumor?
Yes.
Yes.
Yes. In the median canal. Yes.
If this cancellous bone.
Yes.
What I will do first, break this, open up this bone. ये क्या आ रहा है?
Yes. Bleeding.
Doesn't matter. There's little bit of the bleeding. See this?
Yes.
नहीं पकड़ रहा यार. Forceps, give me a good forceps to have a catch. वो कब डजन है यार जो पकड़ते गधे हो यार. See this, pull it.
Okay, such a big size in the pterygoid wedge, sir.
See this, pull.
Okay. My goodness.
See this, pull.
Yes.
So it is almost remove the tumor. Rest we will see with the drill. That is the sphenoid unnecessarily removed. The debrider. Don't do that. Come on. So my tumor is almost out, and then I will show you
the anatomy.
How to deal with the pterygoid. This mucosa are unnecessarily removed. See this pterygoid fossa. See this cancellous bone, it was invaded by the tumor. Hatai?
Yes.
Hatai? See this?
Yes.
Yes.
And this is pterygoid venous bleeding. See that?
Yes.
Look. Now I will completely ensure that this area is completely cleared of the tumor. I am waiting for my drill.
So how much deep from this area do you expect carotid?
Carotid, I told you from the pterygoids yesterday, from the
1
lower
centimeter.
edge 2 centimeter, upper edge behind that is the sphenoid body, and then the sphenoid. See this sphenoid body, and then the sphenoid sinus, and in the posterior
Then
part of the
posterior.
sphenoid.
So you can drill it safely,
Yeah,
sir.
very safely. Give me that drill. देने में 1 घंटा लगा. Give me just.
It's bleeding, but it's good amount of bleeding is coming.
Left पर देना. Raise. See, now I am not using the coarse diamond. See this. Hello.
Yes, yes, sir.
This is a pure diamond because
To
I
stop
don't
the
want a
bleeding.
coarse diamond. I want to stop bleeding also.
Yes.
ऊपर डाल पानी. उधर. अरे यार. पानी डालना राकेश. हो गया क्या? This is pterygoid venous bleeding.
Yes.
Venous bleeding is a welcome bleeding, you know. What I am doing, I am flushing this entire bone.
Okay. So what is the end point of drilling here when
You will
you
see
decide?
the flush bone with no tumor. Very soon you will see. Come, come. Super. See, below in this fossa is the muscle, medial pterygoid.
Yes.
You don't have to bother about that part. It is the upper part of the pterygoid which is, involved with the tumor. Action भी कर फिर.
Hold the ears.
Give me wash. See now.
Yeah.
See the sphenoid sinus, see the body of the pterygoid,
Yes.
and see the V2. See the V2?
Yes. Yes. Very clear.
That is our upper limit. Now see the body of the pterygoid. Do you expect any tumor in this now?
No.
देख सकते हैं अगर. Now give me the lux.
So sir, can you tell us the width and depth of the boundaries, all what we have removed?
Width and depth of the?
So the lateral limit, the medial limit, superior and inferior, what we have done.
See,
for the anatomical.
Till you find the tumor.
Right.
And I don't see any tumor in spite of, see this, all this. See very clear?
So the deeper internal carotid artery branch was going to which part? So the nasopharyngeal part?
That was to the nasopharyngeal component. We are already removed.
Okay.
See this. That could be the branch which was bleeding, if you remember, which we coagulated.
Okay.
Drill. See, Rajiv, you are asking when to?
Yes, sir. When
And
to
the
stop?
drill.
Stop. Yes. What's so now it is flush, edges are smooth.
Yeah, you have to rule out any possibility of tumor. Now see below is what? Pterygoid muscle. See this? This is
Yes.
the lower compartment. Yes, sir. Oh, बढ़िया. We have not transfused even a single unit yet. Thanks to our anesthesiologist for giving me the good field. He loaded with a almost how much was? 1000 ml? Yes. So he preloaded with 1000 ml fluid.
So where is the eustachian tube on the operated side, sir?
Yeah, it is there.
Where? Okay, here.
See, this is eustachian tube.
Right.
This is eustachian tube.
Okay,
See the opening.
right. So just take it.
You don't have to do anything to the second tube. What we have seen is our now pterygoid is absolutely free.
So you are almost at the level of the this petrous foramen lacerum type now. boss.
Yeah, it is behind there.
Yes, yes. If we
See
keep
this
on
bone
drilling
is
there,
pretty
yeah.
clear. This bone, see this thinned out. This bone, see this thinned out.
Yes.
That is the temporal dura.
Yes.
Can you see above the
Yes.
V2?
Yes. Yes, boss.
I showed you in this section if you remember.
Yes.
The bone above the V2, that is temporal dura. What's my point?
Yes.
This is V2. This is,
Foramen.
and this is your superior orbital fissure. See that?
Yes.
Yes.
Boss.
See the same anatomy we saw in the cadaver. This is V2. This is maxillary strut. This is your optic superior orbital fissure. Where the tumor was going to.
Yeah, that's the greater wing of sphenoid laterally, boss.
Yeah, see the same anatomy what we have seen on cadaver. That's the beauty of understanding the anatomy. That's why cadaver dissections are most important. Repeated cadaver dissection to orient again and again. Anybody see this? Now, if somebody says, here's the tumor extension in the superior orbital fissure. Have you done the basic dankers? What is great in removing the tumor from the superior orbital fissure? Nothing, you have to just pull it. Tumor gone in the temporal lobe. See, from here it goes into the temporal lobe. From here. Eroding this bone. Widen that bone first before removal. Widen that opening and pull it out.
Right.
See, this is V2.
Yes.
And I will do something to the vessel again because suction. Forceps, a clip ready in case required.
Bipolar, just bipolar it was. Yeah, that's the site where the blood is coming.
That's the vessel.
Yes.
See the vessel?
Yes.
Give me a clip. See this vessel?
Yes, boss.
Once again, don't take a chance and put a clip. Forget about it. See this?
Yes. The lower part is still bleeding.
One more. See this vessel below? Give me the clip. Hold this. Hold this. Can you see the vessel?
Yes, we can see the lumen of the vessel also now. Oh, you got beautiful hand coordination. I mean, as if your hands are made for it. But this looks easy, but the space here is really compromised to put a clip.
Yeah, now, but we have now. I will make more space now. This time. See, this is the vessel. See the vessel?
Yes, yes, sir.
We'll pull it much better and see now. And see this? Once you have got this kind of exposure, you can do anything. रुक जाओ नहीं एक और दे दो See this?
Yes.
Still I'm not happy. Give me one more.
Yeah, done. Great, boss.
Nice surgery, sir. It was an enjoyable surgery.
Thank you for your
We all
attention.
have learned so many things from you.
It is in endoscopic surgery, you have to follow certain principle. And radiology is most important.
Like doing the complete job.
This is just pterygoid venous bleed. See this?
Okay, okay.
Now you can control simply. Problator.
Yes.
Acha.
See, pterygoid venous plexus can be anywhere.
So this is the coagulation mode or coagulation mode.
Coagulation.
So after this, boss, I think hardly there's a need to put any nasal pack after such a
But
massive
no,
surgery.
we'll keep for catheter. I told you the region. Yeah, now, see, there's nothing. Give me a wash.
This pterygoid drilling was very good, sir.
That is most essential
Very
part.
nice.
See this pterygoid.
Acha laga dekh.
Have you not remember the CT scan I had shown you?
Yes.
This was the area where the tumor
Such a
was.
good correlation we can do in this case.
Very good.
And even the superior orbital fissure, the component which was going there was also
Yeah,
nice to see.
you were asking, you were
Yes.
concerned about how to remove that.
But you have done some exposure, you have not blindly put it.
Never.
Medial wall
Never
you have
pull anything.
exposed.
See what happens in the inferior most part of the superior orbital fissure.
Yes.
If you pull anything blindly, in the inferior ophthalmic vein.
Okay.
The inferior most component in the superior orbital fissure is the inferior ophthalmic vein.
Yes.
So never pull anything there blindly. Expose, have a catch hold on the tumor. See no bleeding?
Yes. So
there
maxillary.
was some blood loss. I don't know, 200, 300, 400 ml, whatever. But we have not transfused. Are grateful to our anesthesiologist. See this?
Yeah. Satish, was in case there is bleeding from superior orbital fissure,
Just
how safe it is to if we use this coagulator in coagulation mode or-
Superficially, low current you can use.
Okay.
Sir, one small request, sir.
Yes,
Sir, आप इतना अच्छे से anatomy expose है, can you reorient the audience? क्या क्या दिख रहा है कहाँ पे? It
So,
is.
okay, let me.
Yes.
I was pushing lastly this piece of Surgicel in the bed.
Okay.
See this? This is always a good strategy. So, as far as the anatomy, this is our nasal cavity at the beginning. This is the lateral wall of the nose. That's the maxillary sinus interior. Here, medially is the pterygoid process. And just behind the pterygoid, just anterior to it, this was the pterygobaltan fossa, the narrow space. And all this lateral space is the infratemporal fossa. And all these muscles, neurovascular structures. Above is the orbit. Here, this is the V2. This V2 going there.
And just above the V2 is the maxillary cleft.
Yeah, this is maxillary.
Maxillary strut.
Strut. So it is below V2 or?
Above V2 is the maxillary strut,
okay,
separating it from superior orbital fissure.
Superior orbital fissure. Okay.
Okay, and this is superior orbital fissure from we remove the tumor. And above the superior orbital fissure is going to be the optic strut separating it from the
Optic nerve.
optic nerve. So optic nerve is always above. The level of the sella.
Okay, sella.
Sella, paracellular carotid.
Very good.
And this is superior orbital fissure. See continuity.
बहुत बढ़िया दिखा दिया सर ये. This is brilliant.
So never disorient from superior orbital fissure.
ठीक है. Thank you.
Thank you. So this is sella, clivus, paracellular carotid, anterior to its superior orbital fissure. Above here is going to be the optic nerve and the optic strut.
So my PG is asking inferior orbital fissure कहाँ चला गया?
Pardon?
Where is inferior orbital fissure gone?
Inferior orbital fissure. See, inferior orbital fissure leads to the orbit. Now, this area from where this V2 is going anteriorly, leading anteriorly, this is the inferior orbital fissure which we have already widened to expose our orbit and superior orbital fissure. See, this is orbital floor. Above the inferior orbital fissure is what? Orbital floor. Hello?
Yes, yes.
We have already exposed that.
Right.
Exposed till superior orbital fissure.
Superior
See, this is
orbital
orbit.
fissure.
See, this is superior orbital fissure.
Yes.
We have already exposed the orbital floor.
Right.
So it is uncovered.
Uncovered. Thank you.
So our next case is going to be a subtotal petrojectomy and implantation.
It was very good, sir. अच्छा लगा देखिए sir.
The next case is a very interesting 4.5-year-old child having CSOM, having cholesteatoma, prelingual deafness. You know, speech development time is very less now left. Has a bilateral, ear disease.
अच्छा bilateral disease है.
Yeah, bilateral profound deafness. So we are going to take up the cholesteatoma side, so to treat the cholesteatoma as well.
I think it's a 5-year-old, no?
4.5.
4.5.
चल भाई, try to धोखे पैक कर दे. Thank you once again for your attention. Thank you, Dubey sir.
Sir, thoroughly enjoyed.
Thank you so much,
really,
boss.
It was a treat to watch. And I think next case is also very thrilling for us, and we are waiting for that.
At what time?
Good afternoon, everyone. Now it's time to declare results for e-poster presentation and paper presentation. I will like to request Dr. Ashok Kumar sir to come on stage to distribute the prizes for the e-poster presentation first. The chief judges of our e-poster presentation were Dr. Ombir Singh sir and Dr. S.C. Joshi sir. So any guesses for the second runner-up prize for e-poster presentation from audience? So second runner-up prize is shared by Dr. Divya Garg from NIMS Jaipur and Dr. Manupreet Kaur from Faridkot. Dr. Divya Garg and Dr. Manupreet, please come on stage. Dr. Manupreet. And our first runner-up for e-poster is Dr. Diksha Sharma from Jabalpur. Dr. Diksha Sharma from Jabalpur. Can you guess the first prize winner for e-poster presentation? Dr. Rosie Saikia from AIMS Rishikesh gets first prize for e-poster presentation. Congratulations, lots of congratulations to all our winners for e-poster presentation. Rest of the participants can get their certificates of participation from the counter. Now I request Ashok sir to felicitate our chief guests, Dr. Preetham Arora sir. I request Dr. Sangeeta Agarwal ma'am to please come on stage. Dr. Kavita Sachdeva ma'am to please come on stage. Thank you, sir. Now I request Dr. SP Dubey sir to please come on stage and to give to distribute the prizes for the winners of poster presentation. Paper presentation. The judges for the paper presentation were Dr. S.C. Joshi sir and Dr. S.K. Verma sir. So second runner-up for paper presentation is Dr. Diksha Rani from Faridkot. Congratulations, Dr. Diksha. First runner-up for a paper presentation is Dr. Loveleen from Faridkot. Any guesses for the first prize winner for paper presentation? It's Dr. Simran from Faridkot. Now I request sir to please felicitate our chief guests and the moderators. Dr. Ombir Singh sir, please come on the stage. Dr. Rajiv Kapila sir. Dr. S.K. Sharma sir to please come on stage. Dr. S.K. Sharma sir. Thank you sir. Yes, sir. I request Dr. Ashok sir to felicitate Dr. Joshi sir. Thank you sir. Now I request Dr. Ombir Singh sir to for the lecture presentation.
Of benign tumor of middle ear. Very interesting 4 or 5 cases. Every one of you have must encounter during your practice. झांसी वाला कहीं लिखा हुआ ये वाला ये ए वाई झांसी हाँ ए वाई झांसी वाला है ना ये हाँ? हाँ ये वाला देख लो कौन से पे चले देख ये वाला हाँ हाँ रुक दो जब मैं कहूँगा शुरू शुरू से कर देना उधर उस पर जोड़ दो हाँ हो गया कर दो उधर प्ले कर दे प्ले हो गया this case was of schwannoma of the middle ear, probably was arising from the tympanic branch of the glossopharyngeal nerve. You see that this is the tumor mass gradually dissecting from the middle ear. Very firm mass was attached to the promontory, and with the ball probe it was dissected and was removed into toto, and you can see that there was an erosion of the promontory. There's a big hole was in the promontory, bony erosion by the tumor. Ossicular chain was otherwise intact. You can see stapes and malleus incus. The ossicular chain was mobile. Cortical mastoidectomy was done. It was absolutely healthy mastoid. The only tumor was limited to the middle ear space with erosion of the promontory. So this is the tympanomeatal flap which I raised before removal of the tumor just for the demonstration. Patient has history of recurrent vertigo and ear discharge with hearing loss. Attic, everything you can examine up to the eustachian tube was clear from the disease. And the defect in the promontory was repaired by using the conchal cartilage graft and temporal fascia. There's a big defect. The piece of the conchal cartilage was used to fill the defect in the promontory, and temporalis fascia was placed, 2-layer repair, and this is the final outcome. The tympanic membrane defect was repaired with temporalis fascia. This is the case, have a history of tinnitus, pulsatile tinnitus, intact tympanic membrane, post-oral incision, tympanomeatal flap is elevated and canaloplasty was done. You can see a reddish fleshy mass filling the middle ear. Then ball probe is used along with adrenaline shock cotton ball, and the whole of the tumor is gradually dissecting from the promontory. You can see adrenaline shock cotton ball is used for dissection of the tumor, and the whole of the tumor was removed in single piece, and hemostasis was secured. Hypotympanum also was examined by doing a canaloplasty, and bipolar cautery was used to cauterize the feeding vessels. Ossicular chain was intact and mobile. This is malleus, incus, and stapes. This is the attic area. The each and every corner of the middle ear was examined. Cortical mastoidectomy was also done. and free flow of the water was achieved. And this is the final outcome. We did not damage the tympanic membrane. We removed the tumor in toto without damaging the tympanic membrane. And patient has an immediate post-op recovery of tinnitus. She was so happy. This is the another case of patient has a tinnitus and a mass in the superior part of the middle ear. There was a bulge in the upper part of the external aortic canal, and the large lytic lesion on CT scan, which was all tumor was drilled out. This was an osteoclastoma of the temporal bone. You see that middle ear was spared, incus and malleus was intact. The whole of the tumor was anteriorly going to the this temporal fossa, was removed completely. Tumor was removed and it's turned out to be osteoclastoma of the temporal bone. The bleeding was controlled, and this is the tympanic membrane and tympanomeatal flap. Temporalis fascia was used to cover the upper part of the attic and part of the cavity, and the whole of the cavity was filled by temporalis fascia, temporalis muscle flap. Since last 2 years, patient is doing well. His tinnitus has disappeared and he has almost normal looking ear. This Surgicel. And this lytic defect was filled with temporalis muscles flap. This is another case. You can see that the red mass behind the intact tympanic membrane. The complaint was tinnitus. Again, tympanomeatal flap is elevated, and as soon as you elevate the annulus, you can see the reddish fleshy mass filling the middle ear. Care is taken not to touch the mass when you are elevating the flap. The whole of the flap was elevated, and you can see the tumor nicely coming out. Cotton ball with ball probe, a gentle dissection. Keep on dissecting without breaking it. Yeah, these are the very rewarding cases, good for practice. Patient has immediate symptomatic relief. Was sinus dissecting from the sinus tympani, then going to the hypotympanum. Adrenaline saw cotton ball is used for dissection. And again, in this case, the feeding vessels was cauterized by using bipolar cautery. These two tumors were glomus tympanicus. One was osteoclastoma and first was the schwannoma. So these are the 4 cases which I just want to share with you. See, this absolutely bloodless fill. And you can see each and every corner of the middle ear. Annulus of the malleus you can see, and ossicular chain was intact. This is the eustachian tube. Ossicular chain is intact. Hypotympanum is clear of the disease. And this is the tympanomeatal flap, which we were able to preserve. If there is a minor perforation, can be repaired with temporalis fascia immediately. Thank you very much. These were the short presentation of some good cases, benign tumors of middle ear. We have done few bigger cases like the grade 3 or 2, this glomus jugular. So this was the grade 1, type 1 glomus tympanicus. If any question or any query, I'll be happy to answer. Osteo? Yes. Patient has a tinnitus, then a bulge in superiorly in the canal wall. At the roof of the canal wall, there was a bulge. Patient was from another place. He came to me with a large lytic lesion in the CT scan. Then he went to some government hospital. They took biopsy. So beforehand, before doing surgery, I had a biopsy report in my hand that it was a osteoclastoma. So we removed the tumor. It was a quite vascular and soft. Remove the tumor, control the bleeding, and fill the defect by temporalis fascia muscles. Patient is absolutely symptom free. It's 2-year follow-up. He has a normal hearing, tinnitus has gone, and his canal wall is now looks nice. I don't think he's doing well. There is no complaint, and we discuss with pathologist. He say it's nothing like a malignant component or any. It's not aggressive one. So we were just having a regular follow-up. Thank you.
वर्मा सर हो गया आपके केस बहुत अच्छे तरीके से जा रहे हैं आप अच्छा अच्छा चलिए बेस्ट ऑफ जर्नी अरे वाह वेरी गुड बहुत बहुत धन्यवाद चलो अपने आप लिस्ट पढ़ते हैं मीटिंग करेंगे आपके साथ इसका करोटेड है
Now I request Dr. Rajiv Kapila sir to please take a small lecture.
इसी के ऊपर रख दूं?
Yes. यहाँ से So, good afternoon. So, I'll be presenting shortly about two most commonly performed techniques for cochlear implant surgery. That is classical posterior tympanotomy approach and Varia approach. So most frequently used technique by the most surgeon is classical technique, which involves, as we have seen, cortical mastodectomy, then posterior tympanotomy, and then through the facial recess, the electrode is inserted inside the cochlea. So we have already seen the beautiful demonstration by Dr. Satish. So I'll just see. So what we do in that is we do a cortical mastodectomy first. Then we identify the short process of the incus here. We start thinning the posterior canal wall. And we try to identify the Herald cell here. So that's a Herald cell. So then once we reach the Herald cell, we then take a smaller burr. And there you can see the chorda tympani impression here. That's the chorda tympani there. And that is the facial nerve here. So that is our area of drilling. And that is the incus buttress, and that is the opening of the posterior tympanotomy there. All right, so once we open it, we are head on at the incudostapedial joint. You can see the joint as well as the stapedius tendon. And then we start extending the posterior tympanotomy inferiorly, preserving the facial nerve. And here the bone over the facial nerve should be preserved. And it should, the sheath of the nerve should not be exposed. And then now see here, what I'm doing is I'm inserting my burr from my left hand, from superior to inferior, so that my shaft does not touch the facial nerve. So that is the inferior most part of the facial recess that has been exposed. You can getting the view of the round window now. So that's the round window here. So that is what we do in posterior tympanotomy, right? So that is the final picture after our exposure. So what is Varia technique? Varia is a technique that was designed by Professor Trifon as an alternative approach to this classical technique. He named this technique after his city in Greece in year 2000. And it is a non-mastodectomy approach where the electrode is threaded via transcanal tunnel shown by this line D into the cochleostomy site here. So, so this is the CT scan picture of how the Varia technique is done. A small well is made here, and the tunnel along the posterior canal wall is made, and the electrode is directly passed inside the cochlea. So it gives a very direct access to the cochlea. So what is Varia technique? Varia technique, I'll just show you a video here. So a classical Varia technique is done by end oral incision. However, many people are doing it with a post oral incision also. Then a posteriorly based incision is given in the posterior canal wall from 6 o'clock to 12 o'clock, and it is joined with your end oral incision.
So, and this endoral incision is extended upwards, and similarly we raise flaps, our skin and periosteum flaps are raised, and then we give 6 o'clock and 12 o'clock incision, and a posterior tympanomeatal flap is raised just like we raise in our Stapes case. You can see the chorda there, and the beauty of this technique is this gives us a panoramic view of the middle ear. All right, so you can see head on that our round window is in front of us, our promontory is front of us, hypotympanum is front of us. So it's a very good technique where we can handle the anatomical malformations and ossified cochlea, high jugular bulb, forward-like sigmoid sinus, low-lying dura, contracted mastoid in children, right? So the posterior canal wall is thinned down, a small supramental well is made here. So this small well is just few millimeters deep to house the extra electrode. So there is no intention of doing mastodectomy here. The edges are undermined to house the extra electrode. Then this is the special perforator that was designed by Dr. Trifon. It has a guard and this special perforator, which is a cylindrical 1.4 mm worth. Then along the posterior canal wall, you can see the perforator reaching in the middle ear. Then along the posterior canal wall, from 11 o'clock to 9 o'clock, a tunnel is made. You can see the tip passing, suction tip passing through the tunnel directly at the site of the cochleostomy. And this is followed by cochleostomy. So the cochleostomy site is just anterior inferior to the round window membrane, and the cochleostomy is being done here. So after doing the cochleostomy, it is widened, and rest of the procedure is just like any other surgery. And again, we are making a straight tunnel inferiorly so that we can visualize the complete scala tympani. All right, now see, the beauty of this technique is you pass the tunnel and it goes directly in the cochleostomy site. All right, without any resistance. So that is the beauty of this technique. So that is Varia technique. Now the round window insertion. So the proponents of classical posterior tympanotomy technique say that the round window insertion can only be done with the posterior tympanotomy technique. So how do we do round window insertion is, we have already seen, we drill the round window niche as it is being drilled here. So superior and anterior superior ledge is exposed until we get a full view of the round window membrane here. So that's the round window membrane. You can see the chorda, tympani, and the facial nerve. They are very well preserved here. So that's the round window membrane, right? So this gives us a direct access to the scala tympani, and it is being perforated now with a right angled pick, and it is round window membrane is removed. And in cases of small slim electrodes, we can do a soft insertion actually. So this is the round window electrode. Then the electrode is inserted through the round window membrane, bypassing the crista area directly into the cochlea. So you can see the atraumatic complete insertion of the electrode through the round window insertion. So then they argue that through Varia we cannot do the round window insertion. So then this paper came in 2019 from AIIMS Patna by Dr. Vishwarma and Dr. Kranti Bhavna. They said that in Varia approach, middle ear is completely gives the round window membrane visibility, and rotation of about 30-degree table towards the side of the surgeon gives the very good exposure of the round window. And they are doing all their cases by Varia technique through round window insertion. So round window Varia can be done. So I'll just show you the technique, how the round window was. So round window was exposed. This is the Varia technique through which the round window was exposed. So you can see the round window membrane here. So it is being drilled. And you can see the the reflux here, as I am moving the IS joint, you can see the movement on the round window membrane. So now the round window membrane is perforated again, and the electrode is inserted through the tunnel, through the varia tunnel into the round window membrane, right? So next, the most important thing that people argue about this technique is the facial nerve safety. They say that it is a blind technique, so it can go blindly in the facial recess and under the facial nerve. So then, this is a paper that studied 50 temporal bones, that was done in SGPGI, and what they did was they measured the average length between the posterior canal wall and the facial length, and it came out to be 4.5 mm, and it varied from 3.5 to around 4.8 millimeter, and the size of the perforator that we use here is 2.4 mm. And if we take the safety margin 2 mm anterior, 2 mm posterior, then it comes out to be 2.8 mm, and we are getting an average distance in these temporal bones of 4.5 mm. And we go hugging the posterior canal wall. So I'll show you how we make the tunnel. So here you can see your burr point going, and you are not going posteriorly. This perforator goes hugging the posterior canal wall into the middle ear. All right, so in this direction, and this is the tunnel that is being made, and see, only a few millimeter of bone is there from the posterior canal wall. All right, so this is the tunnel, and see the axial thinning of the bone anteriorly. You can see your perforator passing through this axial bone. So I would say this is not a blind technique. If doing this procedure we can injure the facial nerve, then we cannot do this cochlear implant by PT technique. And round window hearing preservation. So for me, with the coming concept of hearing preservation, like this type of electrode, where the electrodes are slim modular, peri-modular techniques. So these are the indications for doing cochlear implant by posterior tympanotomy, because the electrode designs in these cases is such that we cannot pass it through the tunnel. So varia technique gives us wide accessibility, and rather than the keyhole visibility, no removal of the normal healthy bone is there, and no change in the anatomy of the air cell systems. All anatomical variations of cochlea can be handled by this technique. Cases with hypoplastic mastoid cavity can be easily handled, and I would say that the mastoid is left as such, because in a child we don't know when the mastoid is going to happen, and there is no pathway that has to be created in cases of posterior tympanotomy, but it has to be, we have to make a tunnel in varia technique, and it is very difficult to do contour advanced or perimodular or slim modular electrodes by varia technique. So to conclude, I say that varia is an effective and less complicated technique. It is safe for the facial nerve, and it is ideal technique for difficult cases with anatomical anomalies, and it is ideal for very small children with very small mastoid, and classical PT is an ideal technique for newer hearing preserving perimodular electrodes. Thank you. Video. Okay, I'll take that. So I'll just show how a small, very small video. We have seen Dr. Satish doing beautifully angiofibroma surgery today. So his way of handling maxillary artery clipping was beautiful. So, but it is not always that we handle the maxillary artery so beautifully. So this was the case in my early days when I started doing angiofibroma. And incidentally, I would say that this can also happen in when you are doing a angiofibroma. So I expose the posterior canal wall. I can see this, you can see this pulsation here. All right, you can see the pulsations here, and that is the maxillary artery. You can see the maxillary artery here. So the what mistake I was doing was I was trying to tease the maxillary artery with a sickle knife. It's a sharp instrument. Yeah, we have seen Satish was using a ball probe and taking it out. So it was a grave mistake from my side that I used this sickle knife to take it out. And I could see, I thought I'll take it around very easily. I just tease out the fat, and see, while I was teasing out the fat, and it ruptured. So although I took control of it, but it took around 30 to 40 minutes to gain access to this artery. So I would say that never use any blunt, sharp instruments when we are teasing this artery. And so, like Satish was said, we can clip the maxillary artery completely. We can even clip the branches of the maxillary artery. And sometimes. So you see, in this case, we are teasing out the maxillary artery here. So we are trying to get to the main branch of the maxillary artery, all right, in this video. And see the maxillary artery having a tortuous course coming from here. So we first coagulated this artery with a bipolar, this part. And then we put the clip along the inferior part here. But this artery was seeing again going in a tortuous way here. Like, so this is the clip, and then we, like Satish was placed 3 clips. So we again try to place a clip here. So to get a better control. So that was done. All right. So that is the gaining control of the complete maxillary artery. Now in this case, you can see that even if you don't have clip, it is always better to have clips. But if you don't have clips, you can coagulate the maxillary artery with a simple bipolar also. So in this case, unfortunately, we didn't have clips, but we coagulated the whole artery with the bipolar cautery and then went ahead with the surgery. And in the third clip, you can see there are multiple branches here of the maxillary artery, and we tried to clip the multiple branches separately. So to devascularize. So this is one branch where we put the clip, and that's another branch where we put the clip. So, and another thing I would like to show you that I showed you my one complication that I had with the injury to the maxillary artery. So when I started using coblation in angiofibroma, in the initial of my cases, I was so enthusiastic that I went, while doing the Danker's approach, I went very near to the piriform aperture. And at that time, I didn't realize that I had gone so close, and I went well with the surgery. I came out and I actually discharged the patient. When the patient came out after a week to me, he had this hole here at the level of the piriform aperture. So this was due to the injury done by the heat of the coblation wand. So we must be very, precise in using this wand laterally when we are elevating it from the piriform aperture. Although it was stitched later in 2 layers and the patient did well, but this is a carry home message. So another thing is, even if you are doing endoscopic approaches, we should be very well versed with the open approaches also, because we never know when we have to go for the open approaches. So the open approaches most commonly used are transpalatal, transmaxillary, lateral rhinotomy, mid-facial degloving approach, Lee-Fort 1 osteotomy approach, and maxillary swing approach. So for extensive cases, maxillary swing approach has been our favorite approaches. So the concept here in maxillary swing approach is that you do osteotomies in the maxilla. So there are 4 osteotomies that are done: palatal osteotomy and zygomatic osteotomy, and then pterygoid osteotomy and orbital osteotomy. And then after doing these osteotomy, the maxilla is swung laterally, and then it gives a complete, open access to your tumor. You can see that. So that was the approach that was done. So this is the Weber-Ferguson incision with lip split that was given, followed by the palatal incision. Then these are the sites for the osteotomies that were done. And that is a pterygoid osteotomy that is done. So this is the patient with very extensive case, and this is the incision. See how morbid the incision is for a benign tumor like angiofibroma before we start doing endoscopic approaches. And after doing this, osteotomies are being done, and that's the palatal osteotomy being done. And after doing the osteotomies, the maxilla is swung laterally, and that's the tumor in front of you. In those days, it was like once you expose the tumor, you have to take it in minutes, otherwise there will be a lot of bleeding. We used to arrange 4 units of blood, at least 4 units of blood during our residency days for this. And that's the tumor, head-on tumor for it. So this is after removal of the tumor, the large cavity, and see the cavity here and the open access that it gives. That this technique, this is the tumor that is being removed. And later on, after removal of the tumor, the maxilla is swung back and it is stitched with the mini plates. And this is the post-operative. So see the facial scar this child has by this technique. Although it heals well, but still the remains of this scar remains with the patient for throughout his life. Sometimes when the angiofibroma extends intracranially or intradurally, we have to go for combined approach. Intracranial part for a separate approach for the intracranial part, depending on the site of the tumor, which may include standard facial translocation, orbitozygomatic approach, or anterior craniofacial resection can be done for these cases. And so to remember is that angiofibroma invade the skull base by expansion and bone resorption, and never by cellular infiltration. And tumors that extend through the sella and insuate between the pituitary medially and internal carotid artery laterally are difficult to manage surgically. So it has associated complications, we all know. And the common cause of recurrence is inadequate assessment and planning, extensive marrow infiltration, significant supply from internal carotid artery, and significant intraoperative bleeding. Thank you so much.
Hello. Hello. Yes, Rajiv. Hello. Yes, Rajiv.
Yes, sir, we can hear you.
Yeah, okay. Doctor. Thank you, Dr. Rajiv Kapila, for this nice talk. Now we are starting with the subtotal patrosectomy with CI. And Dr. Satish will just share the CT scan and MRI of that patient. And Chloe.
Hello. Hello.
Yes, sir, we can hear you, sir.
Okay. So this is a very interesting situation. This patient is 4.5 years old. Is 4.5-year-old child. Let me open up this. Yes. So this patient has bilateral profound deafness, prelingual deafness, has bilateral otitis media, having right side cholesteatoma, left side secretory otitis media, but profound deafness. So the decision making is very important in such a situation. You know, speech is the biggest concern and implantation is the only answer, but with cholesteatoma in place, implantation is a big challenge. So what best can be offered to such patients? In our opinion, we have a now big series. See the CT scan of this patient having cholesteatoma, the cavity on the right side, and has this opacity showing secretory otitis media on the left side. So bilateral profound deafness. Answer is CI, and our policy is to do a subtotal petrosectomy and CI same stage for the reasons I tell you. Now, what are the options? Option number one, you can do a canal down mastectomy or whatever, allow it to dry and come back after 6 months, 1 year, whatever, for the CI and then rehabilitation. Now, doing this canal down mastectomy and waiting for the CI will take another 1 year or so, and that will be detrimental to the speech development of the child, number one. Number two, even if you do a sort of mastectomy and do CI, still there is a possibility of infection. A child having this much of disease, if you don't do something concrete, that this disease can come back again. And with, imagine the disease coming in place after the returning after the CI in place, what can happen? That is detrimental to the not only to the CI but to the patient as well, because now you have opened the avenues of infection to spread from middle ear to inner ear and then subarachnoid space. So our goal should be to do something to get rid of this disease, at the same time implantation, at the same time ensuring something that the infection doesn't return. An answer to all this is one and only subtotal petrosectomy and CI. Subtotal petrosectomy involves exenteration of all cellularity from the temporal bone, blocking off all the avenues of infection coming to the temporal bone, means blocking of the extraartery canal, blocking of the eustachian tube, removing all mucosa and epithelium from the entire temporal bone, everywhere, do cochlear implantation and then obliteration of the complete cavity to make a sterile environment for the cochlear implant in future. That is the final answer in terms of giving patient the immediate hearing, at the same time preventing possibility of all sorts of infection coming to the temporal bone in future. So our goal in these patients is to do a subtotal petrosectomy and CI. Now, once it comes to CI, the first thing is to ensure that the candidacy for CI. Candidacy means for a cochlear implant to be effective,
Sir, isn't it safe to do CI on the other side where there is serious otitis media?
but yes, and you have to treat the cholesteatoma as well.
Okay.
Then this approach, a subtotal petrosectomy and CI will treat both, will address both the issues. It will treat the cholesteatoma and make the ear safe. At the same time, it will give hearing as well.
Okay, sir.
And just doing at the same stage, it has no contraindication. We have now a huge series. See this, the candidacy of CI involves a fluid-filled cochlea. You see the fluid-filled cochlea and ability to weighted imaging, and intact cochlear now. See the intact cochlear now.
Yes,
can you see?
Yes, sir. Yes, sir.
Hello?
Yes, sir. We can see, sir.
Intact cochlear nerve and the fluid cochlea that fulfills the criteria for possibility of CI. And this whatever disease, we will remove all this disease, exenterate all cells, block off all sources of future incoming infection through eustachitive extraordinary canal, obliterate them, close them, and then do the CI and then obliterate with the material to cover the CI, to create a sterile zone to prevent future infection, and this involves a good subtotal petrosectomy for such. That's the ideal solution for this problem. Anything less than this is detrimental to such patients. Whatever, if you do suppose you do a good canal down, good epithelialized cavity, and you elevate the epithelium and put the CI underneath, the cavities can infect anytime. Even if you partially obliterate, still the infection can take place, but that doesn't guarantee the future infections. That's the only way to prevent future infection, to create this sterile zone by blocking of all connections from exterior to the temporal bone, that is subtotal petrosectomy CI. So, in order to do that, we need to see the temporal bone anatomy, and temporal bone anatomy from cochlear implant perspective. Yesterday we did the implant, but couldn't discuss the CT scan. We need to see all the inner ear spaces, any abnormality, any malformation. See the intra-auditory canal, the dimension is good. See the cochlear aperture modulus, it is good. All the turns of the cochlea, vestibule. See the semicircular canal, that's the lateral semicircular canal. See this, that's the facial now, the labyrinthine. This is horizontal, this is horizontal, this is vertical segment. This is vertical segment where my cursor is, and this is going to the stylomastoid foramen. That's the stylomastoid foramen. So you can see all this anatomy. See the carotid artery anteriorly with the bone separating cochlea from the carotid. So what all this requires is a good subtotal petrosectomy and cul-de-sac closure of the extra-auditory canal to prevent the infection coming from outside, removal of all mucosa and epithelium by means of exenterating all cells, removal of all epithelium from the canal and the tympanic membrane, and doing a peri-eustachian tube drilling to remove all pericarotid, peritubal, all those cells, and obliterate the bony eustachian tube to prevent the future infection coming from the nasal cavity. And then you can implant in a very, very safe area, and you can obliterate the cavity to make it absolutely, sterile zone. So this is about the CT scan and MRI in quickly. So in quickly we are starting the case, and we'll show you each and every step of subtotal petrosectomy in detail. And once you do, see, people may ask the cholesteatoma may remain, you should stage the procedure and thing. We remove the cholesteatoma from the canal down approach completely. This approach is even more extensive than the canal down. Even after this, if you leave the cholesteatoma, then you don't deserve to do a CI. This exposure given by the subtotal petrosectomy is much more than given by a canal down mastectomy. You can see each and every nook and corner of the temporal bone to see if any cholesteatoma is remaining behind. Obviously, when there is active flourishing infection, you should avoid give antibiotic and then do. So this patient doesn't have any active infection, but cholesteatoma itself is no contraindication for the same stage surgery. So this approach will give you a perfect access to remove cholesteatoma from each and every place from the temporal bone. So the goal is not only to remove the cholesteatoma, but remove entire epithelium, entire mucosa by means of exenerating all cell lines, and then block the eustachian tube, close the extraordinary canal, and then CI and then obliterate. So that's the final answer. We have huge series of patients for years together without any risk of any ascending infection coming to the temporal bone from eustachian tube or external or any source. And those patients can live happily because anyway, this middle ear system is never going to be utilized after the CI for any hearing purpose. So that's the final answer for preventing infection. Otherwise, imagine you do an implant and infection comes, after that, when the implant is in place, it's a disaster. And most of the time, you end up explanting, the device. So all those patients who are having, CSOM, who had history of CSOM, who have a likelihood of developing CSOM, any high risk factor, nasal risk factors, eustachian tube risk factors, cleft palate patients, all these patients, we primarily offer them a subtotal petrosectomy implantation at the same stage to prevent possibility of any future infection. Not only that, all difficult anatomy condition to identify the anatomy, subtotal petrosectomy involves complete uncovering the anatomy of the temporal bone. So that is the approach of choice. All possible difficult anatomy, low dura, anterior jugular bulb, this, that, facial anomaly, whatever anomaly, canal anomaly, anything anomaly in the middle ear, subtotal petrosectomy, obliteration and CI is the answer. For all those situations where there is high likelihood of, developing a CSF leak, like we discussed day before in cadaver, if you have a common cavity, IP1, IP3, there is direct communication with the, subarachnoid space, and sealing the subarachnoid space, preventing CSF leak is always a challenge. Through the narrow space posterior tympanotomy and doing a CI, you can't effectively, seal the CSF space that effectively, comparatively, as compared to the subtotal petrosectomy, because not only we seal the space, but we obliterate the entire cavity to prevent possibility of any CSF leak coming in the future. So that is a short technique of dealing with the CSF leak, as we completely obliterate the cavity, not only seal but obliterating the cavity. So to stay on the safer side, all these possibilities, having situations having the possibility of giving gusher should be dealt with ideally with a subtotal petrosectomy. Any situation giving the possibility of future infection, future CSF leak, or any difficult anatomy, the ideal answer is subtotal petrosectomy and CI. And let's see we are starting the case in a couple of minutes. I'll take you to the surgical steps of subtotal petrosectomy. And having this exposure of subtotal petrosectomy, then cochlear implantation, it becomes a child's play because everything is in front of you. There is nothing like walking through the narrow space or finding or, developing, looking for any anatomy. Everything is in front of you like an open book. And then implantation is a child's play. So in a couple of minutes, we are starting. Any questions till then? Any questions?
Sir, is there any role for doing stage surgery, like first removing the cholesteatoma and then putting the CI?
So what will happen? In this patient who's a prelingual deaf, 4.5-year-old, you remove the cholesteatoma, come back after 6 months, 12 years, what is going to happen? For what change we are planning this? To ensure cholesteatoma removal?
Yes, sir.
With this exposure of subtotal petrosectomy, one cannot leave the cholesteatoma. We are now not only removing the cholesteatoma, but removing the mucosa completely from the temporal bone. Believe me, removal of the cholesteatoma as compared to the removal of the mucosa is much easier. Removal of the cholesteatoma is 1,000 times easier than removal of the mucosa from the temporal bone. So why to unnecessarily stage for removal of the cholesteatoma? You see this will give an amazing exposure and we can remove the cholesteatoma same stage.
Okay, sir. And sir, let's say if in case of the device life is around, let's say 20-25 years, then the patient requires revision cochlear implant.
Yeah.
So if all the cavity is obliterated and
Then
all
it is
that.
so simple.
Okay,
And
sir.
it is much simpler because we obliterate with the fat.
Right, sir.
Open up, remove the fat, whatever implant you want to change, and again obliterate with the fat.
Right,
Your
sir.
planes are always preserved with the fat.
Yes, sir.
There are advantages of obliteration with the fat. Number one, the
Okay,
planes
sir.
are always preserved. Number two, in case you look for monitor for any recurrent disease cholesteatoma, you can get a fat suppress MRI and you get a clear-cut distinction between disease and the fat.
Okay, sir.
So your monitoring vision becomes much easier with fat in place. If you obliterate with vascular tissue, muscle or anything, the variable intensity of the muscle and all that is always confusing with the recurrent disease or muscle.
Okay, sir.
So fat obliteration makes your life so simple.
Sir, what is your protocol for post-meningitis profound hearing loss in labyrinthitis ossificans?
So ossificans depends upon how much of the ossificans has set in. See, this ossification starts from the scala tympani of the basal tongue, where the cochlear aqueduct opens into. So it involves the scala tympani of the basal tongue first, then extends to the middle tongue, then extends to involve the scala vestibuli as well. So depending upon the extent of ossification, you have to plan your surgery. If your basal tongue is completely ossified, if your scala vestibuli is intact, you can come from I showed you the anatomy from the vestibule where the scala vestibuli starts.
Yes, sir.
Go from the vestibule and implant in the scala vestibuli. Even if your scala vestibuli is ossified in the basal tongue, go to the middle tongue. I had shown you in the dissection.
Yes, sir.
You can do a reverse implantation. We recently did one case. Reverse implantation from the middle tongue.
Okay, sir.
So depending upon the space left behind, accordingly you can implant. Sometimes you have a space in the scala vestibuli in the basal tongue, then again some space in the middle tongue. You can put two split array to stimulate the other electrodes in different zones.
Okay, sir. Thank you, sir.
But in ossificans, we always advocate subtotal petrojectomy and CI. The reason being, this ossificans requires a complete drill out. You know how close the carotid artery is from the cochlea. If you do this from the posterior tympanotomy from such a narrow space, how can you control the carotid artery and other vascular structures? It's best to do a subtotal petrojectomy, have a wide exposure, define the carotid where it is, drill out the cochlea completely and obliterate. At the same time, once you open up the scala, you can push your periosteum into the scala and obliterate the cavity, and that is something which secure your electrode array in place much better than without obliteration. So that's a straight away indication for subtotal petrojectomy in CI once you deal with the ossified cochleas.
Okay, sir. Thank you, sir.
Sir, for juniors like us, we have less exposure of this subtotal petrosectomy. Can we go in for the implantation of the other ear, which has just serous otitis media? After?
Yes. So what you can do, we are putting a grommet there. It is not subtotal petrosectomy implanted. You have to deal with the cholesteatoma also.
Right, sir.
So this will address both the issues together.
Right, sir. Okay.
So that is the added advantage operating in this year.
Okay, sir. Okay.
So we can continue our discussion, and in couple of minutes we are starting with the implantation.
Right, sir.
जी सतीश भाई, हेलो
Hello.
यस
Hello.
यस यस
Sir.
यस यू आर टेकिंग द इंसिजन.
Yes, sir.
So
Picture is clear?
Yes, picture is very clear. So
Okay.
The subpectoral vitrectomy, you take incision little more posteriorly.
Yeah.
Hello.
Yes, please.
Sir, what is your thought regarding bimodal hearing? Is it beneficial or not, sir?
Can you repeat the question, please?
Sir, what is your thought regarding bimodal hearing?
Hello.
Am I audible? Hello.
I think you want to ask about the bioral hearing, nahi? Is it that?
No, no, whether he want to ask that 1 year is implant and 1 year is with hearing aid.
Yes, yes.
This kind of hybrid hearing you want?
Yes, yes, sir.
Okay.
For preservation of low threshold.
Then definitely, if you have profound hearing loss, there is no use, there is no place for hearing aid. But you have 1 year profound hearing loss, in other year, if you have some benefit through the hearing aid, then definitely you can use hearing aid in 1 year and implant in other year.
Okay, sir.
So there was a question that sometimes there is a conflict of between the acoustic hearing and the electronic hearing. But now it has been proved with the implanting single-sided hearing that brain has a capacity to adjust it in 6 month to 9 month period. Even if you have normal hearing in 1 year and sudden single-sided hearing loss, you can implant that year also for your binaural hearing and better perception of speech.
Thank you, sir, for your answer.
Hello?
Yes, Satish bhai.
Hello?
Yes, Satish sir.
Yeah. So I will join soon. See what right now what you are seeing is,
Superiorly based flap.
yeah, the flap is being elevated superiorly, same.
Yes.
Superiorly based flap, but the incision was little behind.
Yes,
because you need to do a subtotal petrojectomy. A
right.
regular implant, we do a just small crude cortical mastectomy. But here we need all, exentration of all cells, including, perisinus cells and everywhere. So this is flap elevation. This is a very reliable, superiorly based flap.
Right.
And then little bit of the undermining of the remaining, flap margins to resuture so that it doesn't fall short. Tissue is a tendency. See this undermining?
Yes.
So almost a centimeter of the undermining is done to prevent a tight closure. See, the entire work being done with a knife.
Yes, no
The
use of
cautery
cautery.
has not been used for any reason. So, in order to prevent infection, your quality of dissection, your quality of work is important. The tissue handling is so important. So, use of cautery, takes away the tissue. So that may result in a tight closure. That may damage the tissue as well. Here, everything done with a knife to prevent the tissue loss. Undermining at the same time all around. So the later on closure is never in tension. This is one of the reasons. If your closure breaks away, gives away, and the implant is exposed, that is the biggest reason behind, a disaster. An exposed implant is a disaster and many a time need to be explanted because it acquires infection. And once infection takes place in the implant is a foreign body. The same principle applies most of the time. If infection takes place in a foreign body, majority of the time, even the antibiotics don't work and we have to explant it. Though we have been able to salvage many of the implants using Manuka honey and other, antibacterial agents. And we could salvage those implants many times, but not always. Many a time we had to, re-explore and explant ultimately when the biofilms reoccurred. So you can try in those situations when the implant is exposed, remove the biofilm, wash with the Manuka honey, place Manuka honey everywhere to prevent infection, place the implant at a different new bone and cover with a new vascularized flap. You can take all those measures, but still, many a time need to be explanted. So that is, to me, infection in the exposed implant is a disaster. And we should be doing every possible, we should be taking all, measures to prevent that infection. And this tissue handling, respecting the vascularity, a good closure, preventing infection by all means is very, very important and integral part of a successful outcome.
Right.
Now the next step before subtotal petrojectomy, before I join, will show you the cul-de-sac closure. See, I told you this technique of subtotal petrojectomy and implantation involves excentrating not only epithelium but mucosa from entire temporal bone. Excentrate epithelium and mucosa from the entire temporal bone and implant, and block off all connection of this cavity for future for infection to ascend. There are two major avenues for the infection to ascend are the eustachian tube and the extraordinary canal. So I will show you how the pericarotid, peritubal, all those cells are excentrated, and finally how the bony eustachian tube is, completely blocked. And secondly, how the extraordinary canal is, completely sealed, closed, sutured in future. So this is now this is the cut end of the extraordinary canal. Cut end of the extraordinary canal.
Yes.
See now, the canal being circumferentially cut. See this?
Yes. Centralize the picture, please.
Yes, centralize. Yes. And see this upper part of the cartilaginous canal. See this upper part of the cartilaginous canal?
Yes.
This has to be perfectly closed and secured. Perfectly closed means it should not give way. See the lower part of the canal and all, we will excentrate.
Yes.
And upper part of the canal with the cartilage around. So the cartilage, this canal will be separated from the cartilage gently. Gently, gently. See this? The cartilage will be separated from the canal and then canal sleeve will be taken out and sutured. And this cartilage, see this? Anteriorly is the conchal cartilage there, this behind.
Yes.
And anteriorly is the tragal cartilage. So later on, as a second,
Layer.
that is tragal cartilage. See that?
Yes.
As a second layer, we can suture this conchal to the tragal cartilage to prevent this canal give way medially. See this?
Yes.
How nicely you can separate the sleeve of the skin from the canal all around. Quickly, you can finish in 5 minutes this cul-de-sac. And reinforce with a second layer. See this?
Yes.
All around. So, anteriorly the separated from the tragal cartilage, posteriorly this conchal cartilage. See this? And this canal will be taken out completely, little bit inferiorly. Yes. See, such a simple and useful procedure. Anybody, any question regarding this? See the sleeve of the skin entirely.
Yes.
And this will be pulled out. See this?
Yes.
And will suture with the vicryl, the strong absorbable suture, so that you don't remove the suture for the line to break down. This epithelium should be pulled, exteriorized, and then sutured with the vicryl so that you don't need to remove the suture. See, we don't bring the long sleeve out. We don't cut the, cartilage too medially.
Yes.
So that you maintain the depression in the canal for aesthetic purpose. Now the sutures will be placed onto it. Close it. See, the skin is pulled out. I think now anybody can do this simply.
कर देता हूँ ठीक
This is vicryl.
You're not pulling it out too much so that tragal cartilage is there.
Hello. Yes, boss. So the layers been put by the vehicle. Now you can see the inner part, canal wall. So it has to be done in two layers to make it more
ये
strong.
ट्रेगल कार्टिलेज और कॉन्कल लेयर हैं
Yes, yes, yes.
हैं
Yes, yes. Triangle as well as concal.
so one layer is above and another is below.
Yes, yes.
Close come.
So chances of any leak, any.
Yes, yes, yes.
So Dover was.
Yes, sir.
So in petrosectomy, there is no controversy about where the varia or posterior tumorotomy. It is the only place where there is nothing like which approach.
But ultimately, in this also you need a wide exposure.
Yes.
That
yes,
is why
yes.
you remove all the posterior canal wall and everything.
You're
So that
supposed to take out each and every millimeter.
It becomes a single cavity.
Yes.
And you have a panoramic view to see how to put the implant and everything.
That you will see.
Posterior canal wall is ultimately removed here.
Dubey sir.
Sir.
You have a case of for cochlear implantation who has CSOM.
Yes.
What would you do?
Your awaz is breaking. Please.
What would you do? Patient having CSOM with bilateral deafness.
Definitely, we want to do the cochlear implant and make the ear safe so that implant should not get infected.
So, what is the best way to prevent infection coming back? Because
accentuate all the cells.
anything you do, tympanoplasty, mastectomy, in long run, anything can fail.
Yes.
You see the initial results of tympanoplasty worldwide in the best of the series. Best of the institutes, even House Ear Institute, anywhere in the world. The initial results are increasing over 90% or so, even more than 95% in the best end. But what are the results of the...
Sir, your voice is breaking.
Hello? Now?
Yes. Yeah, it's now good.
So now, what are the results in the long run? Long run, no series has shown those results as those were initials.
Right.
Because you don't have control over everything. You can repair the tympanic membrane, but you don't know why it ruptured. There are so many reasons behind it. Nasal problem, eustachian tube problem, infection, so many things. You can't control everything in long run. And if you do so, an implant and suppose infection returns with implant in place, then
it's a very painful condition for any
only word
implanting
in
surgeon.
my mind is disaster.
Right.
For both the reasons, it is not only the implant which is to be explanted. The cost and other thing is different, but it becomes a problem to give infection to the spreading to the brain.
Right.
Because now you have already opened the closed avenues, for the infection to spread to the brain. So we need to think of something, and this is gold standard. I don't know the reasons why the implant surgeons are not picking up this issue, but The reason is very obvious. If you're an implant surgeon, in my opinion, you have to be well versed with subtotal petrosectomy. As simple as that for anybody.
Definitely.
Because
I
this
agree.
is the short, almost short technique if carried out properly to prevent future infection. And we have our own series and you see the international data. This is pure evidence based, nothing personal. And this is something, a boon to the implant patients.
Right, sir. Worldwide it is done because we have attended one workshop in Mario Sana's place in which they kept 9 cases of adult CSM CI. In all those cases, they have done subtotal petrosectomy followed by implantation.
So you are very right in telling that we are not confident about
Madam,
it.
can you raise your volume? It is not audible. Can you bring your mic closer?
Yes, sir. Sir, you have rightly said that we are not confident basically that to do subtotal petrosectomy, like I would like to
नीचे मत करा, ऊपर चलता जा.
ask you about this, that how do you keep follow-up of these patients?
Follow-up?
Yes, sir.
So, there is a standard protocol of follow-up at 1, 3, 7, 10 years with the scans. But see, that is all theoretical. Practically, this exposure of subtotal petrosectomy is much beyond the exposure you get from a canal down mastectomy.
Okay, yes.
When you remove a cholesteatoma by a canal down mastectomy, this exposure is much beyond the canal down mastectomy. You can remove cholesteatoma from anywhere. So removal of cholesteatoma is no challenge after this exposure. There is no question. To me, it doesn't exist. The challenge is exentration of mucosa.
Sir, so what extra needs to be done?
That's what we are going to share with you.
Yes, that
the
will be
surgical
good.
part.
Yes.
So now, before I join, see, they have seen the tagman and just making the well and the tunnel for the electrode array for the cable. And then I'll join and show you each and every step of subtotal petrosectomy. See, this calls for a complete proper surgery in order to exenterate all cellularity. The reason being, go through the radiology thoroughly to see the all cell tracks in the temporal bone. Challenge sometimes occurs when you have a highly nematized bone with cellular cell tracks going to the petals apex, particularly supralabyrinthine, interlabyrinthine, all those tracks. You have to see and, exenterate. So the challenge is to exenterate the cell tracks. That's it. Rest is everything so simple.
So,
Cul-de-sac is not difficult.
so when do you plan that you should do petrosectomy? If there is no cholesteatoma, then also you do sometime this case?
When there is no cholesteatoma.
Yes, sir.
So I have already mentioned the indications for subtotal petrosectomy implantation.
Okay.
Infection is one of the major indications.
If it is not infected, pneumatization also you like to do?
Yes, I told you the reasons for any patient who has a high likelihood of developing a CSF leak. To me, the best technique to seal and ensure your seal remains in place forever is the subtotal petrosectomy obliteration. You can get away with sealing with whatever sealing material to a narrow space.
Okay.
But that may not work forever.
Right.
So stay on the safer side because you don't want any infection in future. And you see the recent Mario Sana series, the huge series of subtotal petrosectomy obliteration. Amazing one.
So do you give steroid 1 to 2 days prior to the CI? And do you cover it under with steroid, the surgery? Hello? Hello?
Hello?
Sir, is there any protocol to give steroid pre-op, per-op, post-op in your case?
That is not specific for the case, but yes, for all cochlear implantation, steroid is something with the only drug which can prevent intracochlear trauma.
Okay, so you start
So
pre-op.
all patients should be followed with the steroid for at least 48 hours. See, this cochlear trauma can be immediate or can be afterwards as a result of, manipulation inside the cochlea.
Yeah.
So it should be given, like we always, now we have made a habit of flushing the cochlea, filling the cochlea with the steroid solution, and post-op also give for 2 days or so.
2 days, okay.
So the well has been created to accommodate the implant, receiver stimulator. Now for fixation, tie down holes, and then getter for the cable to pass on the cochlea, and then the steps of subtotal petrojectomy. China के president का centralized. This being a CSOM case doesn't have too much of rheumatization. It's already sclerosed because of the ongoing disease we have seen on CT scan. Doesn't have extensive rheumatization, so that is an added advantage in CSOM cases. Regarding the cell tracks, you have to follow according to CT scan all supra and infralabyrinthine cell tracks, perilabyrinthine cell tracks, perisinus, peridural, then retrofacial, then the peritubal around the eustachian tube, pericarotid. All those cell tracks are important, and those are the ones which are likely to be left behind. And you know what happens if you don't excentrate the peritubal and carotid cell tracts particularly, in spite of having the eustachian tube obliterated, those cell tracts may open later on, distally in the eustachian tube.
Okay.
So in spite of eustachian tube obliteration, you may still have if CSF or something is there, you may have a CSF rhinorrhea.
So hypotympanic cells are also there.
Yeah, all.
Okay.
Those are part of infralabyrinthine cell tracts. So need to be excentrated.
So I think we require that attention more, what is the latest group you are telling, because post the mastoid area we usually clear.
Yeah, so in order to remove those pericarotid and peritubal cells,
yes,
it has become our policy to almost completely drill away the bony eustachian tube. We all know
eustachian tube. Okay.
The bony tube is smaller than the cartilaginous one.
Okay.
Bony tube is roughly 12 millimeter or so. So we drill away at least initial 5-6 millimeters.
The luminal part.
Completely.
The luminal part you drill.
Yes, the entire bone.
Okay.
So that is lateral to the carotid artery, so you can excentrate automatically the peritubal cells.
Okay.
And it gives you good exposure to deal with the pericarotid cells as well.
Right.
See, that is something very, very important. If you don't excentrate those, in spite of blocking the eustachian tube, patient may still have a CSF rhinorrhea if it is coming. Because these cells may communicate distally into the eustachian tube. So if those are the most important cells to deal with, which I am going to show you.
So why rhinorrhea you are suspecting more there?
See,
you are doing it for more for infection.
See, suppose you have operated for, not for this case, you have operated for some CSF,
okay,
gusher.
okay, so that is also another indication.
Yes, now you have closed the canal.
Yes.
If some CSF happens to gush out,
it will come through the eustachian tube.
Yeah. So the pericarotid cells, peritubal cells have to be thoroughly excentrated. Eliminate them, not only exentration. You have to flush thoroughly those areas. This subtotal petrosectomy has been used as a part of approach to many of the skull-based procedures. Since long, it was described, in 70s and propagated by Hugo Fish. It's a part of approach in the infratemporal fossa approaches. The sole subtotal petrosectomy answers some time to give a dry ear in, repeatedly operated, multiple times operated, draining mastoid cavities, permanent draining mastoid cavities. So the final answer in those situations. So at least you can give a dry ear. Probably, particularly in patients who have no possibility of any hearing reconstruction left behind. In those, you can at least give the patient a dry ear.
So have you done any study to know the causes of postlingual deafness or any evaluation? Like we are doing the treatment, symptomatic treatment of deafness. But sometimes 15-year-old child is coming with history of 2 years deafness. So what are the studies we should do to rule out the various syndromes? Like it is not having any implication, but we even don't know what the cause of deafness is most of the cases.
Sensorineural deafness?
Yes.
Difficult. How can you get to know the cause easily? Unless some offending factor is identified. Huh? रख ले लिया। ये लगा देना देर बाद। Next case is going to be a parotidectomy. Hello, Paula. Hello. Hello. Wash. Hello.
Sir, yes, sir.
Yeah, so now I have joined. See, the cul-de-sac is done anteriorly
Yes.
with the reinforcement by the other layer from below, cartilage.
Cartilage layer, yes.
Now this is your lower canal skin.
Okay. So you'll excise this part.
Yeah, you have to exercise it thoroughly. See this lower canal skin?
Yes.
See, this is towards the mastoid tip. This subtotal petrojectomy cell exenteration always involve the mastoid tip removal. This? ये लगा ना ट्रैक्टर खोलो See the exposure of the cortex? What is another? Hello, I hope the picture is good.
Sir, अच्छा है transmission, everything is clear.
Now see the canal anteriorly.
Yes.
We have already defined there is no skin lateral to it. This was the reason to define that there is no skin lateral to what we are seeing.
Okay.
What is this? What is this? Conical. So now my exenteration starts. Section. आज सर के ऊपर
सिग्मॉइड दिखने लगा?
Can you see the sigmoid sinus?
Yes, sir.
And I am exenterating all these perisinus cells. See the dual plate?
Yes.
Hello?
Yes, yes, it's nicely seen.
That's dura.
Yes.
See the disease?
Yes.
Bipolar.
Would you not like to take a biopsy for tuberculosis and all?
Good idea. There is no harm. Bipolar. I take a biopsy. There is no harm in doing that. एक जना इधर आओ यार. Bipolar. Biopsy also. See, that is the biopsy from this granulation. Initially, to save time, I am using the larger burr. Okay? For this crude work. See the disease? Bipolar. Can you see the tip being exaggerated?
Yes.
Yes, boss.
Circle. I'm quickly removing all these,
Lot of diseases there in the.
Oh, ले लो biopsy के लिए. Some more tissue for biopsy. Knife. I will saucerize everything later. Just to save time, I am just finishing the crude work first. That's the bridge you can see. That's the lower down is the semicircular canal. And until then, I can quickly in the same go, I am removing the bone and the skin. Just see the canal skin?
Yes.
Right. Why not? There you go. Very nice. See, I'm finishing off this crude work very fast. See, wherever I remove the canal skin,
So you bring down all the bone till the tympanic annulus.
yes. See the canal walls all around. That's the cholestoma.
Yes.
Satish boss, do you always remove tip in these cases, menstrual tip?
Always.
So what's the advantage of removing the tip boss?
Yeah, so there could be cells which you may leave behind, number one.
Okay.
तो वही चल क्यों बंद कर दी? बाइपोलर यार. बंद कर दो। हाँ, ठीक। See this entire canal wall soft tissue?
Yes.
Now, give me a diamond, medium size diamond. See? Now I'm first time taking the diamond, having done all this work to saucerize everything.
Right.
Now, after this, you will see the each and every anatomy clearly. So first of all, sinus. अरे यार ये क्या है? वो भाई. Good. कर रही है. दे कम लंबी. हाँ. Can you see the sigmoid sinus region?
Yes.
You have to exaggerate not only sinus but perisinus cells also completely. Let me know if I leave anywhere any cells. This is a favorable case because of the CSM, the mastoid is almost, sclerosed. Bipolar. See this?
Yes.
क्या चक्कर है यार? See this saucerize?
Yes, sir.
यार ये मोबाइल
Sort of bubbling is there in the.
क्या देता है यहाँ पे? अब आएगा भी.
Centralize the picture, please.
दूसरी there. Give me another bar. See this?
Yes, please centralize the picture, sir.
Satish was when sometimes in some children the mastoid is very cellular with all perilabyrinthine cells, perifacial cells going inferior to the infracochlear cells. So
yeah, you have to chase down. Yes, yes. Oh, you have to chase down.
Yeah. So, boss, what if few cells are left? I mean, what if few cells are left?
Basically, a little bit is assumed to make it fibrous. But if the entire cellular tract is left behind with no aeration, with no aeration, is going to secrete.
Secrete, yes.
Sir, please centralize the picture. Thank you.
See, all these epithelium. Yeah. Give me the drill. I will show you the facial now. Get the facial now. I uncover the hypotympanic region completely. Anterior wall especially, I'm very, very radical.
Sir, centralize the picture.
So even this step we require you to tell us nicely that here you're drilling the hypotympanum or something like that, or you have reached that area.
Yeah, this is where the hypotympanum is.
Okay.
I will uncover, cutting them off.
So how are you saving the round window and all?
We'll show you, Not reach there. It is going to be there.
Satish was why you said you are very radical with the anterior wall?
So that I can expose the eustachian tube, carotid area.
Okay.
And remove the, I told you, no, peritubal and pericarotid cells.
Right.
Without exposure, you can't do.
So it seems that you're going deeper to the tympanic level. Now you are going.
No.
No.
Still we have to go there.
So this, all this cells. Having seen the facial now, I can exaggerate all these cells. See this?
Yes.
Facial now is here. See the facial now.
Yes.
See the vertical course. See the horizontal, genuine vertical course.
Yes, yes.
He is uncovering the hypotympanum further. Here's how the facial nerve is going out from here. You saw day before on whatever the course of the facial nerve. Can you see the facial nerve going?
Yes.
So you have to excentrate. See the region of the stylomastoid foramen.
Yes, sir.
Can you see this facial now?
Yes, yes, sir. Now you can see the picture.
See these cells. Hello?
Yes, sir.
See the amount of cells.
Yes, lot of cells are there.
You have to accentuate all these retrofacial cells. What are the limits of the retrofacial approach? Anybody? I told you this before in cadaver.
Labyrinthine posteriorly.
Pardon?
Your retrofacial cells, na boss?
Yeah, raise your volume, Rajiv.
Retrofacial cells you are talking about.
So retrofacial,
So these,
limits.
yes, so these cells generally lie between the labyrinth and the facial, boss.
So what exactly is the limits of the retrofacial recess? See this retrofacial recess is obviously deep to facial now. Facial nerve is there.
Yes.
So when you come from behind, you're behind here, superiorly your limit is?
Posterior semicircular canal.
Yes, right.
And sigmoid sinus and jugular bulb.
So posteriorly, this superiorly, this is my limit. See this jugular, posterior canal I am defining.
Yes.
This one.
Yes.
And inferiorly is a jugular bulb.
Right.
See the jugular bulb here.
Yes.
In between these two, if you come anteriorly, you can come in the
Retro.
yes, in the hypotemporum. If the cells continue. See this?
Yes.
See the jugular bulb?
Yes, very clear.
See the kind of drilling required. See the labyrinthine block.
Yes.
See the labyrinthine blocks?
Yes, we can
See
make
the plate of the bone here above?
Yes.
Yes.
See the pre-sigmoid plate of the bone. There is no cell left behind.
Absolutely.
See with your see and believe.
Absolutely good.
And this is my jugular bulb. This patient hardly any retrofacial recess. See this?
Yes.
Agreed?
Right.
Rajiv?
Yes, sir.
See, there is no retrofacial recess beyond this.
Yes, there's no cell beyond this, boss. Absolutely agree.
Agreed? Complete acceleration?
Agree, boss. Absolutely.
Now, coming anteriorly. Cutting this. Same cutting. See, I am working anterior to the facial now.
Yes.
Now deep to facial now I am coming.
Yes.
That I can see the glimpse of the jugular bulb. See the jugular bulb?
Yes.
See the glimpse of the jugular bulb here.
Yes, we can get the bluish glimpse, boss.
Can you see the bluish hue?
Yes.
So this,
Yes, very clear.
now coming to the question what madam had asked, can somebody leave the cholesteatoma behind after this? With this exposure. So leaving cholesteatoma behind is something we are not even, considering. Leaving cholesteatoma behind doesn't exist to understand this science of total petrogen. Diamond इससे छोटी. More concern is the mucosa, my dear.
Yes. You have to accentuate all the mucosa.
Yes. That is cells. See the 80th floor?
Yes.
See the facial now?
Very clear horizontal segment. You are very at the level of first genu now, boss, right?
Yes.
Yes.
Yes. See this mucosa?
Yes. That's tensor tympanic canal.
Yeah, I elevated. See this?
Yes.
This all mucosa from the spherical recess.
Right.
Bipolar. See, cautery does the same thing. If you can't remove the mucosa from somewhere, you can devitalize it. Is that?
Yes.
You can devitalize it
Yes.
to prevent future mucocele formation. तोड़ने के लिए मोटी वाली. Now, what messages? If you have laser, we use laser. Hello?
Yes, sir.
Yes, sir.
So,
to cut out the stapedial suprastructure. See this?
Yes.
Yes.
What I've used? Chorotomy.
Yes. So the stapes foot plate is intact and suprastructure you have removed.
Yes. Yes. Circular. Is this mucosa?
Yes.
Yes.
Where the round window region?
Yes.
See the round window?
Yes.
Yes. Yes.
We can see the glimpse of the round window membrane also.
Yes. Yes. See the glimpse of the membrane. And see this little bit of the cell over here.
Yes.
There's some cell over there.
Anteriorly, yes.
Some cell over there. See this?
Yeah.
I'll come to each and every cell now.
So that is actually the area of carotid canal also.
That is anteriorly. Anteriorly.
Yes.
Hold on. Small diamond. See this?
Yes.
Yes.
See any evidence of semicell over here?
Absolutely
No.
clear, boss. So,
Right.
boss, you will remove the eustachian tube mucosa also?
Yes.
I will show you.
And block. even from the foot plate.
Yes.
Yes.
Centralize the picture, please.
Now see this. See this? Underneath the facial nerve.
Yes. Sinus cell.
Yes. See the sinus tympani?
Yes.
See this?
Yes.
Yes, sir.
That is below the round window. See this?
Hostess.
Yes. See all these mucosa from here. See that?
Yes.
Round window, little bit of the work is left behind, I will do.
Going towards the eustachian tube.
Now I am going anterior to the cochlea.
Yeah.
That's the jugular valve you can see.
Yes.
Hello?
Yes, sir.
Now I am going anteriorly towards the carotid artery. And you can see the glimpse of carotid artery.
Yes.
See that?
We can see the periosteum over there.
Yeah, that is the cell in between. Okay?
Yes.
Beautiful.
Now what I will do, this is the key work. I hope you are oriented.
Yes, sir. Yes, sir.
See, that is a bony eustachian tube.
Yes.
Cutting that. See the bony eustachian tube?
Yes.
This is carotid below.
Next case will be pleomorphic adenoma of the parotid, going to be shifted very soon after this case.
Pardon? Pardon, madam?
The announcement was there, sir, that next case is parotid, very soon will be shifted.
Yeah. Very soon we'll take the carotid case. This is infratemporal set. See that the carotid?
Yes.
I am uncovering this region for two reasons. One is to excentrate the pericarotid cells, and one is to uncover the carotid artery and the pericarotid cells. Peritubal and pericarotid.
So what is
I'm still with the
required in every subtotal vitrectomy to uncover it?
Pardon?
To uncover the bone over the carotid, is it required in every?
No, I am not uncovering the bone.
Okay.
No need to uncover the bone over the carotid artery at all.
Right.
Circular. See the eustachian tube.
Yes. So you will, after removing all the mucosa, you will feel something there?
Yeah, a lot of mucosa. See, there's a lot of mucosa.
Yes. So we'll obliterate this.
Yes, we'll obliterate this diamond. See, obliterate this to ensure no infection ascending to this region. See the bony eustachian tube?
Yes. Please centralize the picture.
Without drilling the bony eustachian tube, यूं करो इसको पकड़ो, यूं पकड़। क्या हुआ? Disconnect हुआ?
We are getting your voice, boss.
Okay, we are waiting from the anesthesia instructions. फॉलो होके देखना, ट्यूब तो नहीं है लिया। आगे आगे किंक हो गई होगी। देखो वेंटिलेट हो रहा है ना? नहीं, इट इज कम अप आगे से। We'll tilted the head, तो हो सकता है ट्यूब आपकी किंक हो गई है। फिर तो वहां गई नहीं अभी तक को। यस, ओके, ठीक है सर, थैंक यू। लो, हेलो, किसको रेट
Yes, sir.
Bipolar. See how this area need to be excentrated. See this eustachian tube area? Hello?
Yes, sir, we are seeing.
This is the bony tube, lateral wall.
So what, boss, how far should we drill this eustachian tube? I mean,
Until you find the course of the carotid artery and around and there are no cells left.
I mean, looking, sometimes just looking at it, we don't see any cells. So we need to drill and find the cells in this case?
No, it's not about finding, it's about the cells. I am showing you the same thing you are asking.
Okay.
See the cells here. See the mucosal cells.
All right.
See this?
Yes.
The side circular, you know.
So can you point out exactly?
Yeah, this is eustachian tube region and a lot of mucosa I am removing.
Okay.
What's up there?
And externally also there are a lot of soft tissues here.
The right angle is it? Let me clear this to show you. See this area? Bipolar. Drill. Now see above is what Rajiv was telling that time. See that tensor tympani. See this?
Yes.
See this tensor tympani? And see the canal? Hello?
Yes,
Sir,
boss.
please centralize.
Yes.
Yes, now it's.
That's the tensor tympani in the canal.
Yes.
To widen my further exposure.
So you're removing the tensor tympani muscle also?
Pardon?
So you're removing this muscle and canal?
Yes, because this runs over the eustachian tube.
Okay.
So I'm removing to improve my further exposure of the eustachian tube. See, this is my carotid in the medial wall. Can you see?
Yes.
1 minute. See this. That's the carotid artery going.
Yes.
See the bone intact, everybody?
Yes.
See this.
Absolutely.
Now see. That's the carotid artery, that's the cochlea.
Yes.
And that's the remnant of the bony eustachian tube. That is lateral to the carotid. See this angle, my direction.
Yes. So you are drilling by taking care not to go towards the carotid.
Yeah. See, my direction of the drilling is lateral.
Yes.
मेरे रुक रही है यार.
बहुत centralize कर दो.
Centralize नहीं क्या? Drill रुकती है. देख. See, this carotid is going in medial direction.
Yes.
Oh. And my direction of instrumentation is lateral. See this?
Yes.
Yes.
So you have almost completely drilled the bony eustachian tube, boss.
Yes.
But a lot of mucosa is there.
Yeah. So that gives you the best opportunity. By drilling the eustachian tube from all around. Eliminate all these peritubal and pericarotid cells. See, my carotid is so flushed.
Yes.
We keep on reducing the tissue bulk by bipolar. See this?
Yes, sir.
Now drill. See this? And this way you can effectively block the eustachian tube. Once you have a wide opening.
Satish, boss, suppose some mucosa is left and we block the eustachian tube laterally, will that mucosa not drain, keep on draining in towards the nasopharynx?
So don't leave the mucosa towards the middle ear.
Okay.
Our concern is that.
Right.
See, now the area is thoroughly excentrated. See where the carotid artery and where I am working far anteriorly.
Right.
I'm almost eliminating the bony tube.
Yes.
No question of leaving any cell which can communicate later on there.
Yes, sir.
My point is no cell will later on drain into the rest of the eustachian tube.
Yes.
See, carotid artery.
Yeah, beautifully demonstrated, boss. Beautiful.
Now, see this eustachian tube drilled off. See, almost a centimeter of the bony eustachian tube has been drilled off.
Yes.
See, my level of the cochlea is here.
Yes.
Where I have gone. The entire carotid artery is exposed in your field.
Yes.
Can you see?
Yes.
Yes.
नहीं चल रही ड्रिल, क्या मजाक कर रहे हो आप? हाँ, अब चली. See this everywhere?
Yes.
No mucosa, no cell, nothing is left behind, no bony eustachian tube to communicate.
We cannot see any mucosa right now.
Nothing. That is all infratemporal tissue. See that?
Yeah. Is that the cartilage or is still the bony, boss?
Yeah. The bony tube I have almost drilled off.
Yes.
See the complete bony eustachian tube?
Yes.
And now our obliteration will be so easy, imagine. You don't have to bother about anything now. You have to just push the fat into it. See this?
Yes. Yes.
Now see first of all what is subtotal petrosectomy.
Satish, was there one more question? Can in subtotal petrosectomy, in subtotal petrosectomy, is it possible to preserve chorda tympani?
No way, no way.
Okay.
No way. See the cavity of subtotal petrojectomy, everybody.
Yes.
Now I am coming to the round window region. See this? Yes.
डालना है ना.
एक साइज बड़ी देता है. रुक.
It's still bubbling.
Give me a smaller
The water is
section.
still bubbling, boss.
हाँ यार, हर बड़ी बबल कर रही है. ये section पतला. Now see, implantation is a child's play. Nothing is, no challenge in implantation, you have to push into it. वो देना राइट एंगल. अब पतली भर दे वो क्रेस्टा की. See all mucosa in the peri-round window region. See the round window?
Yes.
अरे यार बिल्कुल कम कर दो. हेलो.
Yes, boss.
Yes. Now नहीं यार, ये तो वावल कर रही है यार. देखो दूसरी तरफ. मजाक मत करो. टाइप मत. क्या हो गया इनको? दूसरी लगा दे. यार गिव मी ड्रिल, मजाक मत करो यार. दूसरी दे. जल्दी खुल गया. हेलो.
Yes, sir.
I have to just widen it inferiorly. Say this inferior widening. Hello.
Yes, sir.
My tunnel. Wash with the steroid. See the tunnel? Can you see or not? See the tunnel, inferior
Yes,
tunnel.
now it is being seen clearly.
See the inferiorly?
Yes, very clear.
Straight tunnel, nothing is in between. See this?
Yes. Centralize the picture.
Yes.
Yes, sir, now clearly seen.
See
Even
the
blood-
inferior tunnel?
Blood vessels are seen.
No modulus, nothing is coming in between.
Absolutely clear, boss.
Clear?
Absolutely clear.
Yes.
See exenteration everywhere. No infection. We have already blocked the extraordinary canal. बोल दस ली थी. लाओ इम्प्लांट खोलो, देख के रहे. हाँ दो तो. हेलो.
Yes.
Harvesting some periosteum, sir. Now give me a thorough wash for a while.
Sir, perilabyrinthine cells are all done. निकाल दिया आपने?
Yes, there is nothing left, madam.
Okay.
Periosteum there.
उसके बीच कितना गया है एक्सरसाइज
लगा के दे वॉश क्या दिया के दिया है यार
अब इनको अपनी कार में अपना सामान लेके
see wash everything to see any bone dust or anything, to see any bleeding or anything, because now we are opening our implant. See that?
Yes.
Absolutely fantastic. Now give me section steroid solution.
उसको ड्यूरा खुला पड़ा है ना
I am looking if there is any site of, oozing or anything remaining behind. Hello?
Yes, sir.
And I can wash with the steroid again. See this?
Yes.
That's it. No implant. Now the simplest part of the surgery is coming up. Implantation. Everything is open for you like a copy book. Okay. How about implant? Pani mat dao. Hello?
Yes, sir.
So now we are fixing the implant first of all.
Yes.
See this figure of 8 fixation? Hello?
Yes, yes.
This is rigid fixation. Let me zoom out. This is rigid fixation. See this?
Yes, we can see now.
चलो उधर करना See, this is rigid fixation.
Yes.
Yeah. So my note is going to be placed on sides. So that I can invert it into the suture margins.
This is prolin, was no? This time this is prolin.
It's long.
Hello. Hello.
Yes, sir.
Yes, sir. Any inputs, any questions?
It was a beautiful demonstration, sir. मजा आया देख के, especially the station tube drill out.
Hello.
All the problems, future problems, after this, majority of them come from the Eustachian tube region. See, I fixed this.
It's surgical.
See this knot inverted.
Buried.
So today you have used which suture to fix it, sir?
Pardon?
Which suture you have used today?
Generally, we use proline.
Proline.
Ball electrode. Look, hurry. Well, already made a tunnel for the ball electrode there. See this? Gone inside?
Yes.
And now the steroid wapas. The simplest part of the surgery again coming up. See the tunnel?
Yes, sir.
Hello?
Yes, we can see, sir.
Now see better? Can you?
Yes.
Yes.
See now the implantation is, there is no challenge. Bande yaar section. Implantation is no challenge for septal forcing.
Already harvested fat?
Yes. See this?
Yes.
You have to direct antero-inferiorly towards the floor. That's it.
Gone. One white mark already gone inside.
Yeah.
Yes.
See, without any sort of, obstruction. Because it is in a tunnel going straight. No wall is coming in between. See that? Hello?
Yes, sir.
Yes.
Give me.
The boat should be directed downwards.
Yeah.
Inferiorly.
Yeah, because initial part of the tunnel is antero-inferiorly directed. This is my periosteum, which I want to circumferentially, wrap around the electrode. So bony margin should be the periosteum, not the electrode. See this?
Yes.
It can firmly secure. See this?
Yes, yes.
If your electrode is at bony margin, the perilimb can leak. Got my point?
Yes, sir.
Should be circumferentially. उधर देख जरा जल. कितना देना यार?
Only hearing my condition. क्या चीज़ में देर से की menstruate टिप में?
सेक्शन ही बंद है यार. प्रॉब्लम पता नहीं क्या है.
निकल रहे भाग रहे कितने लोग आए हो
देखो
All from same place
gel form is always a good thing because gel form soaks more than its volume and gives a good gentle pressure. See this? Hello.
Yes, boss.
See this? Now, so छोटे दे आगे के लिए देख एक बड़ा देख तो इसमें. Now see obliteration part one by one. बहुत बड़ा दे दिया बहुत बड़ा. देखता हूँ. See the first of all. Hello.
Yes, sir.
Use second tube and carotid region. This is soaked in rifampicin. Hello.
Okay.
This is soaked in rifampicin.
This fat was kept in rifampicin.
Yes.
Okay.
हाँ जाने ट्रेन है
Why reference?
किस्मत के तुम्हारी डिटरमेंट है तो सुबह से घूम रहे हो मेरे पास दुख नहीं है वैसे भी क्या करना है तो तुम्हारा मन था ना हुआ ठीक है वो भी जरूरी है भगवान का आशीर्वाद जरूरी है हाँ
See all around securing the cable. See this?
Yes, yes.
Give me a big one. Now this is the big one to cover everything.
Why specific rifampicin?
To prevent staph infection. See this?
Yes, yes, sir. Yes, sir.
Now little higher, so it will be tightly packed. And it is not covering the receiver stimulator.
सर आप जूम आउट करेंगे तो हम लोग को दिखेगा क्या हो रहा है
See this?
Yes, better. So full cavity you have packed with fat.
Completely overpacked, a little bit overpacked.
Okay, and full was immersed in rifampicin for how many minutes?
Huh?
Rifampicin में dip किया तो it is
Minimum 15 minutes.
Okay.
It prevents fat autolysis also because even the infection of the fat may lead to autolysis. Even the airborne staph infection can lead to fat autolysis. So now we will cover it. We will put our flap back in position, and this fat will be completely sandwiched. Okay. See this final picture.
Yes, thank you.
Thank you, sir.
Very much for your attention.
It was
We'll be
very
able to-
Big
interesting to
applause for
see.
you.
Beautiful.
Thank you, sir. Wonderful.
Thank you. What we have achieved is Eustachian tube infection source is finished. Extra-aortic canal infection source is finished. No mucosa, no epithelium. Implant is there in place. No role of middle ear now in the hearing physiology. Implant will directly stimulate the nerve endings, and the cavity is, created and covered by the fat to make a sterile atmosphere around. That's it. So this is for indication, like this was one of the ideal indications for this. And in one stage you can accomplish this
So
without
no,
any.
no chance of infection of this fat also.
No, that's why the fat is a material which is being extensively used for obliteration at many places. And with rifampicin, it prevents autolysis and chances of fat necrosis are rare. And secondly, it gives a good interface for future imaging.
Okay.
You can use a fat suppress imaging. That imaging will suppress the fat. Everything will be dark. And in contrast to that, you can see your disease, your cochlea, your implant and everything in contrast to that.
So you will advise only MRI भी कर सकते हैं सर इसके साथ.
So impedance is good. NRT is coming. See, very
Yes,
nice.
yes, yes.
See, even at a low current, it is coming now.
Yes, very low impedance.
Can you focus this there? No, is this external camera coming there?
Yes, yes, we are seeing it. Good impedance.
Yeah, see the electrode number 6. See
Yes,
this, even at 161.
Even previous one was below that.
Yeah, so we'll obliterate it. Thank you very much for your attention.
Thank you,
Any
sir.
questions, anything?
Madam was asking about MRI. The MRI basically implant depend upon the implant. This implant is not MRI compatible. So if you want to.
Yes, up to 1.5 Tesla, no issues.
Now the implants are there. They are compatible for 3 Tesla MRI also, but they are very costly.
Hello, boss. Dr. Boss. Good.
Yes, sir.
Yes, boss. Next, we have a thoughts first. Parotid has some issue, some hypertension before high.
Okay.
So we are doing revision first.
Revision first.
Yeah, operated almost 2 times.
Okay.
2 times operated. Just wait for some time. We are starting the case.
Sir.
अशोक तुम लोग तो यहीं बैठे हुए हो? हाँ, पता नहीं कोई ले गया क्या? अच्छे रिटर्न गिफ्ट दे रहे। बिना जूते के घूम रहे, इतने अच्छे कारपेट है।
Till next case begin, I would like to call Dr. SP Dubey sir on the stage to facilitate our guest, means chief guest and nearest guest from Panipat. Sir, Dr. Pritam Arora sir, please, we would like to felicitate you. So you are so patient. I have seen you for last 3 days. You are so patient in watching each and every surgery so patiently. I am impressed. सर हम आपके बीच वाले सेशन से आप शायद कहीं चाय के लिए गए थे, ये मिस हो गया था। सो आपका जो पेशेंस है ये हमारे काम आ गया, हम आपको मिस नहीं करना चाहते थे। प्लीज सर, थैंक यू वेरी मच फॉर कमिंग सर।
Hello, hi sir.
Dinesh?
Yeah, hello sir, Deepak sir.
Yeah, अभी चालू नहीं हुआ सर्जरी.
चालू हुआ है. Now they are just put it a pause. They are changing. They are shifting to next OT, sir.
Okay.
Just give one minute, sir. They will talk with you.
I will join little later. No problem.
No problem, sir. You can wait. No problem.
Okay.
Sugar.
तुमको देख लेना है तो आ जाओ। आप अब बच्चे के पास चलिए। आपका ट्रेन का आइए इनको टिकट अपना आधार होता था ना। अभी रात में 11 बजे तक केस चल रहा है, पता लगा आपके इंटरेस्ट का केस लास्ट ही है। मैं भी वैसा ही सोच के मैं 8 बजे तक उठने के लिए सोच रहा था। हाँ सही बात है। इसी द प्रॉब्लम इज कि द इंफ्रास्ट्रक्चर इज नॉट देयर। आदमी को होता तो अच्छा रहता। पर नाउ व्हाट आई रियलाइज कि अब हम लोग को वर्कशॉप में 2 साल नहीं आना चाहिए। पर फिर आ जाएंगे जैसे बिग चेंज हमने जो किया था। हाँ हमने भी यही सब कराया था ना। कैडेवर आप आए थे क्या? हमने 18 में कराया है, जानकी राम का भी कराया है, सब कराया है। पर उस समय यूट्यूब का कंसेप्ट कोविड के बाद आया ना, स्ट्रीमिंग का। इट इज फार, फ्लाइट से 2 घंटा। इट इज मिड इंडिया ना। नहीं जबलपुर में फ्लाइट है। हाँ दिल्ली से जबलपुर जाऊंगी। इट इज लाइक अ सेंट्रल पॉइंट ऑफ इंडिया। इंडिया का सेंट्रल पॉइंट इज नियर जबलपुर। तो आई हैव टू कम टू दिल्ली। उतना डिस्टेंस, साउथ जाओ उतना, नॉर्थ जाओ, इवन मुंबई जाना भी उतना ही है। हाँ कमिंग टू दिल्ली, कमिंग टू मुंबई, कमिंग है ना, अजीब सा ही है। कहीं भी जाओ ना 1.5 दिन लग जाता है। अपनी कंट्री अजीब है यार। अब कहीं भी जाओ तो इतना टाइम लगता है। हेलो 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 ओटी।
Hello, T, when are you transmitting the case, please?
Okay, ma'am.
I think we should start, sir.
Sir, Sanjay sir.
Hello. Hello.
Yes, sir. Starting the case.
Yeah, we are starting the case. This is a case of recurrent polyposis.
Okay.
And patient was operated around 9 to 10 years ago at a corporate level hospital. And now again there is a recurrence of the polyps. and chronic rhinosinusitis, and we will starting the case shortly.
Okay, you're showing, you'll be showing the,
On the screen.
okay.
10 बंदे भी होंगे तब भी हम लोग दिखाएंगे कुछ.
सर हम बोले हैं उसके सिटी MRI प्रोजेक्ट करके
Yeah.
बेस्ट होता है कि दो दो ओटीपी चलती है ना, तभी इफेक्टिव यूटिलाइजेशन ऑफ टाइम होता है ना. मतलब यहाँ पे आई थिंक दैट इज ए ड्रॉबैक, दो ओटी नहीं है इनके पास. हाँ, अपन तो इंट्यूबेट कराते वक्त सेकंड इसका स्टार्ट करवा देते हैं. आई नो, ये तो 1 मिनट वेस्ट नहीं करते हैं. हाँ नहीं, आगरा आप आए थे कि नहीं? आगरा आए कि नहीं एक बार भी? इट इज लाइक दैट. सुबह 8 बजे से रात के 12 बजे वो ऑपरेट करते थे, हम लोग सोने जल्दी आते थे, ऐसा होता था. हम लोग लेट होते थे, उनका एक आधा केस हो जाता था. और पचौरी अटैच था इसलिए हम लोग आ रहे थे. करनाल कौन आता बताओ? नहीं, एक्चुअली यहाँ पे ना थोड़ा इंस्ट्रूमेंट प्रॉब्लम, इंफ्रास्ट्रक्चर प्रॉब्लम सब है. कॉलेज लेवल पे क्या होता है, हम लोग के पास टीम रहती है, अपन सबको रिक्रूट कर देते हैं.
डॉक्टर सतीश सर,
तो मोटी में चले गए थे, क्या देखा था तब? हाँ, तुमने हाँ, वो तो लेफ्ट हैंड चलाता है. मतलब he is a confident man. डरते हो? And he is non educated.
हेलो
हेलो हेलो.
वो बोल रही है, आ नहीं रही आवाज. हेलो
Hello, we are able to hear you, sir.
Yes,
We can
madam.
have a brief discussion of this city and then case.
So, last case is ready for the demonstration. And are you getting any imaging?
Image is clear, sir.
So this is basically a revision phase.
Okay.
And see, I'll just quickly take you through to the positive findings. If we go from anterior to posterior, this is the intersinus septal cell.
Right.
This is opening in the right frontal sinus.
And even the lateral recess is also there on the left side. You will call it
Lateral
a cell.
recess you can't say right now. This is the frontal proper. As long as beak is there.
Sir, how about the supraorbital cell then?
Yeah.
If you go back.
So if we, let me go behind where the supraorbital cell is going to come. This is most anterior, this is frontal sinus. Then this is the frontal recess. This is the Aganiji cell.
Okay.
The most anterior one here. And this is the supraorbital recess.
Okay.
Supraorbital recess, see. So Aganiji was not cleared. The intersinus septal cell is okay. Then the ethmoidal septations are still intact. See this?
Yes.
So many ethmoidal septation were not removed during previous surgery. That means it looks like only polypectomy was done. Then we have a slight septal deviation. The antethmoids complete white out, posterior ethmoids complete white out. Maxillary has not very extensive disease, just mucosal edema. And in the sphenoid is the onodi situation on this side.
Can you show the cut with onedi, please?
Yeah, this is onodi.
Okay.
See, let me bring. This is posttracheal cell.
Yes.
Now I'm following it posteriorly. Now see posteriorly. This is.
This cell. Okay.
That's the frontal, the sphenoid sinus proper. The left one is very small. Left sinus is very small as compared to the right one. That's it. So it's a revision phase. Looks like mucosal disease everywhere. Requires a full house phase for future penetration of topical steroids. And all these septations have to go to give a good, cavity where the steroids can reach out. So the fault which may have been leading to this issue, number one, the complete exenteration was not done. See, all septations intact. Looks like only polypectomy was done. See, all septations are intact. So we have to exenterate all these to give a good cavity. Okay?
Okay.
So we can continue discussion. We are starting in couple of minutes now.
Any other cuts or section you have taken? Sagittal or something?
Not really. Actually, I don't know how they all are upside down.
Great.
कितना ब्लेंड कर दिया पटक के।
So no other sections are otherwise. So let's see.
So there is no concept of giving antifungal at any stage of this fungal sinusitis, like the allergic fungal sinusitis.
Hi. कितना council they recommend? जाना है इनके पास एकेडमिक। हम लोग फ्री होते तो हम लोग दूसरा काम करते हैं। We should not do that. मुझे ये बताओ पैरोटिड करने के बाद जो पैरोटिड डिस्चार्ज रहता है कई लोगों का वो कैसे जाएगा? Ready? Okay. जितने अपन करते उससे होता है. And what is the treatment? I'll ask him.
He said, the patient is,
हाँ.
in such cases, yes, it is advised to give
Antifungal.
the agrees. Second thing, suppose if you are thinking of a tenacious,
हाँ.
that case also,
हाँ.
tenacity.
You are in विजयवाड़ा विशाखापट्टनम तो वहाँ यहाँ से कितना डिस्टेंस है दिल्ली टू है डायरेक्ट फ्लाइट है सुबह से 2 केस दिखा है ना अभी तक जेएन में और ये कुछ हो ही नहीं रहा है पता नहीं क्या कर रहे हैं
Sir, we are not getting any view of surgery or anything. Hello, OT?
Hello, yes, ma'am.
We are not getting any view of OT.
बोला जा रहे हैं Yes. Meet you somewhere. दीक्षा हम लोग को बोले कॉफी आप लोगे ना रामनानी क्या लोगे आप कॉफी लोगे चाय लोगे कॉफी लोगे ना उसको बोल दे कॉफी पी लो ज्यादा से नहीं जो बैठे वो बोल देगा तीन कॉफी तुम कॉफी करो ले लो लो, क्या करना टाइम पास के लिए कॉफी खाओ
के लिए जो वेट करे तुम कितना करने को
अच्छा करना अरे उनको बेचारे को बताती नहीं होती, उनको दोबारा बुला लो ना हाँ। बच्चों को भेज देना घर चले गए बहुत अच्छा
सब जबलपुर टीम रहेगी
भगवान वो तो बदनाम हो जाएंगे अपन भी घर जाके वीडियोस ऑनलाइन देख लो
कल कर यानी करने
Hello.
अगर आप अभी निकल जाते तो
बात है
Hello, madam.
Yes, sir.
So we are ready with the case and we are decongesting the nose.
Right.
And are you getting the picture?
Yes, we are getting the picture,
This is
voice
the
transmission is
external camera.
okay.
Shortly we will be with the endoscopic camera.
The green tube is endotracheal tube or it is appearing?
No, it is, I think it is a suction tube.
Okay, this is special type of thing you are using.
No, it's Satish choice.
Okay.
This is rubber tubing basically.
Right.
Sorry, this, hello?
Yes.
This is the cable, the light cable. I was not in the OT, I was seeing the picture only.
So that is a cord.
This is the
Fiber
light
optic cable.
Fiber optic cable.
Addition is there, Sainikya.
Hello.
Hello, yes, sir.
Yeah, madam, are you getting any
Endovision.
Yeah, we are getting the endoscopic
picture?
view,
Yes, sir.
endoscopic view, voice is also clear. So management plan क्या है sir आपका इसमें?
The same. First of all, full house first,
Okay.
then steroid dosing, and work up for any comorbidity, and if it is management of that. This patient has a high deviation. If you look at the opposite side, I had shown you earlier.
So since this patient is having recurrent polyposis, would you like to give her itraconazole or something
No,
like that?
no, that is not indication for recurrent. Recurrent is because
Inadequate surgery.
yeah, inadequate surgery, follow-up, overall management. Failure has many regions. It's not that. See the synechia on the opposite side. See this?
Yes, sir.
And see the high deviation, which I'm surely going to correct. See, surgery, a proper surgery is the beginning to the good outcome. That is not everything. Don't try to compare it like any other mechanical surgery. This is to reduce the inflammatory load and allow the steroids topical treatment to penetrate deep. That's it. It doesn't mean that a FES is going to cure everything. It can happen in certain situations like an odontogenic sinusitis where it can give a cure. See the initial topical application?
Yes, sir.
Lot of things we have already discussed. The revision are always challenging. Always, lot to learn in revisions. It is incomplete. Mass stabilization. Looks like the remnant of the uncinate. This now complete. That is the level of the lamina. See the axilla. Hello.
Yes, sir.
You can interrupt me anything, but since we have discussed lot many things earlier, so I am not repeating everything. But feel free to ask me anytime. See, that's the axilla.
Okay.
And I am removing all these cells. See the lamina.
Yes.
That is my principal landmark now. See the lamina?
Yes, yes.
See the middle tabulate and lamina together?
Yes.
Hello?
Yes, sir, it's visible now.
And this is the level of the axilla. We have already seen. Now, cobbleter. Suction.
Bye.
Anil, connect kar. Connect.
So what are you doing with coblation, sir?
Pardon?
Reducing the coblation, what is the indication of using coblation over here?
Yeah, it's somewhere, some oozing, spoiling your feet.
Just, okay, just for hemostasis.
That is much better alternative to coagulation. So we have completed the middle meatal enterostomy, you can see.
Yes.
I remove the upper part of the uncinate,
Right.
expose the, lamina papricia. We have seen the lamina, we have seen our medial and lateral limits. See that?
Yes, sir.
And now quickly we'll change to 70 and finish out the frontal sinus work. See this cavity?
Yes.
120. So now switching over to 70 degree. See this?
You had an upturn
Nice.
suction or irrigation for this.
Pardon?
So you are using a special instrument for this suction or upturn suction or something like that?
Yeah, in between. Now see where your beak is.
Yes.
In between your lateral and medial limit.
Beak is there.
See where the beak is ending.
Yes. So पहले focus होता था back to front. Now it is totally from front to back, the surgery.
See the frontal sinus.
Beautifully seen, fast.
The best part is, this is the short way of defining the frontal.
Okay.
See this?
Yes. Very clear and within seconds you are reaching there.
Yes, that is the beauty of this technique. Reverse. So define the beak and reach out the frontal. So simple. I think nobody has doubts about it. Suction नहीं लगाएगा? You can apply in your practice and simplify the frontal sinus work. See this?
Yes.
Without any hassles, you can easily reach out the frontal. Reverse. See I mentioned already during CT, the septations were not completely removed, so the complete job was not done. See this everywhere, the reasons for failure you can see yourself.
Yes.
See, I am using my skull base blade towards me. See, flush the posterior table,
Yes.
and that is the level of the entrance-modal artery. See there,
Yes.
that is the level of the entrance-modal artery. Give me a pack. So in no time you can, work on the entrance-modal skull base. No time. Without any hassles, you can reach the entrance-modal skull base in no time. See the beak.
Yes, sir.
See, this relationship is something never changes. Axilla, see the axilla?
Yes, sir.
Underneath the beak, where the beak ends in the frontal.
Sir, always there is discussion, इतना shrink होता है, ये होता है, तो will this shrink?
Pardon?
Will this opening shrink with time?
No.
No.
You have to follow with the medical treatment.
Okay.
Irrigation.
So always they tell the 25% shrinkage will be there of the opening.
No, nothing will happen. Having done the entrance model roof work, now I am back with a 0 degree. First, finish of the post-it model and the sphenoidal work. See this?
Yes.
छोटा दे देख मेरे से छोटा दे दे ला वो दे मेरे को सुनो cobblator दे a little bit coblation.
So working with 70 degrees, sir.
हटा ले no, not 70 now, it's 0 only now.
Okay. Okay.
Hello?
Yes, sir. 0 degrees, sir.
No more 70 degree now. See the entrance model skull base complete.
Yes.
See the cobblator is helpful in little bit of the,
Hemostasis achievement.
bleeding, mucosal tear, all those which can hamper your field. Now 0 degree. Now see the polyps medial to it.
Posterior model.
पानी डालना है यार. See the polyp, it was from the terminate only.
Yes,
See this?
yeah.
Yeah. Now to enter into the post-ethmoid. See this?
Yes, fast entry.
This is your middle turbinate, superior turbinate.
Superior turbinate.
See the level of the sphenoid sinus.
Yes,
See, take the reference of
septum.
maxillary line
Okay,
and glide along the septum. See now everything, this is the post-ethmoidal roof.
yes. Actually prepared.
Sphenoid little bit I widened here. Rest I can widen later. See, this is the sphenoid only.
Sir, even these patients didn't have received the pre-op steroids also, I think.
Yeah, all these patients should find out.
Should receive.
See, this side first I am going to finish off in next 3 minutes.
Seconds.
See the post-ethmoidal roof.
Yes.
Now lastly, I am flushing the post-ethmoids.
You were telling ONED is also there.
Pardon?
ONED भी दिखा था शायद इसमें स्कैन में सर. ONED cell.
Yeah. This is only.
Okay.
Now, once we take this medial route,
Yes.
doesn't matter whether it is onodi or not.
Okay.
But we are
ठीक है.
already
Externalizing
the
it.
safer side. बंद हो गया. See the cavity?
Yes.
Partially blocked, eh? See the skull base?
Yes.
See the skull base all the way?
Yeah, yes.
Superior turbinate, remnant, septum, middle turbinate, see the cavity?
Yes.
The entire ethmoidal roof and the sphenoid reasonable.
This is the polypoidal tissue seen laterally.
Pardon?
There is polypoidal tissue still present there. This
Where?
one. Between the two laterally.
No, not really.
No?
See this pretty clear.
Okay, right.
That's the final picture.
Done.
See that?
Yes.
This side done.
So the case is done.
Yeah, this side done. See the cavity this side.
सर इसमें भी आप बर्न कर सकते द सेंसरी नर्व्स.
Pardon?
सर जो आपने बोला था सेंसरी सप्लाई द फॉर एलर्जिक राइनाइटिस यू कैन डू कॉब्लेशन यू कैन डू दैट इन दिस केस.
Yes, you can do easily. You have to work in this region. See this?
Yes.
See this region?
Yes.
Or later. You can do in no time. See this between the middle and inferior turbinate.
So we can do this for allergic rhinitis also without doing anything else if we do
No.
coblation.
This is the additional adjuvant,
Adjuvant.
to reduce
But
the
if patient
mucosal.
is See, sir, some patients
to-
are having
to
allergic
reduce the
rhinitis
response
only.
of mucosal glands.
But some patients have only allergic symptoms and they don't have polyps. So should we do that? That case?
Allergic symptoms but don't have?
Allergic rhinitis, sir, sneezing and all, but they don't have polyposis.
So you don't need to do that. Once this is an adjuvant procedure in those
polyposis.
Yeah, and having allergy.
Okay.
See, this side face is done for me.
Yes.
And see the panoramic view. Okay.
Yes.
Okay.
Sir. Yes.
See this.
Yes.
See the perfect cavity.
Yes, sir.
See, in the same manner, we have achieved this. Using the same landmarks like a primary case. See this?
Yes, sir.
How's the cavity now?
Perfect.
Now, the chota pet. See, opposite side has high deviation there. Knife दे देना. See this high deviation? Hello?
Yes, sir.
Look at the high deviation on the opposite side.
Yes.
See this one?
Yes, yes.
So we'll do something to it. See this? Hello?
Hello, sir. Yes, sir. No problem.
Suction कर.
सिंगल शॉट हो रहा है. क्या? You suture it or you just keep it and then it will heal?
Pardon?
So you'll suture the incision line or you'll just keep it and let it heal?
Yeah, we'll put a small suture.
Okay.
That's a limited correction.
So if we do correction, then it is better chance for healing with
See,
ventilation.
there are
will
many
improve.
ways to do the same thing.
Yes.
There are so many ways to do the same thing. हटा दे. Leave it. We'll put a small suture. See that?
Yes, beautiful.
Now see my high deviation.
Yes, sir.
Good space now?
Yes. Perfect.
Earlier there was hardly any space. Now full. Maxillary sinus is widened. Find out. What is it? See this?
Yes.
Some mucosal edema, polypoidal mucosa. See, incomplete removal of the uncinate. See this? Backbiting. Incomplete removal of the uncinate. Do you see?
Yes,
Hello?
sir. Yes, sir. We are seeing, watching.
That is lamina.
Yes, sir.
This is the axilla, which I am opening up now. See the lateral and medial limits.
Yes. We are appreciating that detail, sir. Working in this boundary.
Can you see both lateral and medial limits?
Yeah, yeah. Very nicely seen. You have defined lateral limit, and that is making the job easy.
Right. 170 degree. Next 5 to 10 minutes, we'll be through with this side as well.
Sir, what latest you are doing? You keep on adding your knowledge. So what was the latest you have added?
The skull base is unlimited field, madam.
Okay, skull base you are exploring more.
Unlimited. Some goodness. Highly unexplored field.
Yes.
Lack of coordination between the neuro and the ENTs.
Plus,
Hardly any evidence-based science existing.
I'll tell you, sir.
Patient reaching to the neurosurgeon, they will operate. Reaching to the ENT, they will operate.
And sometimes the patient
It
goes
requires
about
a
without
consensus.
diagnosis.
Reaches to the physician or someone else who doesn't know will radiate anything. So that science is still,
No man's land.
difficult to improve. Follow this beak. See this axilla?
Yes, follow
Can you
the
see
beak.
the beak there?
Yes. What I see.
Underneath the axilla is the beak. Can you see beak?
Yes.
And underneath the beak?
So you are using only debrider for this now, no other instrumental or something. The debrider is good enough.
Ultimate tool here.
Okay.
See, I am in the frontal in no time.
So special, what type of debrider is this one? Rat 60 आप क्या use कर रहे हैं इसमें? What is the debrider specification in this for frontal?
The same debrider. What other specification?
Okay.
See the frontal?
Yes, nicely seen.
A little bit of the enterothmoid, postethmoid and the sphenoid work. We have already opened lots of cells. See your frontal. See this?
Yes, sir.
Without any doubts. Reverse. See, defining the skull base.
Yes.
That is the anterior model artery. See that?
Yes, yes.
Behind.
Yes, sir.
See the frontal?
Gradual gradient बहुत अच्छा expose हुआ है. The posterior mud.
0 degree. And finally, little bit of the posterior and the sphenoidal work. Bilateral. Bilateral done. Few minutes, 2-3 minutes. See, behind the anterior artery is the posterior roof region.
Yes.
See that?
Yes, sir. Good.
See the posterior roof region,
Wonderful.
just to show you.
Yes. So there was addition between the two.
No, that is the superior turbinate behind.
Okay.
That is the septum there.
Right.
See that?
Yes.
That is our maxillary line.
Okay.
That is our sphenoid.
Yes.
Now we'll take away everything. And we are through.
Good work, sir. बहुत मजा आया आज का केस देख के. This last was a special case.
Fast endoscopic
Thank you
sinus
so
surgery.
much.
Yes.
Thank you. It was
Am I
good
right?
to watch you. Ji, sir.
This was fast endoscopic sinus surgery.
This was
Yes.
your way of doing it.
Yes.
Yes. If we learn this also basically, then this is good. At least the recurrence should not happen. Sir, I have one VIP patient, father of my student, parotid किया, उनका fistula धीरे धीरे खुद खाने के समय आता है. What should I do for that?
Pressure reduction. You can inject PRP in the base.
At the fistula?
Yes.
PRP.
Yes.
Okay. And do dressing.
Yes. Pressure dressing.
Or any other medicine which I can try.
No, no. Later.
And will it heal or I need to suture it?
Pressure dressing.
Pressure dressing. Like, thank you, sir. आप जबलपुर कब आ रहे हैं सर? इस बार घूमने के लिए आ रहे हैं कि फिर डिस्कशन करने आएंगे?
Yes, madam. Always.
I know you will come for discussion, but when are you coming for with family? हम लोग के जबलपुर के पास कान्हा किसली वगैरह है. I think you should have some break also.
See the sphenoid?
Yes, sir.
Have the sphenoid.
Beautiful,
sinus,
beautiful.
posterior model cavity.
Very nice.
The
Perfect.
skull base, right anterior model artery.
Beautiful.
That's the maxillary sinus, that's the sphenoid and rest of the sinuses. And that completes, we have already done a
Wonderful.
corrected the high septal deviation.
Ji sir.
And see this, see the cavity.
Beautiful.
Thank you all once again for your attention, and big thanks to Dr. Sanjay Khanna and Rajiv Pachori sir for giving this opportunity, organizing such extensive courses. Thank you once again.
I really appreciate Dr. Sanjay Khanna, Dr. Ashok, Dr. Pachori and you for organizing. It's a very tedious job, like serving, preparing and serving to the audience who wants to learn. Great job, sir. Thank you.
वो क्या वेबिनार करते रहता है हम टाइम, क्या होता है हर संडे को बैठ के देखता है तो कुछ ना कुछ।
ಏನಪ್ಪ ವೆಹಿಕಲ್ ಕೃಷ್ಣ? ಕೇಳಮ್ಮ. ಇತ್ತು ಅಲೆಗ್ರಾ ನೆಗಡಿ ಇದ್ರೆ ಅಲೆಗ್ರಾ ತಗೋ, ಗಂಟ್ಲು ಇದ್ರೆ ಸೂಪ ತಗೋ. ಬೆಟರ್ ಮತ್ಯಾರಪ್ಪ ತಗೋದು ಇಮಿಡಿಯೇಟ್ ಆಗಿ ತಗೋ. ಏನ್ ಇವಾಗ ಮತ್ತೆ ನಾಳೆಯಿಂದ ನೆಗಡಿ ಕಂಟಿನ್ಯೂ ಆದ್ರೆ ತಗೋಬಹುದು. ಅಲೆಗ್ರಾ ವಿಲ್ ವರ್ಕ್ ಫಾರ್ 24 hours, 1 ಟ್ಯಾಬ್ಲೆಟ್ ತಗೊಂಡ್ರೆ ಸಾಕು. ಮತ್ತೆ ನಾಳೆ ಇದೇ